Do we have a first MPT Pro just to show? Yeah. Obviously. So that whenever that background.
Yeah. Yeah, man. Huh? Very nice. Hold on, brother.
No. You can start from beginnings. I think projection also projection is being please share. They have been the start, but PPT doesn't do anything. Last PPT part. Yes.
Thank you for the waiting. I welcome you all for the second time. Pharmacology is not just a study of the medicine, it is the science of unlocking mystery of disease, enhancing human life and advancing the boundaries of medical knowledge. As we gather today, let us explore, innovate, and inspire the future by education. I am Dr. Arun Surya, Senior Lecturer, Pharmacology, Medical College. And I am delighted to have Dr. Abhinaya, Senior Resident, Department of Pharmacology Research. And I invite you all for the scientific test MPSCON2024 conference in association with Savita Medical Department of Pharmacology. Tell me briefly about this conference. It's an international conference. The theme which we are going to discuss today is the innovation of pharmacology, using research, and method is all the things of pharmacology. With this, I like to invite you all for the first session. For that, I like to invite the chairperson. To invite the chairperson for the first session, Dr. Dubi, additional professor, pharmacology, associate dean, former dean, before time. And also, I like to invite the co-chairperson, Dr. Madhav Rao. I will hand over the session to the chair and co-chairperson. They will begin to take care of the session. Thank you, sir. That's what the session I'm gonna. Yeah, ready. Yeah. Well, like that. Come on, listen. Yeah, put the information. Right. This camera is on, huh? Yes. Hello. Everyone, welcome to this MPSCON conference. So let's start the session. with the first session. I would like to invite the first speaker of the first session, Dr. Sonali Kirde. Dr. Sonali Kirde, madam, she is a MBBS graduate from Government Medical College, Nagpur, and MD Pharmacology from MGMS Sevagram, Varda. Recently, she has started the entrepreneurship journey as a strategic investor and consultant at healthcare startup and incubators. And she is also an official startup mentor at Mark by Government of India, Startup India. She is also featured industry ambassador in Singapore, holding the various responsibilities as regional director in NGO, working on network. And Madam is also a and career guide to medical professionals, recognized speaker at the various conferences. With this brief introduction, I would like to invite the Dr. Sonali today to start this session.
Hi everyone, am I audible? Hello. Hello everyone.
Able to speak.
I'm not able to switch on my camera.
Madam's not able to switch on her camera. It's active on. She can join as a participant. No, better. Yeah, you are audible. Hello.
Yeah.
Ours
Okay.
is muted or what? No.
I
Can you hear me? Can
Yeah,
you
I
hear
can.
me?
Yes, you're audible, sir.
Yeah, I think you are audible. Okay.
Ma'am, you can try sharing your screen. There will be a camera icon, ma'am. You can click on that.
I'm getting an alert that you cannot start your video because the host has stopped it. So maybe if you can give
I
me the
think
right,
can you just check that something multiple? You can make it multiple. Then we can do it later. Now you try. Now you try.
No, sir, not able to. Still not showing.
Now can you try?
No.
Can you try switching on your camera?
No, sir, it's not opening at all.
Okay, but it's okay. Can we go ahead? Oh, okay. I think now can we go ahead with your presentation?
I'm trying to share my screen.
Yeah. Just the video now. This is YouTube. YouTube is switch off. Video.
YouTube screen you want to start?
Yeah, no, not that one. That window you close.
Okay.
That window is on.
No, sir.
So it's showing I cannot share my screen also
No, don't
while
show.
the other participant is sharing. I think you'll have to stop sharing, then only I'll be able to share my screen at least.
Yeah, so stop this yet.
I hope it's visible to all of you.
Just this YouTube. So can we project your slides?
So I have already projected it. Can you please confirm?
There is. Here, yes, we have. Yeah, we can see.
Okay, all right.
Yeah, ma'am. Go ahead, ma'am. We can see yours.
Sure. So thank you so much for very good morning to one and all. Thank you so much for having me here. Unfortunately, the camera is not functioning, but nevertheless, we will try.
It's faster to start. Wait, no?
Ma'am, can you wait for a minute? We are working on the audio, ma'am.
All right, all right.
Thank
Can I
you.
control that?
No?
Yeah, excuse me.
Yeah, 1 second, 1 second.
No, no what? Sound, sound is
Ma'am,
not.
ma'am, stop.
Hello.
Hello,
Yes.
Sonali, Dr. Sonali,
Yes, sir.
just the sound output, who is in charge of it, please? Can make a crucial role.
The speaker level did not change. Kill him.
How are you? It's a
Uh,
pleasure.
Dr. Shiva, sir, if you can make me as a co-host,
yeah,
I think I will be able to share my screen and switch on my camera.
Okay. What's the speaker? It's possible. வெளியே
Why? Please make her co-host. Really liking.
Video better,
Video. Video கிடையாது only இந்த மட்டும் நெட்ல பிரச்சனை மைக் வச்சு இல்ல வைக்கலாம் இல்ல வரும் இதுல இதுல போதும் ஆம்பிளிஃபையர் நேத்தி வந்துச்சுங்க இப்படிங்க வராம நேற்று எல்லாம் கரெக்டா இருந்தது நேற்றுக்கெல்லாம் ப்ரோ எல்லாம் பக்காவா செட் பண்ணி வாங்கிட்டு Hello, ma'am. Hello.
Dr.
Hello.
Sonali?
Hello. Hi. Am I audible?
Yes, you can go ahead.
Okay. So I'll
Yeah.
go without camera only because I'm not able to share the camera.
Yeah.
Let
Slides.
me share my screen.
Slides.
Can you please confirm if my slides are visible?
Yes, yes. Slides are visible.
Okay, and shall I go ahead?
Yes, go ahead, please.
All right. So thank you so much. A very good morning to one and all. Thank you so much for having me here. A special thanks to Dr. Shivamurthy sir for taking this initiative and for Savita Medical College for organizing this fantastic conference. Now we are at international level, and I request each one of you to, especially the medical students, the MD Pharma students, to pay attention to all the sessions and also build your networking. It's a great platform. You will get to learn a lot from the stalwarts from Pharmacology Society, and I wish you all the best luck. So today I have been given the topic which I'm very personally very passionate about, and I have been doing this mentoring and coaching of MD Pharma students across India since 6 years now. So today I'm going to talk about how to succeed in Indian pharma and clinical research sector as a medical pharmacologist. May I request to go on mute, please? So on my screen, on your screen, you can see the flow of presentation. I'm going to take you through my personal journey, my career journey from doctor to doctrinaire. I will also help you understand what are the various facets of MD pharmacology as a subject once you pass your MD. I will also take you through the essence of pharmaceutical industry in general, because this was a question which I used to think a lot when I started my residency in my college as MD Pharma. This was a question that I always used to think about: what are the prospects, what whether I'm the right fit for the industry or not, what are the skill set that I should develop at a personal and the professional level, and how I can excel in the pharma industry as a pharma professional. I will also take you through medical affairs in India, how it functions, the roles and responsibilities. Coming from a medical affairs background, I will be able to give you a bird's eye view on this, and some tips and tricks and some notes of inspiration, if at all I will be able to inspire you all. And of course, we'll end it with the future scopes and opportunities and the concluding the session. So in the end, it's just a beginning. So it's a great beginning, and it's a great subject. We all should be extremely proud about it, and there is a lots of scope if you talk about MD pharmacology as a specialty. Now let me talk about myself. I am from Orange City of India, Nagpur. I have completed my MBBS from GMC Nagpur, which laid the foundation, the basic foundation of my scientific expertise or medical expertise in during my college days. From there, I have decided to start, the rural service, and as a bond, as a compulsory mandatory bond, I did my rural bond of 1 year. I got involved into this rural service so much that I decided to extend it for another year. And there I used to do a lot of things, right from management of OPDs, MLCs, emergencies, handling patients, and also administrative activities. I was also in charge medical officer. And there were a lot other things that we used to do, like delivering lectures, creating awareness about health conditions on various days, and celebrating ASHA and Anganwadi Sevikas and sickle cell workers, working very closely with them and understanding the ground reality of healthcare industry in India. Now, with this, why I'm trailing this in details is because these particular 2 years helped me in knowing me as a person, also helped me in making a better version of myself, because I have seen the grassroots level. I have seen how our medical industry functions at the grassroots level at the rural sector, and that was something which I was very passionate about. I wanted to continue, but as they say that if you want to make a bigger impact, you have to have some credentials or credibility, or if you want to make a higher impact, you have to go through some processes or some kind of journey, then only will be understand what better impact you can do, and you can come back to root. And this is which is it is related to my recent my recent career switch, where I've started now as an entrepreneur. After completing my 2 years in rural service, I opted for MD Pharmacology, because pharmacology opens a gateway for all the subject. It's a subject which will lead you to have multiple scopes. And coming from a background with no, no medical background support, or I wanted to start from zero. And for that, I thought this is the best platform and the best specialization, wherein you will be able to have a good span of career aspects or options, right from your academics or clinical research or a pharmaceutical industry, and also start your own thing. So I completed my MD Pharmacology from Mahatma Gandhi Institute of Medical Sciences, Sevagram. During this 3 years of residentship, I also became the founding president of Resident Doctor Association. And I was also introduced to Medical Pharmacologists Society, MPS, and to Dr. Shivamurthy by one of my friends. And I would say this 3 years, I have developed leadership skills. I could network with people. I have attended lots of conferences, workshops across India. It really helped me to develop me as an individual, and the skill sets that are required, like communication skills, negotiation skills, decision making skills, and also various skills which are required, soft skills which are required for a better pharma professional once you start your industry career. So from there, I started my pharmaceutical journey with Merck Sharp and Dohme. I started as regional medical advisor, or MSL. I was handling diabetes portfolio for the western part of country. I was here for 1.5 years, and from there I moved to GSK. I'm sorry, may I request all of you to please go on mute? Thank you. So from MSD, I moved to GSK. I completed my 2 years of tenure in GSK. I handled dermatology and anti-infective portfolio, wherein I was a part of.
Sonali, Dr.
Yes.
Sonali, your slides are not moving. So can you stop sharing?
Okay.
Okay, just please follow some instructions. Now it is working. Yeah, you just don't make the presentation mode. Just do this way only, so that people will be able to see. Okay, is that fine?
Is it visible now?
Yeah, now it is visible.
Oh, okay. Thank you so much, sir.
Yeah,
Sure,
thank
sure.
you.
Thanks. So in GSK, for 2 years, I was a part of clinical trial as a medical monitor, and I got a lot of other opportunities, which, as a pharma professional, always everybody aspire to be. Then I moved from GSK to Takeda. I was handling the immunology, rare disease, and gastroenterology portfolio as medical advisor, which was office-based role. Both GSK and Takeda were office-based role. And now, after gathering this experience for roughly 6 years in across industry, I have decided to start my own. I wanted to start my own company, and I'm now working as a strategic investor and consultant at health tech startups. And there are many things more which will be coming very soon, and you will get to know about it on my LinkedIn page. So, dear friends, the MD Pharmacology as a subject has multiple facets, and all these facets are interconnected. It's a degree which opens multiple doors for you. If you want to start your career as an academician, it's a fantastic, specialization. The next is the research, the clinical research. If you are very much into clinical research and wants to read a lot and want to do something really great in the clinical research and medical research, this is really a great specialization. You can always have your career in that, and you can flourish as a researcher and as a scientist in from the pharmacology specialization. The next is pharmaceutical industry. Pharmaceutical industry in itself is an ocean. There are plenty of opportunities and options that are available for pharmacologists, and of course you can always have your own company, and you can always start your own business as an entrepreneur. So in general, let us have a look at what is pharmaceutical industry in India looks like, and how it is for a MD pharmacology student. So once you complete your MD Pharma, you will be aspiring to become pharmaceutical professional. So there are multiple options depending on your choices, your aspirations, your interest, and your preferences. You can choose your options. So I would like to start with medical writing. So medical writing is a very specialized kind of career, wherein if you are very good in writing, very good in writing in terms of scientific writing, if you are very good in manuscript development, and also if added to this, if you are a good biostatistician, this is really a great platform. You can work, you can start your own medical writing agency. You can also join some multinational company as a medical writer. You can also join some startups and be a good medical writer. Also, you can work as a freelancer. So medical writing as a career gives multiple opportunities. Also, it gives you a good work life balance. And if you are very passionate about writing, I think this is the go to sector for you. The next is pharmacovigilance. Pharmacovigilance, we all know, we have been doing this during our residency as well. This is a very good specialization, I would say, in the pharma industry. They work on safety reporting, they work on signal assessments and audits, and they play a very vital role across the industry. And now with new norms, all the pharmaceutical industry will have to have one pharmacovigilance department special. And the scope is huge. The jobs are very good. It gives a good work life balance, and it's a desktop job, and there is no traveling involved. And as per your preferences and your interests, you can definitely offer of PV as your aspiration. The next is clinical research. Clinical research, as I was mentioning, it is for those people who are very passionate about clinical trials or developing newer drugs, having newer and newer portfolios in the medical field, and who are very good in planning and executing clinical trials, and super passionate about writing protocols and designing a clinical trial, and also getting into the regulatory approval. So if you are in of that mindset, clinical research is definitely for you, because MD Pharmacology is a degree which opens a straight gate for clinical research, and you can be an independent researcher. You can join some organization, and also you can join some MNCs as well. Moving to next is medical affairs. Medical affairs, the background with which I come here. So, medical affairs is a bridge, or you can say a very vital or very one of the important pillars of pharmaceutical industry. Medical affairs, they develop strategy. They also liaison between the internal and the external stakeholders. Medical affairs is a specialization, or is a domain which will create a bridge between the various stakeholders internally. Also, you work very closely with regulatory affairs, you work very closely with marketing team, with your sales team, with your legal and compliance team, with your other stakeholders internally. And externally, of course, you are the face of company. You are the peer to doctors who are practicing, and also you are the subject matter expert for all the doctors who are practicing and who want to know more about the drug or the product which you are handling. So medical affairs, they work very closely with marketing team, and they build a medical strategy, and they have a huge contribution in the, not only in the making the company you can say scientifically very balanced, but also have a great contribution in the revenue generation indirectly. So let me take you through 50,000 feet view about the medical affairs in India. We'll talk about first about the field-based roles. Now, field-based roles, these are the entry-level roles, or you can say the face of company. These are executionary roles. I would request all the MD Pharma students who are aspiring to become a pharma professional in pharma industry, please start your career with entry-based role, that is field-based role, because these are very very important. This actually helps you in understanding what's happening in the market, what is the the belief of doctors, the mindset, and also takes also basically develops you as a professional, because this will be like the first time you will be actually applying all the theoretical knowledge that you have gained through 3 years of your residency. So I call it as a internship post MBBS, because you actually hands-on, it actually provides the hands-on learning, and also it involves a lot of soft skill development, which definitely happens for a couple of years or for 1 year. So at least for 1 years or 2 years max, please start your career with field-based role. In your long career journey, I think definitely this much time you can give. Even if you are getting office-based role, I will request, if you are getting field-based role in MNCs, that will really change your perspective, and it will make you a better professional in future. So it lays the foundation of medical affairs as a person, and also it's a stepping stone for all the roles and all the leadership roles that you are going to handle in future. The next is the office based role. Once you complete your 1.5 or 2 years of MSL role or a field based role, you move to offices, which are the headquarters of multinational companies. So most of these headquarters where medical affairs function is there, they are based out of Mumbai, Delhi, Bangalore, and Hyderabad. And out of that, Mumbai is the hub of medical affairs, where I would say 80% of companies, they are sitting in Mumbai. So if you are aspiring to become medical affairs professional, the humble request will be to keep your mind and options open, because if you want to climb up the ladder, ultimately or unfortunately, because it's not decentralized, unfortunately you will have to shift to Mumbai. And of course, there are other options in Delhi, Bangalore, and Hyderabad also. We have companies in Bangalore. We have AstraZeneca. In Hyderabad, we have Novartis. We have Dr. Reddy's. In Delhi, we have Lilly, and we have Takeda also as an headquarter. But yes, majority of other companies, they are based out of Mumbai. So this office-based role, once you sit in the headquarter of India, in whatever location the office is based, you will be exposed to have a good stakeholder management. You have to come out as a good team player, a good team leader, and also it will give you a platform to apply your strategies. So the strategic mindset will be developed once you start your career as an office based person, and it gives a high visibility to you also, because now you will be in direct contact with your senior leadership team, and you will be having better visibility of how the function is functioning, and also how the molecule is actually taking shape in market, and overall the general perspectives or the prospects of the therapy area that you are handling. So it involves a deep understanding of the therapy areas, whichever products you are handling or the therapy areas you are handling. And also it gives you a development of your business acumen or the market economics that is required, at least to some degree. Not like marketeers who are pure marketeers, but at least some kind of business acumen will be expected from you, because you work very closely with marketing team as well. Of course, it opens global opportunities, and global exposure is high once you sit in the office, and that's why the next move after field based should always be an office based role. Now if you can look into the pyramid, which is on the right side of your screen, it starts with entry based role or the entry level role, that is field based. In some companies the designation is regional medical advisor or RMA. In some companies it is MSL, and in some companies it is also called as ZMS, that is zonal medical advisors. From there you move to HO based role or headquarter or head office based role. The designations are different, like medical advisors or senior medical advisors or therapy area lead or head medical affairs also. Then comes a very very important part of the medical affairs, that is senior leadership team. Now these are the top notch bosses or the top notch people who actually understands, who actually have a broader perspective about the function, and who are the decision makers, and they are the representative from India for the global market as well. So this is how the medical affairs bird's view in India. Now let us talk about the roles and responsibility. Now this is the question that most of you always will have, and whenever I mentor students and MD Pharma students, these are the things that they generally ask to me. What are the roles and responsibilities in general? So I would like to highlight only few things, and there could be some other things also. apart from what is you can see on the screen. Number one is the scientific expertise. Yes, you are a doctor and you will be meeting a doctor who is practicing outside your company, so definitely the highest expectation from you and the minimum expectation from you is to have a good scientific expertise, the hold on the product, the hold on the therapy area. So of course you have to be the subject matter expert for both the internal as well as the external stakeholders, because if you have a good scientific expertise and the subject matter expertise on your product, you'll be able to navigate various activities. You'll be able to understand what are the communications that need to be sent outside the company. You will be able to strategize and help your strategists who are the marketeers to develop a proper strategy from the business perspective, and also keeping the scientific scientific support and evidence based communication only. So there comes your first responsibility or the basic minimum required from you as a scientific expertise. The second is the strategy. What I was discussing with you, the strategy, applying now this theoretical knowledge or the medical knowledge you have gained for last 3 years, or when you read about the product which you are handling. Now applying this medical knowledge to identify therapy need gaps. Now every therapy they have need gaps. So you have to identify those need gaps and also have to provide the science driven solution to your counterparts. And there comes if you are very good as a strategist, you will be like a blessing to any company. So a combination of scientific expertise and a strategist together is kind of the golden person, or the person who will everybody would like to sort for. So please become that. Then next is guardian of compliance. As we all have taken oath, it continues till we take our last breath. So of course, for any communication which is going out or any marketing output which is required for the promotional material or the non-promotional material, each and everything has to be highly compliant and scientific driven only. So we have to check the points to ensure that the function is functioning in a very compliant manner and no communication is going outside the company without proper check by a medical affairs person. So you are the guardian of compliance as well. Next comes the communication design. Yes, the designing and the inputs and all the approvals has to be given by a medical affairs person. And it could be as it could be therapy slide decks, or it could be manuscripts, or even the small scripts which are required to create the awareness about the therapy outside for the HCPs or healthcare professionals. Now coming to next role, research and clinical development. You also work very closely with your CD team, the clinical development team. If you are a part of clinical trial, if you are in an innovators company, if you are handling a product which is innovative and which is undergoing some clinical trial, definitely you will be involved. You will automatically get involved into the CD. You will be either absorbed as a medical monitor, or you will be closely handling the things and become a part of clinical trial. So right from developing protocols, clinical research papers, or also clinical operations is you work very closely with them, and also sometimes third party management is also there. Now coming to next, the new product ideations. During our residency, we always talk about the recent advances. So this is a chance that you will actually get opportunity to identify newer and newer products, to evaluate them, to have a good strategy and provide the inputs whether this product should be launched. If it is, it has to be launched in what in for what indications and for what is the best product fit, and all these things will be done by medical affairs team, in of course in collaboration with your NPI team, that is new product ideation team. Now comes the next role also, medical safety. Yes, you also work closely with PV department on the collaboration on PSURs or adverse events or signals with the PV team. So yes, you work very closely with all these stakeholders. And the last is regulatory affairs. So there is a dedicated regulatory affairs domain or department in pharma company, and you ensure all the communications to be compliant with PI as the prescribing information, and also you collaborate with regulatory teams for DCJ approvals and other further communications related to regulatory affairs. So if I can say, you work in various dimensions. You have to be multifaceted, you have to be multitasker. Your day is gonna be super exciting and super full of various tasks and challenges. But during the process, you learn a lot. You learn from people, you learn from processes, you learn from places. So apart from that, the training of sales team is also one of the important responsibility in some companies. So whatever trainings or coaching you give to your medical students or MBBS students, your teaching skills, your delivering the lectures, and all those skill set is going to be used when you actually train your sales team. The executionary, the most important pillar of pharma industry is sales team, and you have to be their trainer in some companies. So these are various roles a medical affairs professional can and have to play while being in medical affairs department. Now, are you wondering if you can do it? So, trust me, friends, if you can dream it, you can definitely do it, as rightly said by Walt Disney. So, be passionate, be compassionate, keep your work, keep your networks open, be visible, attend all the conferences and congresses, and I would say stay in touch with seniors. They are fantastic gurus. They give you all the tips and tricks. I'm using this, and I will do this for my life. So there is no wonder that you can't, there is no surprise that you can't do it. If you can dream it, you will definitely able to do it. Now, while thinking about pharma industry as a career, one thing I would like to highlight here: keep your goals grounded in reality. Now, most of the MD students, they ask me that my college is situated in a remote area, or maybe in a town or a tier 2 or tier 3 city, and I am not exposed to any pharmaceutical industry workshops or internships, or I don't have any senior also who is working in pharma industry. So, my dear friends, the good news is we are in a virtual setup. So, please do not hesitate to reach out to people. Be shameless in terms of contacts. I am coming from Sevagram, which is a rural institute. Not even Nagpur. Nagpur is a tier 2 city, or now it's a smart city. But from the village part of Wardha, which is another district in Maharashtra. So coming from Sevagram, I always used to think that how can I develop myself to be the best fit for industry without any internship to pharma companies, without any exposure, and without attending so many things which happens in Mumbai and all those metro cities. So with this virtual platform, you can be a part of multiple things. Only thing is you have to understand yourself first, whether this is really for you. What are your interests? What are your positives? What are your strengths? What are your weaknesses? Just work on your weaknesses and keep aspiring and get inspired from people from industry, and you should exactly know what to do to get you there. So if your mind is clear, if you have a good mentor, good coach, you will be able to definitely crack it and do it well in industry. So, as they say, seed today will be a good flourishing plant or tree tomorrow. So, it starts from very basic, the first year of residency, where we choose right college, we choose faculty, we have good focus. So, 3 R's: right college, right faculty, and right focus. So, your first year of residency, you are blessed with your gurus, you are blessed with the best possible college that you have, and also you have to be vigilant and very attentive about what is happening in pharma specialization, in pharma specialty. You have to see what the other colleges are doing, whether I can be a part of some WhatsApp group also. You have to enhance yourself every day. So early orientation is the seed of success. And if you dream big, you will be also be able to build self belief. So the first step is have a good orientation, early orientation, focus on your early days of residency and sow the seed of success. The next is the baby step. Baby steps is basically once you get settled into the departments and you know people knows you, time has come that you start working on your taking your baby steps. You understand the basics of pharmacology. So each and every aspect, each and every subject or the topic that you read during your pharmacology is going to help you in some or the other way. Nothing goes waste. So understand the basic of pharmacology. Prepare the foundation of research methodology. It is research methodology is not just for tick mark. It is a very 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 important thing. That's why it is compulsory. And especially as a pharmacologist, you have to pay good attention to RM, research methodology, and have a mastery on it. Whatever is delivered to you, you can over and above read and learn more about it from the external resources as well. Try to build soft skills, try to understand people, meet new people, not only restrict yourself to pharma department. Explore your ideas,
Excuse me,
explore
ma'am.
your personality outside pharma
Excuse
department
me, ma'am.
also, and start to think strategically. From there is the
Excuse
time
me,
you
ma'am. Sorry
hello.
to intervene, ma'am. We are running short in time.
Okay,
So,
okay. Sure,
yeah.
sure. I'll just wrap it up. Sure. Thank
Thank
you.
you.
So practice. Of course, learn newer and newer skills. You have to have mastery in your MS Office, and now the AI is in vogue. So learn new skills and have a good networking and building bridges, which will help you to to cross the difficult parts and identify your calling. The most important thing, you have to identify your calling and only follow your gut. Don't follow people. Don't follow rush. Don't follow the mad rush. Just follow your calling. And of course, no one can stop you from flourishing. And once you have a strong base, you are going to be relevant, going to stay relevant, stay updated, and of course a fantastic successful professional. Now, I think lots of GAN I have already delivered. I hope the audience is not sleeping, but I would like to summarize it with giving you a very positive thing about the scopes and opportunities. Of course, sky is the limit. We have by working in pharma industry, it opens the gateway for global roles. So of course, you are highly valued professional in pharma industry. Second, I would also encourage people, if they have some ideas or they want to have something on their own, they can. The system is also encouraging, ecosystem is also encouraging. Now you can become an entrepreneur. You can always be a great academician, because we want good academicians or good professors in pharma industry, in MD pharmacology. And that's why the newer and newer institutes are like AIMS are also coming in various cities, and the opportunities is increasing with time. You can of course explore this opportunity, and with the phygital hybrid model of working, the opportunities are plenty with your specialization. So to summarize, I have also already said the future is bright. So please keep shining. This is what I have started newly. I was doing this in a very informal way, but I have started my top mid channel. And these are few feedbacks that I am sharing on the screen. If you ever want to get in contact with me, have one-to-one personal guidance, please do not feel shy, or feel free to reach out on LinkedIn and send a request to me, and we can have a good discussion about your career. So thank you so much for your patience, and thanks a lot. If there are any questions, I'm happy to answer. Hello. Hello.
Okay, I would like to extend a very heartfelt thanks to Dr. Sonali Kirde for delivering such a comprehensive and insightful session on how to excel in the Indian pharma and clinical research sectors as a medical pharmacologist. Madam, your expertise and practical advice have provided us with invaluable guidance and navigating this dynamic field. We appreciate the time and effort you put into sharing your knowledge with us today. Because of the lack of time, I would like to ask only one question.
Okay. Thank you, sir.
And can you just tell me the two most important common challenges that can be faced by the newly joined medical pharmacologists in the industry?
Okay, the first thing I would say is a lot of times I have seen people struggling with their soft skills. So the first challenge that we see in the corporate life is different. The college life is different. We were always into the practice or a part of medical college. So the soft skill is something which I find very challenging for students once they step into corporate industry, and it takes time. It will take time, but over the period of time, with right guidance and under right people, we polish ourselves, we develop our soft skill set, and we become better and better professionals. The second, from the medical affairs perspective, the challenge, or I would say the requirement, is a traveling job. So you have to have some kind of traveling, support some roles, like for field based roles the traveling is lesser. the traveling is more, but for office based role the traveling is lesser. But in some or the other roles, you definitely is expected to travel to places for conducting activities or for conducting various programs led by your company. So some people, they find it very challenging to leave their home place and start their journey by leaving their place and traveling to be a core part of their responsibility in a medical affairs stream. So I see these are the two most the challenges, the common challenges that I have seen so far.
Thank you so much, madam, for your wonderful session. Now let me introduce the second speaker of the today's session, Dr. Mahesh Kumar. He is my senior during my postgraduate period. Sir was the associate vice president, customer excellence, Paris Global. He started as a research scientist in R&D and moved to pharmacovigilance as physician and manager, former deputy EU and EU pharmacovigilance responsible person, certified lead auditor, managed teams up to 900 employees in India, responsible for more than 100 pharma health authorities, CROs as customers. He's been a part of generative AI initiatives and his disruptive potential in pharmacovigilance, regulatory affairs, medical affairs, and clinical. Sir also has managed a team of multi-cultural senior directors throughout the Europe currently. With this brief introduction, I would like to invite Dr. Mahesh Kumar to start his session. Hello.
Stop share. You stop share. Open his PPT. Keep it ready. Sir, just hello, sir. Are you ready? Hello, sir. Yeah, so can you start the presentation, sir? Yeah, I can.
Okay, sir is joining this session from the German. Now I please invite to start our session.
Hello. Can you share sir, share your desktop, sir. Yeah, don't share the PPT, share your desktop. Then it will automatically move.
Dr. Shonali ma'am, you can close your PPT and stop sharing, ma'am.
Yes, sir. Sir, yes. Can you make it presentation mode? Perfectly all right, sir. Yes, sir. Perfectly all right. You can go ahead. Thank you so much.
Can you hear me on the audio?
Yes, sir. We can hear you. You can go ahead.
Right. Again, thank you, one and all, and especially Dr. Shivamurthy sir and the organizing committee, Savita Medical College. And then I believe the one who introduced me is Dr. Madhura. I've been very close aid of him for the last few years. So thank you very much for providing me this opportunity to share my thoughts and perspectives. My title of the presentation is How to be Successful in International Positions in MNCs. So without much ado, I would like to get started. So in the next 30 minutes or maybe depending on the time constraints, I would like to share about some information about me and my experiences. Again, what is considered as a success? That's also important. At the same time, we are also going to talk about opportunities, nuances, and then how it is slightly different in international positions, especially with respect to interviews and work environment, culture, different nuances. Then at the end, again, we're going to talk about what is that actually drives every person, the opportunity and readiness concepts, success, aspects related to the success, and of course, the time management. See, these things, of course, when Dr. Sonali spoke a few minutes ago, she covered beautifully many aspects of being in industry and then how to be also successful. These are clearly no different. I know she has kind of stolen my thunder as well, but I'm going to more and more concentrate on how it is going to be in international positions, and how can we move up the ladder in international positions, and then obviously that can come in with a lot of advantages in terms of you moving up the roles as well as financially, personally as well. So, few more information about me. I give again from the day I started my post graduation in GPMA Pondicherry. I was very fortunate to have the head of the department, Dr. Aug-2024, as my guide, and then he was also probably at that point of time close to retirement, and very fortunate at that point of time. So we worked on pretty different aspects, including pharmacogenomics, vigilance, etc. So that was actually a great foundation when I started looking around as soon as I was getting close to completion of my MD Pharmacology course. I had actually multiple different offers, and I definitely chose the best one, which was AstraZeneca, wherein I joined as a research scientist, which is slightly different from the course typically an MD Pharmacology takes post graduation, mainly because of the fact that this particular role was in discovery and development, more like a translational pharmacologist, a translational scientist. Everything that I studied in MD actually came to use, including some of the pharmacokinetic concepts, pharmacodynamic concepts, and even obviously the toxicology aspects, everything actually. So I was part of those lead identification, lead optimization, and candidate drugs projects. I was actually providing medical inputs as to how this can have an impact and how we should be selecting the right candidates moving forward to the clinical stages. So that was really probably one of the best roles that I had in my career. So that came first in my as the first job, which was actually also, I could say now this is probably purely a luck. So what was this? What was this role about? So we were actually sitting and identifying those candidate drugs which could actually have an impact both pharmacokinetically and dynamically, and then identify the dose or the dose demand predictions using some of the concepts prevalent at the point of time, including the simulations, both at the level of animal studies as well as at the level of human clinical trial data that was available. So it was really very challenging, at the same time very satisfying aspect of that career. Then for various reasons, I'll talk about that in the next slide. I had to move into IQVIA. Then when I moved into IQVIA, that was entirely, completely different setup, wherein I was actually a PV physician manager. You can imagine that from discovery development, I directly moved into PV, which was entirely controlled environment where every act of ours was fully according to the GVP guidelines, and then we were and there are set processes. Whereas the one that I had previously was more of an explorative. So we were having a lot of options to search the articles and publications and identify whatever the best that can work for our compounds and products. And whereas, this was entirely different. Here is where, the foundation on pharmacovigilance came to, became evident for me. Though I was doing medical review of ICSRs, aggregate reports and signals, and a small team management. But this actually helped me in establishing a good foundation, mainly from the point of view of what is needed for pharmacovigilance, what is needed for the regulatory authorities. That really helped, and I could learn a lot in this role. But then, this is when you would also understand how it is important to also learn the project management skills. So I was in crossroads when I was in IQVIA. The crossroads was essentially that I do have an opportunity to get into much more deeper aspects of PV and become a subject matter expert. At the same time, I also had an option of getting into the operations, the project operations, or the project management, and then go towards people management. I really contemplated a lot, and I actually had few different options. Then I actually chose, okay, let me get to the aspects of project management because I thought I had actually learned a good deal of it in IQVIA. And that's where I got an opportunity in Bioclinica as a senior PM. The very first day when I joined, I was given an end-to-end project of pharmacovigilance, which was almost 130 people project, so which was having huge issues in terms of reaching the regulatory compliance timelines for the clients, and that was not a good thing to have. So huge challenges there, and then I talk about some of them in my next slides. I quickly rose up the ladder and then became associate director and then later director of customer engagement. This is when I also moved into another role within Germany. I got transferred to Germany to take care of not just only all the projects that we had in Germany, not Germany, sorry, Europe, but also do a role of deputy QPPV. As you might be already aware, QPPV are the qualified persons for pharmacovigilance, and this is probably the penultimate role for any pharmacovigilance person, probably not just only in Europe, but also globally, because this is actually a legal role. This means if something really goes wrong, you're also in trouble, actually. This means if you're not really able to do your job properly, this can also, you will be legally responsible and maybe even taken to court. So this is a very serious position. And then, I made a switch for into Eversana as a senior director for global PV operations. And then for the last 5 years, I've been with Aris Global as a senior director, client partner, and then now moved up the ladder to associate vice president. So what do we do actually in Aris Global? This is, again, I moved from a pure research role, then into if you see the middle three are actually the CROs, the last one is actually a technology company. What do we do here? It's essentially the R&D technology. We work on all the technology related to medical affairs, clinical, regulatory affairs, and of course, pharmacovigilance. Many of you who are in the PV field know about Aris Global. The biopharma companies, they are some of their clients. We actually work also very closely with regulatory authorities. For example, FDA is one of our customers. So we work with them, and we actually we interact very closely with them as well. And at the same time, of course, many global CROs are our customers as well. So we have all the pillars with whom we are interacting, and then we drive a lot of innovation within the market. And just to give an example, when at least 6-7 years ago, we were the first one to start the automation technology in all this R&D space, and now we are the front runners with generative AI, using generative AI for all these technologies. And what's going to happen, because this is clearly going to disrupt. It has already disrupted the whole world, and now it has started the next phase, wherein it is coming in every aspect of our work. It has the potential to definitely affect the number of jobs, the amount of time needed to do robotic processing. So that's something that we should be watching for. So moving on, I just want to share not every medical college or not every student will get an exposure to such great foundation, but it is really in our hands to really go ahead and then learn more and then continue. Again, as Dr. Sonali heard her, that you need to be a bit more open and reach out to your seniors. Why did I put the second point, avoiding herd mentality? And this is a very important thing, because when I was in AstraZeneca, there was a situation just 1 year before I left the company, that this was a direction from the corporate to decide what would be the strategy for Bangalore discovery unit. Would they like to go towards infection portfolio, or would like to go towards neglected disease portfolio? I was actually one among the two. The other one was the head of research to raise the hands and then say it's actually a bad idea to move away from neglected diseases. Because of course, to me personally, it was very close to my heart. I wanted to really continue working on the neglected diseases, because I don't think any other country or any other organization is ready to do it other than, of course, India. Whereas the whole organization, whole discovery unit, were actually in favor of working for infection. Of course, because of this strategy, it led to later closure of the discovery unit as well. But again, what I'm trying to emphasize here is that if it is important, if it is something that you believe in, please be open and talk about it. And even if it is non-democratic, you don't have to follow what others clearly are following. The third one that I want to quickly talk about is, again, also believe in yourself, because some of the solutions that you give to your customers, to your clients, or anyone for that matter, or within the pharma industry, could be actually very silly, straightforward, but sometimes it actually resonates. So we had provided some solution against which we were contending with big giants. We had no experience, but still we were able to win that project. So it's all about being confident and winning with that. Learning of new skills. I talked about my journey in IQVIA, wherein I could get some fundamentals, for fundamentals being practiced, is that whatever gets measured gets improved. Some of these things are might look very basic, but when you really put this into practice, you will start seeing results. We were not really measuring some of the compliance aspects in some of the projects. So when we were able to adjust that, we could actually see immediate results. So these are all really basics. If you stick to basics, definitely it's going to help. These are, of course, some of the very basic information that are available in MBA, maybe even first chapter. So go and then read them when you have time. when you're really scaling up to lead such bigger teams. When I decided that I need to get into the people management roles, really there was not much of time to scale up. But I think the job will teach you how to scale up and then start managing. But always important to read and understand how to lead bigger teams. So, some of the experiences that I wanted to share. Now let's switch the gear. Even before what I'm going to talk today is really not how entirely specific to MD pharmacologists, how they can be successful, but also for everyone, right? It's not just only for MD pharmacologists, but within the global scenario, there are medical affairs roles, there are regulatory affairs, clinical, as well as PB roles. Medical science liaisons, medical directors, and these are all some of the senior roles that you can actually get into. You need to get those experiences within India, spend a few years, and then really start looking for those opportunities. What many people do not know that technology space also provides lots of opportunities for MD pharmacologists. I just had another person joining in the last 1.5 months, our organization. He leads the product, the Signal product, and he is an MD pharmacologist. And he's also joined as an associate vice president. So you can imagine that there are such roles, and all we need to do is just be open and start embracing those opportunities. Solutioning experts, subject matter experts are needed everywhere, even in clinical, regulatory, and medical affairs spaces. I talked about translation pharmacology. When I joined my first job, it was actually probably single-digit number of people used to work in translation sciences. But today I see that many have actually some of the roles have been turned out to be translational scientist or pharmacologist role. So this is extremely challenging, at the same time satisfying role. So think about it, and these are also available today in India, but very commonly available abroad. And customer-facing roles like program managers, product managers, client partners, strategic account directors. Some things that many people have not explored is to really get into some of the BD roles itself. And these are again very challenging roles. BD roles are really not easy for everyone. So you need to be having that mindset, that openness to meet people and enjoy the conversation, etc.
Hello, Dr. Mahesh. You have 10 more minutes. Okay, just to alert
I think we can finish in 10 minutes.
Yeah, thank you so much.
So what is the success for medical pharmacologists in industry? When you see a drug or a candidate drug impacting patients' lives, this is finally, this is exactly why we work for it. And then at the same time, then you also prevent wrong drugs entering the market. So, and also help to reduce the cost at the end of the day to the patient, especially to some of the, within Indian or any third world countries, if you're able to get the new drugs, at the same time, reduce the cost of drugs to the patients. And to me personally, it helped in, satisfying my passion that neglected diseases, or working on neglected diseases to bring them to the patients was one of the things. And also bring those innovations to the health authorities, biopharmas and CROs that actually could impact patients positively as well. Okay, so what do we need when you are actually applying for roles abroad? There are many roles that if you go to LinkedIn, you can find many, but I can tell you the last point, the role of visas and selection is something that's going to prevent everybody from applying to such roles. But I can tell you for any role that gets published within Europe or a senior role, there will be thousands and thousands of people applying for it. And there are robots who can actually, they will read your CVs in such a way that they will identify the keywords and simply reject. At the same time, there are visa requirements. You can actually contact me if someone is interested to pursue international roles. I can actually provide some guidance on the visas. At the same time, as I mentioned, well-suited candidates only will be selected. And there are probationary periods within which you will be assessed. And later, you would be either eliminated or, taken ahead and provide permanent roles. Especially in Europe, you have language requirements. I stay in Germany, and some of the roles definitely need German language. 80% of the roles require German language proficiency. Especially, they even ask you the native speaking ability, and they are actually preferred. And the people management roles, definitely you need a good German, because you will have some people who are of German origin and even cross-cultural within Europe. So you need to have those skills also. So you need to have all the 6 that I described here to be successful, first of all, to get into such international roles. Then, cultural differences is something that you need to immediately be aware of. There are high context and low context kind of mentality, cultural difference. We, from Indian origin, we give a lot of importance to the power, a lot of importance to the role that person is playing, whereas in the developed countries, it's entirely the opposite. It's not about the role, it's not about actually how, what kind of role, even including a CEO, but it's all about what is it for that particular person. So that is how it is. So you need to completely switch that mentality. There are different workplace behaviors. You just work 8.5 hours a day and take a holiday, no problem. Even sick holidays are not really frowned upon. So you need to really switch from that point of view also. And working with non-Indian managers, I do have at least experience of working with 4 to 5 such managers already. What they want is to really make sure that you are meeting your requirements in the job. If you are going ahead and then working for something else, really that is not corporate. So, whatever is agreed in your job description is something that is simply expected. If not, then that is going to affect you adversely. Many people within this scenario, they don't sometimes expect promotions because they would like to stay happily with the same role, just because that gives them good work-life balance. So you need to see that behavior also in the, you will see that behavior also in at least the EU, not much in US. Finally, it is going to be rewarding from financial point of view also, because especially in the developed countries, economies like Germany, France, UK, and US, you will actually see very high-paying jobs in this area. Okay, what is best for your growth? It's definitely about you. It could be small and growing organization, big and stable. I have worked in both. I liked actually the first one mainly because it changes every day. The dynamics are changing. The challenges are huge. Quick growth potential. And there is a misconception that small companies pay less, but that's not true. And there are HR policies evolving. But as far as a big and stable, again, it depends on your personality. How do you want to take it? How do you want to approach it? Slow growth, but stable and peaceful jobs that you can actually see in the bigger companies. You will be able to get, full quota of your holidays and, a standard compensation. You don't have to really negotiate so much with bigger companies. So it's all about how you follow this. Again, the last, one of the last topic is what's your driver? What do you want actually in life? When you come to jobs abroad, do you like money? Of course, money is one of the driving factors, especially early in the career. Or do you want to actually get into those roles? what is your passion? I think that is something that you need to identify very early in the career. What kind of personality you are. For example, there are jobs in medical affairs wherein you need to go and meet people, especially the field ones, and interact with a lot of people. So do you get energy out of those interactions, or you lose energy? Are you a people person, or you are a number person? What are you? So those things are important things. We talked about opportunity and readiness already. So small companies provide you with vertical growth, and big companies provide you with horizontal expansion that you will be able to really expand in your expertise. So it entirely depends on you. There are two geometrical aspects that I've described: triangle of success and quadrangle of time management. I don't know how much time I do have, but quickly I want to touch upon. These are the only three things that are going to make you successful in any organization, any setting, abroad or Indian. You need to continue to work on your knowledge, continue to read, and get job and industry knowledge. And you need to continue to brush up your communication, leadership, technical and people and analytical skills. That has to happen on a daily basis. At the same time, when you actually work on these two, automatically it will help you in improving your attitude. It will help you become more confident, integral, as well as you will show courage, and of course you will also behave as a team player. So this is something very important. And the last one that I would want to quickly touch upon is the time management. Today, I know everyone has cell phones, but think about using your time very judiciously. Even today, or when you get into the industry, 80% of your time needs to go to this quadrant, not urgent but important ones. Otherwise, they will end up being urgent and important and start pressurizing you or start putting you stress. Urgent but not important are the ones that people come to you, and it's not really your problem, but it's essentially other people who will be putting pressure to get this done. Whereas the last one, not urgent and not important, is the one which is quote and unquote called time waste. You should not be spending time on the last quadrant at all. The one on the right hand side, upper quadrant, right hand side, is the one where 80% of your time should go, so that it becomes very rewarding for you in the coming days. Okay, so finally, in my view, there is no one formula for success. It all individual dependent. You need to be ready for opportunities whenever it comes in, and mentally you have to be ready. How are you going to be ready? You're going to be ready with your skills, knowledge, and attitude, and that will, all these things would come out when you are even speaking and you're presenting something, and people can easily identify you as the right person to give that opportunity, and be ready for that opportunity anywhere at any point of time. So what works for you may not work for others. So with this, I'd like to end my presentation, and I would be happy to take some questions given the time. But again, I would like to thank Dr. Shivmurthy sir, organizers and panelists for giving me this opportunity. Thank you. Can you hear me okay, sir?
Sir,
Your voice is breaking actually.
am I audible, sir?
Yeah, now slightly it appears you're away from mic, but yeah, I can hear you.
Thank you so much for your wonderful session. I'm succeeding as a medical pharmacologist in international position within multinational companies. Sir, you have provided us with practical insights into the essential skills that needed to thrive in a global environment, such as effective communication, understanding diverse regulatory framework, and building strong network And definitely your experience have highlighted the importance of adaptability and cultural awareness in navigating the complexities of international roles. I believe this takeaways will be invaluable to everyone here, helping us better to prepare for global and career opportunities. So, as we are running late, I'll just quickly take one question. What are the current trends in pharmacological research and development that international medical pharmacology should be aware of? Just in a brief, sir.
Can you repeat that question, sir? I couldn't hear well.
Yeah,
The last.
current trends in pharmaceutical research and development in international global platform.
The current trends in
Yeah,
the
please, sir, like what are the like as a budding clinical pharmacology that they should be aware of?
right, the current trends are clearly multifaceted. Three different industries are three different pillars of the fraternity. One is technology. You should be definitely aware of how the new technologies are affecting or impacting the whole uh, industry as such. That's number one. Number two, what are the things that regulatory authorities are bringing uh, in terms of their new changes? You should be well aware of it, well read, have a good read about it, and be ready. At the same time, these two industries, how they are going to impact the pharma and CROs is something that you need to be aware of. As someone who's trying to seek international positions or work and be successful in those positions. So this is something that they need to continue to look for trends. And if you are keeping up to all these things, definitely that will lead to success.
Thank you, sir, for your wonderful session, and happy to see you in this platform. Long time, so
thank you very much for the introduction and opportunity. Thank you.
Thank you, sir. Now I would like to request my colleague, Dr. Ashok Zurbe, sir, to introduce our next speaker.
Good morning, all. When I say it's my honor and privilege to introduce Ravindran, sir, it shouldn't have been more heartfelt because this is the person whom I have looked up to many times in life, and he has been there to guide me whenever I'm in a fix, and you cannot find more straightforward, thorough, knowledgeable person than him. And most of us know about him, but some of the youngsters who don't. Just a quick brief of Sir. Sir retired from GFMER as a professor and head in pharmacology. Currently, is director of MGM Advanced Research Center, Puducherry, and also professor of pharmacology there. He has been ex-professor, ex-team research at JIPMER, with the author of CAL software X-Farm. When we talk about alternatives to, probably Sir was way ahead of time, and 10 years back, we all only knew about this software. He has authored a book titled The Practical Approach to PG Dissertation. He has been chief editor of Indian Journal of Pharmacology 6 years, Journal of Pharmacology and Pharmacotherapeutics 15 years. Both were PubMed indexed during his time. And he has conducted more than 50 workshops on research methodology, biostatistics, and biomedical communication all over India. He also had been dean research at JIPMER. And many important administrative posts. Sir has held member of institute body, standing academic committee, standing finance committee, standing selection committee at different aims for selection of faculty members. So it's a huge list. He is stalwart in pharmacology, and many of us, most of us know about him, and I won't stand between him and the audience for this important topic related to the CAL software. Morning, everyone. Thank you, Dr. Dubey, for the kind words. Dr. Dubey, thank all the visitors for giving me an opportunity to come and speak something. Okay, the topic, so actual topic given to me is indigenous call software. I slightly changed it. So the content is the same. I slightly changed it to my journey with the XForm. The XForm is my creation. Of course, it has been stolen recently. It's my creation and it's a software as a production. It's a software, software, computer learning software. Then my talk is going to be very, very light. It is not going to be okay. I'm going to tell you about my experiences, how I created this form, and then how I am getting on with this software. This lately. Anyway, so let's switch off the light, please. Since, yeah, it's okay now. Now, we see, I mean, it's also experience, but something it's not exactly, and not exactly this in 1985, December, our department got one of this. At that time, no, there were not many experiences were not very popular or not available in many places, but then our department, Japan, there was something in Japan. Now, I was a postgraduate. 1984, I joined as a postgraduate. 1985, our department got one December. And this got a data processor. Why? You can see the monitor. It's a computer monitor. It's a monitor. So the monitor and it's not data was but actually it's a computer was. It's just okay. No, the 6 years, 16 because also the experience is not. And also it has got facility for programming, basic programming. Basic is for beginner all-purpose body code. So the department called basic programming language. You can do programming in basic language.
Voice transmission.
Yeah. So what I thought was, I just started started the computer. This the data processing started the man basic programming. Basic programming. Just when the examples when I just made when there was a journal, there is for the journal called Tips. Advancing Pharmacological Science. So this journal was really starting general library was getting this journal. This journal, what they do is one column was the computer program. They give some of the code, basic code to do something related to pharmacology. So on that one, trigonometric therapy was A.B. Barlow, as a well-known pharmacologist. So he did some text-based simulation, not a graphics-based simulation, text-based simulation of LD50. Give some animals not right and increase the dose, the animals are dying, and it calculates and it's just a text-based simulation. When I read this, I immediately got an idea. Now, why not know what simulation of experiments? We were demonstrating how which are doing for undergraduate students. At the time, we used to know some 15 experiments. We used to demonstrate some 15 animal experiments. And of course, the students also have to take part in this experiment. And the regular practice classes, as well as final exam, also they have to do the final experiments. Yeah. So what it is was I started writing now this one on the trying of dog experiment. I was trying dog experiment. I got a home computer. So from UK, at the time, was not available in India. And I had to get one from UK. And this is about the time the home computer is popular in the West. But Sinclair, no, I got this one.
And this one now, this is what you can see now the recording grades is ordinary audio tapes. Audio tapes can be used to record the program, whatever program that can be recorded, which see now CDs and like this. And then now this can be done the computer and then this can be connected to TV. So I got a small TV and then I connected to it and then I started again creating another version of dog BP. So I was able to find the full program and yeah. So this one I demonstrated in 20 years. 20th conference of IPS, Indian Pharmacological Society in Punjab Medical College, in 1987. And this is now the abstract of the book of the proceedings. So this I demonstrated. So I present my question. So I put my computer there and then I read a TV. I thought an organizing TV. I was able to get someone color TV on the time. So TVs are so big, CRTs. I got some TV and arranged some tables and then put it and then I started demonstrating. Other than it was totally, of course, it was totally new and everyone was thrilled. Next please. Yeah, then in 1989, the computer started coming, IBM PCs, now IBM compatible PCs. So before that, there was no such thing called PC. PC means personal computer. No such thing called personal computers. Those days were mini and maxi computers or the mainframe and mini computers. Those are all big computers used by the scientists, space scientists, and these people and so. But there was the IBM came with for personal use. For personal use, they can tell me computers in the 80s, I think 81 or 82. And then the computers are available. What's for 1985? See, the people got when IBM compared to PC, I was able to get access to it. And we can also this program, GW Basic, actually this application program. GW is actually the Roman connected close to that's why it's called GW Basic. So using the GW Basic, I was able to program several experiments. You can see that dog, rat, rabbit, frog, Indian, and mouse, all these things I was able to
Microphone.
Next one. Next, can you or this are this thing. If you give me, then I can say. Yeah. So this I made a program, but then the computer was so new. Not many colleges had computers. Okay, when you know this thing, you see computers. So whatever I did not know, there's a computer and it's the also part of it. Yeah. So next
Slide. Previous career, previous.
Yeah.
This one.
Previous slide.
Twitter.
Previous.
Previous.
Yeah. What we can do next. Next one, please. Next one. But in between, there is one mistake. Why is it?
Remote. Remote use பண்றதா? இல்ல remote connect பண்ணணும்.
I think in between, go before. See, yeah. This is the one. Okay, next. 89. Next. 90. Okay, fine. Yeah, fine. It's okay. So, 1990, I went to UK. I was in boards in the Colonial's Medical College, the clinical pharmacology department. So at that time, now I took my whatever I did for PC. So there, the computers are available, freely available, every department for IT, and everyone had access to computer, everyone was working with the computer. So I was doing some changes in the program. And then the law person, the name Johnson, And when I was doing something, now he looked at me, this thing, and then he said that no, they are happy to participate. British Pharmacological Society conference. The December now it's a grand one conference they used to be conducted in December. They used to have 3-4 meetings in a year. December meeting of a grand one. So on that time it was conducted in London, the St. George's Medical College. There I demonstrated this abstract. Next one. Then I came back and I joined the JIPMER faculty member. And Dr. Roy encouraged me to distribute it. So what I did was, so on the time now you can store it on the PC listings, you can store it now 500 water. It's the trend of now just this. So these are the source things that are available. Not there are expensive things. Chief of new name of and there are other in the channel. When I started distributing. Next. Of course, there are not many takers because many didn't remember computers. And then the scenario changed in 1995. The Windows 95 came. Windows 95 came. So most of them know they started switching over to Windows. So what we did was I was able to get some funding from PPT. They would get some funding from PPT and then started writing this program. And he did something, and I also what you did since it was machine basic. I already have experience in basic. I started now writing this experiment in this place. So this is movement rate of the software and the God model experiment. The effect of the excellent heart every time God the problems of like this. Then 2000 to 2010. So at this time, what I did was I started seriously distributing the Windows version of my software. So I made it in CDs and whoever wanted it for a nominal cost from the Department of Pharmacology. The Department of Pharmacology at the time had IPS branch, local branch of IPS. So in the name of local branch of IPS, we started distributing for nominal price. Then I created a website also. Next please. Yeah, this is my website. So in the website, what I did was I put it on the website and then I freely distribute. Now people can expand this ambition sessions and they expand here. So on there. So what I did was I put it on the website and then anybody could freely distribute, freely download and then they can install in their computer and they can use it. So there are so many, many people they started distributing, downloading from the market from India, from cities and Latin America and so many places they started using it. So in the website point of they gave it free. Still people wanted CD because when MCA inspectors come now they ask for more. There is a CD and also some colleges they wanted CD, so those who wanted CD we charged some nominal price and distributed the CDs also. Then what it was I got some funding from that I showed. Then CPC at the time CPCSCA was formed 2000 around 2000 CPCSCA next slide. So moving. So CPCSCA was formed. So the first time CPCSCA was formed. In fact, CPCSCA invited me. I came to know that I made some program for replacing earnings. So they gave us so what it is appearing in my software was one my CPCSCA rules in fact on the use of laboratory animals. They say that the CPCSCA rules know how we impact the use of animals and also said because my software has started making routes and many people started using it and it completely replaced rabbits. The rabbit experiment was solved, especially for undergraduate students. Next, please. Then there is something called the internet. Internet is your UK-based, it's NGO, okay, non-governmental agency. I mean, no, it is involved in reducing animals in education. So they gave me some funding. They gave me some $2,000, £2,000 or $2,000 something they gave for distribution of objects. So what I did was I made 3 CDs. CDs, and at the time I was editor of Indian Journal of Pharmacology, chief editor of Indian Journal of Pharmacology. So made CDs. All those CDs I put it in each issue of the issues. So I put it in the thing. You have seen the initially they showed the CDs. So those CDs I put it in the CDs, and then it was distributed. It was distributed along with the journal. And also, they reported that because of those CDs were distributed, and so many, that is true. The many medical colleges they stopped demonstrating animal experiments for undergraduates, and they in fact they reported in their website. Next one. Next. So when a software became popular, then what MC did was it started recommending the software. They say that it was an alternative to this use. To discuss involving animals, before quantitatively have developed next form, a black CD. This CD has been prepared for engagement to used in undergraduate courses in medicine, pharmacology, retail sciences. So what they sort of recommending, this is minutes of one of their meeting, and then they recommended my software. And then what they did is in 2012, I think, in 2014, they completely banned also. Next, please. In 2012, this is Gazette. The Gazette participant of the government completely banned. They say that for teaching physiology and pharmacology curriculum, the required knowledge and skills should be important. It's completely assisted modules. So only on India was supposed to be required for medical colleges. So they completely banned the animal experiments for undergraduates, not for postgraduates, undergraduates. So because of this, the many people know the many colleges they started using the software. Yeah, next. Then 2010, something happened. There was some pharmacologist. Varun Gupta. And Varun Gupta, he joined Elsevier, India. And then he knew about my software when he was undergrad, when he was postgraduate, he used my software. So when he joined Elsevier, one day he called me. He said that the Elsevier will market my software. I said that my software, it was written by me, it was very a bit amateur, it was not very professional. What I said was, let Elsevier fund it. Okay, I will write I will hire one company, a professional company, and then we'll rewrite the whole software, we'll bring out a very sophisticated version of the software. So they agreed, they funded it, and then we hired a company, and then the XFORM Pro was born. So this was XFORM Pro, and 2010 and 11, 11 it was released, 10 it was software, and 11 it was released. Next, please. And this started, they started distributing it. Of course, they started selling it. And it was used all over India as well as abroad. They started selling the software. They, in fact, now it was not selling it, they were licensing it. That is, they give it and every year, the colleges have to pay licenses. And online, it's all online. The offline software is not there. It was not available on CD. Demo was available on CD, but then the full version was available only on online only. So people have to pay a subscription every year. They have to pay subscription, and then they can use it. Many colleges, more than 100 colleges, they paid license, and then they were using it. Now, how we use this XFORM in 1994, we started demonstrating this event for UGs. 1994 with my software. I told you in 1994 itself, we started distributing. So at that time, we had a couple of computers, and then we started distributing, demonstrating it. And 1997, we included this experiment in the faculty curriculum. So at that time, previously it was optional, and then 1997, we included in the curriculum, and then we started demonstrating, and then we offered students to do. They themselves were doing this. At that time, still they were using the XFORM for DOS. And from 2010 onwards, all 5 experiments. Only one of by 1997, 2010, adding more experiments in the curriculum. And by the time of 2010, we included all 5 experiments practical, and we completely remove the manual experiments. Of course, there was a ban from the government also banned. So it was very easy for us to include all experiments in the curriculum. And from 2011 onward, we started using XFORM Pro. XFORM Pro was released in 2011. We started using it for 2011. And these are the pictures of what are the pictures. Okay, this is our computer lab now students using it. This initial version they were using it. The students have to share the computer, but later we got many computers in the computer lab. Each one of them on a computer and we started using it. And we are using this for this. It is not only for practical classes. And second exam, as well as final exam also we started using. We're using these modules. Because these modules contain tutorial as well as examination mode. Examination mode can be used for final sectional as well as final exam. Next. So 2017 to 2022, 2017, what happened was the company which was marketing XFORM Pro simply they stopped it. It was really painful. They didn't tell us anything, and then they simply stopped it. And I had a big fight with them. And in fact, it was a dark street for XFORM. So the company stopped marketing XFORM Pro, and the COVID started. COVID started because we wanted to make a use of myself and one of my partners. We offered XSolid. My software is XFORM. His software is XSolid. So the COVID started, there was went to the approach. Some company got it, and then we paid some money, and then now slowly they couldn't use it, and we lost money. And so we lost time for the reason why 2019, the XFORM Pro was stopped. Nobody could use it. And by this time, now the 2015 onwards, what happened was the correct XFORM Pro started appearing in the market. So one person who is in Gujarat, and he sold my XFORM, tried to XFORM, and he registered in his name, and then he started XFORM of EX and this thing, and with he sold, he sold our this thing also, our pictures and everything he sold, and then ideas, pictures, all this thing he sold, and he started making a very bad copy of whatever we have done, and then he started selling it. Okay. Yes. Next. So this is the last slide. So 2023, then what we because of COVID we couldn't do, and then we again 2023, myself and my partner, author of Technology. Then we approached a company in Delhi, they were willing to do it, and then we named the platform as Medical Pharm. So now we can see we go to Medical Pharm. Next please. So Medical Pharm now we both XFORM Neo and the Pharmacology Neo. So both we included 32 experiments. They go to mycalpharm.com. It's available in mycalpharm.com. And of course, you have to pay. And those who want to use, they have to pay if you have a license now. It's based on license, on yearly license. And generally, we are able to get it back on the track, back into the market. So because difficulty and lot of money and all this. Next, please. So my journey has not stopped. So it started 40 years back. Still 40 years back. It's not stopped. Still continuing. Maybe you would like to know how much all this cost me. Now, making a software is not easy. If you are making on your own, it may be, may not cost much. And the problem is, it don't need to be very amateur because we are not professionals. Unless a professional does it, software may not look very professional. Of course, professional, if you get take a professional, it is going to really cost so much. Usually, during COVID, we approached the company, we paid some more than 10 lakhs or some this thing, and then totally lost. And then this one now is spent almost 30 lakhs or something. Totally about now. So far we have spent 40 lakhs myself and my partner. And There is one reason now why you cannot do it free, because it costs so much. If you want a professional good quality one, it costs so much. And of course, when you spend money, you take it back. So there are questions. So why can't you give it free and all these things? It's not possible. And if you spend a lot of money, it is definitely not a quality product. So you spend a lot of money, and it's not possible to give it free to anybody. Of course, you might ask, well, I haven't earned any money. Yes, they earned money when Elizabeth was marketing it. They were giving me royalty. And with the money, we instituted Exform prize for best paper presentation, which ISRPT conference. And the ISRPT conference, there's a session, basic, oral basic, who gets, the instituted ideas of money at this thing. And also I donated some money for travel grant. Maybe now I get more money, I can spend money for what is something again now I can spend money for the development, more money, if I get more money, spend money for more development of other more programs, and also use it for the teaching some titles and travel grants, all these things. Okay, thank you very much. So,
Thank you so much, sir. It was a good sharing and sharing, going through the journey that you went. I know now that whatever little I know of him, and the kind of staunch, honest person he is, whatever he mostly must have lost momentarily. Whether the making and whatever little he made, I know that he instituted a few awards for different societies.
whatever I lost from whatever I learned from the previous Exform Pro. So, not that what is it?
Good question, always for academics and what we have learned a lot from you, Seven. And thank you so much.
Thank you.
Dr. Shiva.
Yes.
I would like to thank sir. Basically, he kindly accepted it immediately when I requested him. And he is my guru. And I I keep always telling him, sir is I am Ekalaga and he is Dronacharya. So that's how we have that relationship. And whenever I meet him, I take his blessings. And he really blessed us by coming here and presenting his life story. And we have a, I request all of you to, assemble back because sir will be in the award, lifetime achievement award. And we are first award in this sir only. So we request you to, all of you to join back when we have the inaugural program. Sir.
That's opportunity.
So just one thing, sir. Yes. Sir. And we can call him as a father of experiment pharmacology for Pharmacology. Yeah.
I don't deserve big words. Not that I have done so much. I don't deserve any big. So, thank you.
Sir, it's not like you have heard the story of X-Pharma. So, bigger story behind, he wrote one book he has written, that is research methodology, postgraduate, and that is widely used. And I can tell you, each and every postgraduate, I think they would have read it while writing their thesis, how to write PG thesis. That's really wonderful book. And he is also means today, if I have achieved anything, it's because of that I can tell what because what we get from the home institution and what we get by attending this one workshop for maybe 1 day or 2 days. I think it is the teaching is like and I think today I have looking how the teaching onward. Like from teaching onward, I have not used any statistical help just because of you. I have not taken any statistical help, and I just use this knowledge what you have given me on book. And till date I am using it, I am continuing. It's not about being jumping into income. This function will need a car. Thank you so much, sir. I request you to bless me and bless everyone. Yes.
So the final was already sitting by now.
Thank you for the wonderful speech, sir. As we come to end of our presentation, I could take this time to acknowledge and express to give the moment to speaker, sir. For that, I invite the chair.
You can break it up.
I invite our chairperson. Dr. Sudhakar sir will give the appreciation to the chairperson.
ஆடியவே யாருக்கும் கேட்கல யாருக்குமே கேட்கல சரி பண்ணாதான் பார்க்கணும் பரவாயில்ல
Co-chairperson will give the moment first.
எல்லாரும் வாட்ஸ்அப்ல கட்டிட்டு வர ஆடியவே கேட்கல ஜூம் மீட்டிங் ஆன் பண்ணிருக்கீங்களா
Thank you, great for me. Okay, since because of time restraint, we will move on to second session. I will have on the questions.
Zoom let me tell you. Finance சரி பண்ணிடா நீங்க ஸ்டார்ட் பண்ணுங்க என்ன பண்ணுங்க பண்ணி குட்டி ஷட் டவுன் பண்ணிட்டு ஓடாம சார் ஜூம் கலந்துங்களா சார் ஜூம் யாராவது வேணும் பண்ணிக்கலாம் அந்த இதாக சொல்லுங்க அந்த அந்த பாஸ்வேர்டா சொல்லுங்க ஜஸ்ட் அந்த லிங்க் யூஸ் பண்ணி ஜாயின் பண்ணுங்க வாட்ஸ்அப்ல மீட் கனெக்ட் ஆக மாட்டேன் Hello.
Working, sir. That is the issue. Right now also they have
working,
right now also they have connected. ட்ரை பண்ணும்போது இதே ஸ்பீக்கர் தான் எல்லாமே கேட்டுச்சு
and also there and then
volume ரொம்ப so it's audible volume is very low
speech like from here, but now you try. You try now. You go there and then.
To the online viewers, can you give a thumbs up so that we can move to our second session? Yes, thank you.
Chairperson's legacy. So Chairperson doesn't know.
Keep the stem. Connect the stem.
సరే ఒరే నిమిషం
EVNMB, welcome you, ma'am. And I welcome the co-chairperson, Dr. Pujilanjan sir, and sir is associate professor in the AIMS Raipur, and sir has of more than 140 publications and copyright of 24 grants and patent. And welcome you, sir. And chairperson and co-chairperson will introduce the speakers and over to you.
Good morning, one and all present here. I am, first of all, I should thank Dr. Shivamurthy sir, founder of MPS, and organizing chairman, Dr. Tirunavakarasu sir, professor and head of the Department of Pharmacology, Savita Medical College, and Shanas ma'am for giving me this opportunity as chairing this session. And I would like to invite Dr. Arun Kumar Radhakrishnan. He's a head pharmacologist. And I'm noting to introduce
సెకండ్ సెషన్ సార్
as a vice principal and professor and head of the Department of Pharmacology, Chettinad Hospital and Research Institute. And sir has been serving as a director of IPSC, Chettinad Academy of Research and Education. And sir has been of various committees of government institute such as Danby Medical College and Kilpack Medical College. And sir serving as a vice chair of IHEC and ICMR NIRT, and he is an well experienced and in academics, research, trials, and ethics committee affairs. He has publication of 60 to his credit, has citation 292 at index 9. And I would like to invite sir to deliver his talk on roles of artificial intelligence in clinical research and remote monitoring.
PowerPoint வருமா பேப்பர் போறோம் screen essential.
Gigantic Good morning. I'm going to talk about the role of artificial intelligence in clinical research and remote patient monitoring. Before I start, I think I should thank the organizers for inviting me to be part of this event, the Association of Medical Pharmacologists. I should thank Dr. Shivamurthy, who is the founder of this collaboration, and Dr. Thiru, Dr. Shanaz from the Department of Pharmacology at Stanley Medical College. This is an opportunity to share some of my viewpoints on this evolving topic, artificial intelligence in clinical research. Next.
Sir.
We know that clinical trials are human experiments. We do it with drugs and devices with the purpose of generating data on the safety and efficacy of the drug or device. With the purpose or with the aim of submitting the data to regulatory agency or government bodies to seek marketing approval. Not all human experiments are clinical trials. Those studies which are done in humans with the objective of getting the data and then submitting it to the government agency to get marketing approval will fall into this definition of a clinical trial. The purpose of a clinical trial is to ensure that the drug or a device is safe and effective in human beings. When we look at conventional clinical trials or the traditional way of conducting clinical trials, we know there is a sponsor or pharmaceutical company who is developing the drug and he wants to market this drug. He's doing all research in preclinical, in vitro, he is formulating the compound and then he is trying to test it in human beings. For that, we talk about clinical trial, we have a protocol which is written maybe by the sponsor or maybe a CRO. They prepare all the documents like informed consent forms, CRFs, every other essential documents getting prepared. And then they identify the sites, maybe 10, 20 or 30 hospitals they identify and they depute CRAs or coordinators, where the coordinators sit with the doctors and the data is generated in CRFs. There are two ways. Initially, we used to record the data in paper CRFs, and even before 20, 30 years, we had this electronic data capture. This is not a new one. It is there for 30 years or so, more than that. This data is going to sponsor maybe CRO. They do the data management, statistics, prepare the report, and then submitting it to the government agency to support the marketing approval for the drug, its safety and efficacy. This is what we call it traditional clinical trial or conventional clinical trial. But we are talking about the digital influence of such clinical trials, and this was possible because we have few things that have happened in the last decade. There is a rapid technological innovations in the field, not just in medicine, but anywhere, any field, any domain. We have rapid technological innovations. Information management system has become very robust. Then advanced computing facilities. All these things have made us to realize and also made us to adopt, the artificial intelligence in clinical trials. The way that we are perceiving and then conducting clinical trials is changing. Even we have adopted many of these principles and the processes in COVID-19 clinical trials. Just to say about artificial intelligence, of course, it is not a branch of medicine. It is common for many things. They use the computer science. It is the branch of computer science, statistics, and engineering, and they use algorithms or models to perform tasks and exhibit behaviors, so that they can develop a system which can learn things like our brain. The system can learn, and it can make decisions, and it can make predictions, give solutions. That is artificial intelligence. It's machine learning. It is a branch or it is a subset of artificial intelligence, which allows the system to develop own models. And these models will do analysis of data. With that, it will learn, and then it will make again predictions and give solutions. But we need not program it every time because the system itself is like a brain. It will learn on its own and then provide solutions. Today, it may give a solution for a given problem. After 1 year, it may not give the same solution. It may give a refined solution which is suiting that particular environment and time. That is machine learning. And for the purpose of our discussion, these two terms are interchangeable. Artificial intelligence and machine learning These two go hand in hand, and hence we can use them interchangeably. There are potential uses. Theoretically, at least we can predict that artificial intelligence can give value addition to our routine process. Like it helps in bringing safe and effective drugs faster. We conduct a trial for 5 years, it can reduce the timeline. It helps us to broaden the access of medications to everybody. Health equity, it helps. It helps to increase the quality of manufacturing. It helps to enhance the drug safety, develop novel drugs and drug classes, and then it also makes us to adopt the personalized medicine for wider population. These are potential uses that we look at when we are talking about artificial intelligence. Like it is faster at a less cost with more regulatory compliance. It helps in clinical data management, personalized medicine, and then improved patient outcome. Particularly talking about its role in drug development and discovery. It has role in every aspect of drug development, starting from drug discovery, target identification, selection of a candidate molecule, giving priority to particular compounds when you have hundreds of compounds in the library. And even it helps us to design a particular compound which is targeting a specific receptor or a pathway. It helps us to enhance the screening. Already we are doing high throughput screening when we have hundreds of compounds. Now with the application of artificial intelligence, we can screen hundreds of compounds, thousands of compounds in a day or 2 or 5, 10 days. You cannot imagine the speed in which we can do such screening. Of course, virtual screening. And it helps us in non-clinical research, clinical research, post-marketing surveillance, and then pharmaceutical manufacturing. Next. These two areas we'll be focusing more on this presentation because we have some speakers who will be dealing with the discovery and the other aspects of the application of artificial intelligence in drug development. Next. Now, there are already some notable innovations in the field. Artificial intelligence and its application in clinical research. I have listed about 6 or 7 items or the products or the processes which are already existing in the market, and people are using it, adopting such practices in the way that they are conducting clinical research. I just read the names of them. The first one is decentralized clinical trials. We'll see what it means little later. Digital health tools, passive data collection. All along we are talking about active data collection in clinical trial, but we are talking about passive data collection, e-tracking of adherence, e-tracking of site visits. Then we are talking about virtual clinical trials. Without the patient, without the drug, we are doing a clinical trial, in silico clinical trials. Then automated reporting, safety reporting, pharmacovigilance, without any manual intervention, people are generating safety reports. Next. What is a decentralized clinical trial? I mean, I've already narrated the process in which we take up clinical trials, like the sponsor or CRO is generating documents, giving it to 10 sites, 20 sites, 30 sites, and the trial is conducted, data is transmitted, data management, statistics, and the report. In a decentralized setup, this has happened in COVID-19. Many vaccine trials were done in this manner. What we expect in a site may not happen in the site at all. What we expect in a site, we see a patient there sitting, we see a doctor there talking to the patient, getting informed consent, giving the drug, asking him to take it, and then asking him to visit every month, doing clinical examination, getting blood samples, doing analysis, safety, and efficacy. This is what we expect things to happen in the site. But in decentralized clinical trial, none of it will happen. There may not be even a patient visit to the site for informed consent. There may not be any doctor interacting to the patient in the site. So many things which are supposed to happen in the site will be decentralized to suit the convenience of the patient, of the environmental condition, of the doctor, of the pharma company. So this is supposed to be decentralized clinical trial, which is picking up, which has really happened in COVID-19 clinical trials. Next. For this to happen brilliantly, smartly, we need to have digital tools. which will help us in various phases of conducting clinical trials. For example, recruiting patients, enrollment of patients, randomizing, blinding, getting informed consent, providing study medications and administering study medications, outcome measures, and safety monitoring. Now, these tools are very important when we talk about decentralized clinical trials. We are moving towards application of computers and software and artificial intelligence in the way that we are conducting clinical trials. Now, this actually it is good in ensuring participant safety and research integrity. And also it does reduce the participant burden of traveling too many times, talking to too many people, and all these practical burdens are reduced in this decentralized clinical trials. It is something like, we are delivering it at the house of the patient every day. But there are concerns, ethical concerns. Without seeing the patient, can we enroll in a clinical trial? A big question mark. Digital concerns, data privacy and confidentiality, everything. They are all discussing about it. Maybe we will get better policies on this. Talking about digital health technology. I mean, this is the era of technology, digital technology. Now, this DHT is not something simply about a drug or a device or a biologic. It is more than that. It is a system which uses not simply the devices or drugs, but also it is integrating computing platforms, connectivity, software, and sensor. Everything is embedded in the technology in which a device is only a part of it, the rest of it is handled by artificial intelligence. And please remember that it also helps us in maintaining the blinding, masking the treatment. Even though we are adopting such technologies, we can still mask it. Now, one of the advantages of using DHT is that it gives the opportunity for everybody to participate in such trials. People do not have access due to travel and other things. They find it difficult to participate in trials. Now, this DHT makes everybody to volunteer to participate in clinical trials, even from remote locations, even from tribal or rural locations. People can participate in clinical trials using this DHT. Next slide. Now in COVID-19, we can appreciate many of these things have adopted in COVID-19 clinical trials. I'm sorry for the font size; it is very small. I mean, people are talking about SMS alerts and using various applications to alert. And this, I think, is readable. We can use apps, part of artificial intelligence, personalized medicine, and then telemedicine. Electronic health records and electronic medical records are part of such tools to utilize such data to get patients, and then wearable devices and sensor. Everything we consider as a digital health tool and we'll be using in, when we are applying, the key factors of artificial intelligence in clinical research. So next. Now, what is this passive data collection? Like I was saying all along in clinical trials, we say that it should be I mean, we need to actively look for the data, safety data, efficacy data. We need to see the patient, ask so many questions, check so many parameters, do so many tests. There is active data collection in a clinical trial, but people are moving towards passive data collection. Yeah. We use wearables, we use sensors, we use devices, and then we keep tracking the data which may be physiological, which may be pathological, which may be a simple vital parameter. We can interview them, we can monitor them. It is a gathering data without active participation of the subjects. Of course, we get concerned, but then patient may not be aware of the fact that we are really collecting the data. For example, you can imagine pulse rate. There is sensor. We can record the pulse rate around the clock, 24/7. We can get the trend of the pulse rate. Or we can give a schedule. Once in 4 hours, you get the pulse to me. Pulse, I'm taking it simply, so that we all can orient towards it. Blood pressure, or ECG, or any parameter for that match. We can use this passive data collection using these gadgets, which gives, it is more objective than our active data collection, which is little subjective in nature. And we can get the data only once in a week or once in a month. But using this passive data collection, you can get the data anytime that you want to measure. And it goes deep, really deep to get that information from the patients. But then there is a problem, data privacy. Anytime we can get the data, any information we need, even if it is not needed, we can get it. That it gives us a scope to collect such, data. passive data collection. Next. Then we have treatment follow-up or adherence. See, how do we ensure that the patient is compliant in taking the tablet? We give a phone call, we count the pills after they come for a visit. And in case if the patient is defaulting, we may not be able to get, we are losing it. If the patient is compliant only to 50%, then the data may not be helping us in establishing the safety or efficacy for that matter. And hence we are having something like smart pill boxes. I mean, people are using it. Even in Amazon, we can, there are seeing limited options. Smart pill boxes are available, but then with the application of artificial intelligence, we can enhance the facilities and features and like you imagine there is a box which can send an alert to the patient that today morning 9 o'clock you have to take the pill. And we may not know whether the patient is coming and taking the medicine. So it can be fixed to biometric or voice recognition. So the patient is going to present and then the box opens and gives only that medication which is blinded. And you can fix a camera there so that you see that the patient is taking the pill. You photograph and then or videograph so that it is an evidence for compliance of taking the medication. And in case if the patient is missing, you can alert at least the next door. So these are the applications of artificial intelligence in the smart pill boxes, or you have DHT for visual confirmation of compliance of taking medication. And similarly, you have e-tracking tools, simple tools in the mobile, which can facilitate, optimizing the patient's visit to the hospital. Can you imagine that there is a software, there is a tool, artificial intelligence tool that is there in the mobile phone application? It tells him that tomorrow morning you have to go to the hospital for a visit. You can book a call taxi for him tomorrow morning 8 o'clock. Patient can get into the call taxi and can get on in the hospital. The moment, it can be tracked using a GPS. The moment the patient is in the hospital, it is an alert to the investigator or CRO. There will be a reception for the patient in the clinical trial unit. Correct? And if there is a scheduled blood sample collection, the phlebotomist will have an alert, will come to the patient, collect the blood sample, does the ECG. So there is a lot of time that we can save with this. There are applications which are already available. I mean, you can imagine that Swiggy is something which is very commonly, in this 5 years, you can see how it is improving. The way that we are placing orders and receiving, it is not simply, a tool. It is an artificial intelligence inbuilt tool, Swiggy, or these mobile applications which are very amazing. So that we are trying to bring in here so that it makes our job easy. At the same time, the safety and efficacy of the drug product is not compromised. We don't lose data. This is treatment of follow-up adherence using smart gadgets or applications. Next. Then there is something called digital biomarkers. Digital biomarkers are not really novel in that sense. We don't try to invent any biomarker which is novel here. We are only trying to digitize the biomarkers which are already existing. The data that we are talking about here is objective, quantifiable, physiological, and behavioral data. We can collect using digital devices such as sensors, wearables, portables, implantables, and digestibles. Using all these, digital health tools, we can get objective data which is quantifiable, which can be physiological, which can be anything for the client. So there is no need for the patient to come specifically to give this information to a doctor. By using such tools, we can capture those information. Sitting in US, we can get this data from India, who is living in a remote place. Next. This is fascinating. I mean, the very imagination that we can do a clinical trial without a patient, without a drug is quite fascinating. When we design a drug, we know that which receptor is targeted. And we may be developing such drugs for a particular disease. You can get the information of potential participants from the databases. We have huge number of patient databases available, maybe electronic health record, maybe medical records, maybe there are several databases. We run through our screening and we can get about 100, 200, 300 potential participants. And they will have every information of their patient record. Because there is there in the EEG, baseline pulse, sugar, urea, creatinine, ECG, everything is in there. So you can select a cohort of participants who can virtually participate in this trial. Okay, and we can pull a drug, and then we can make the drug to interact with them, and then get the safety and efficacy data virtually. I mean, you can read this: a new medicinal product can be developed and tested for safety and efficacy in human beings without real human beings and without being manufacturing the drug at all. Everything is virtual, it is possible. The advantage is that with the mixed cost, we can fail it. Spending hundreds of millions of dollars, getting to know that the drug is a failure at the end of it, in phase 2 or phase 3.
Okay.
It is the pain for the sponsor, it is the pain for the CRO. So to get some early predictions on the safety and efficacy, people are talking about doing in silico clinical trials or virtual clinical trials. And drug interaction studies are possible in such virtual environments, clinical trial simulations, and imaging device evaluations. Everything is possible. It is reducing the costs and making us to play in the virtual environment rather than the real clinical trial scenario. Next. Now, these are some of the innovations which are already playing a role when we talk about artificial intelligence or machine learning in clinical research or patient retention. Think specifically about where exactly this AI is playing a role. Help in the study design, recruitment of the patients to our study, selection of the participants, optimizing the doses, treatment adherence, retention of the patients, reducing the dropouts, selection of sites. People are already using it, and of course, in clinical data management, and then safety reporting, case processing, case evaluations, and automated case submissions. Now, this is a scheme which is there existing. People who are doing or applying artificial intelligence, how they get the study design. I mean, if I have a drug and then some key parameters, they can get the design out. Even ChatGPT does it. We have a question, we have some problems, we shoot it there, it gives a solution, but that solution may not be apt for us. But these will give a solution which is very smart, which is highly applying cognitive information. It is going to give a solution. Like it has a natural language processing and a knowledge base, automated reasoning, and then machine learning. It keeps learning. We don't program it to learn. It learns on its own and then gives us predictions and evaluations and possible solutions and a protocol summary or sometimes in a full protocol without a need to vet it or correct. Next. The recruitment of participants. How do we recruit? I mean, we simply do advertisements in newspapers or in the internet or some, something we do it in our hospital to get the patients. But what we do is that there is vast amount of data available in the public domain. It's here that there are databases available, clinical trial database, trial announcements, social media database, medical literature, patient registries, cancer patient registries, orphan disease registries. Everything is available. Electronic health records. So if we want about 100 patients with hypertension, we can just do a data mining to get about 1,000, 2,000 patients of hypertension. Then we can give equal representation for variables such as gender, race, and ethnicity. We can do equitable inclusion of participants without any bias. This is possible. In future, we see that artificial intelligence will play an increasing role in matching individuals with investigational treatments. Next. Next slide. Now, artificial intelligence, with the data which is there in our clinical trial database, it can do a PK/PD predictions. I mean, we are starting the trial with 100 milligrams, assuming that it does the PK analysis, it does the PD analysis, and then it can optimize the dose. Well, 100 is too much. We have more adverse events. We can go for 75. We can go for 150. Such those optimizations are suggested by artificial intelligence. And when we include patients with liver problems, renal problems, pregnant population, pediatric population, accounting drug interactions and physiological and pathological interactions with the drug effect, we can optimize the dose, which is possible with the application of artificial intelligence. There are automated tools available to predict it. People are already developing or giving their brains to it to develop so that we can use in our routine clinical trial practice. Next. Retention of participants. The problem in doing a trial is that we enroll about 100 patients, but then we use about 20 or 30. What are the reasons? Why do we lose patients? There are two important reasons why we lose patients. One is the treatment problem. It can be an adverse event. It can be a serious adverse event. It can be a treatment failure. There is no optimal dose that the patient is receiving, and hence the patient is not happy about it, and then he is not reporting to the clinical trial, we are losing the patient. There are problems with the safety and efficacy. But then there are also genuine problems, like, the patient is finding to visit you too many times, 5 times, 10 times, 20 times. He's got his own job to do it. So he's losing his precious time. So application of artificial intelligence will help us in retaining the patients effectively and reducing the dropouts. One important aspect is that we use passive data collection to cut down the number of visits. So the patients are happy. They can do their own routine job. Still, they can be part of such clinical trials. For that, they are using tools like maybe chatbots, maybe voice assistants, maybe intelligent search. In this way, we can also capture the adverse events before they become serious. Let us say we are looking at arrhythmia as an adverse event. We are doing a cardiovascular trial, and this drug is producing supraventricular tachycardia. But the trend can be, detected even 1 day prior. We can see the heart rate is slowly increasing. Though it is a sudden and outburst of an arrhythmia, we can see the trend that this patient, the heart rate is increasing. All along it was about 80. Now it is suddenly increasing to 120. With over arrhythmia, we get a signal. We go to the patient. We do something to reduce the chance of getting into supraventricular. This is a very simple application of AI-based interventions in detecting adverse events, giving treatment, satisfying the patient, and at the same time, we can retain more number of patients in our trials. Patient retention, the role of artificial intelligence. Next, site selection again. You do data mining. You have a huge number of data available for every hospital and how many patients are enrolled in the hospital, what sort of a disease available predominantly in a particular site. Everything is available in the data. We simply need to, smartly apply our, mind, and that is where the role of artificial intelligence is coming. Big data analytics and algorithms. They used to detect a particular site with good number of patients where the doctors are very sincere. Everything you can detect and you can fix the sites. You can enroll them in your clinical site selection. Next. Now we are moving to data management, clinical data management. It involves, of course, data collection, maybe data processing, then data analysis. For data collection, we have seen it, how AI is going to influence it. It has a lot of tools, digital health tools. With that, we use such devices. It may be a smartphone connected product, or it may be a wearable, or it may be an implantable or digestible, or anything of that sort, with which we can generate objective data, which is quantifiable, longitudinal, and continuous physiological data. Everything we can collect. Once we collect it, we submit it for data cleaning. Next, we do data cleaning. Duplicate data, we can remove missing data, we can remove unrealistic data. If the pulse rate is mentioned 1000 per minute or 0 per minute, it captures on its phone, and then it highlights to us, and it also takes a decision based on the protocol. What it should be done for missing data, for highly variable data, which is not fitting into our data profile. We expect the pulse to be between, let us say, 30 and 200. But if the pulse is 1, what the machine should do? The pulse is 1000, what the machine should do? These things are inbuilt in such tools so that our job is becoming easy and we need not spend too much of time in data. And this process can be supervised or unsupervised also. And this process can be blended or unblended out. Everything is possible. A data which was unblended, the system can make it blended out. Doesn't mean that once it is an open trial, we have to keep it open always. Suddenly, at some point in time, you want to mask the treatment from the data, it is possible. Data management. Next. Analysis. We already have software applications for data management. Oracle is there. So very many software applications are available. And we already have softwares for statistics. Everything is connected to one particular platform, and then it does the stats on its own and then provides us the output without any manual intervention or the orders for the machine to start. It does everything. And it helps in silico trials also. Next. And it does the clinical endpoint assessment. Ultimately, the drug efficacy and safety is based on the clinical endpoints. Of course, there are laboratory endpoints available. There are very many endpoints available for us to make the predictions on the safety and efficacy. But clinical endpoint assessment, which may be subjective, which may be objective, or quantifiable or qualitative also, everything can be taken into this environment, and then it does analysis and provides the evidence that whether it is safe or effective, that it helps in the assessment of outcomes captured from diverse sources. It can be paper also, it can be electronic data capture also, it can be anything can be taken to this environment and can give us a solution starting from data management to data analysis and then finish up the report. Next. Safety, maybe I have a couple of slides to further discuss on how we are going to use these tools on artificial intelligence in automated safety reporting. When we talk about safety, we are talking about case report. We're talking about an adverse event. We're talking about a serious adverse event. How do we report it? Right now, we are sitting on 24 hours timelines. The doctor is sitting, getting the information, preparing the report, and then submitting it. Now, these things are automated. We have, AI tools available to do this job. Next, we're talking about individual case safety report. Next. See, we cannot simply accept any case as a case. I mean, if it is a clinical trial, there are some set parameters to consider a case when we talk about safety. Now, we are talking about the safety reporting not just in the clinical trials, but also in any case, even post-marketing phase, we are supposed to report the safety issues. So, we talk about clinical trials. There are adverse events reported in health records. There is something called spontaneous reporting. Phone calls, people can report that I have an adverse event. Emails, literature, registries, insurance claims can have data on safety, adverse event or serious adverse event. So such information can be automatically taken up to this environment in which you have a AI platform, the tool AI. And they will take it only if it is a valid case. What is a valid case? I mean, we all know it. I mean, there should be a patient who is identified, there is a drug, there is an event, and there is a reporter. If all the four are there, we say that this case can be processed because this is the case which can be reported. Next. And such cases can also be evaluated for its causality. Is there anything between the drug and event? We can do it here with artificial intelligence tools. And we can also assess the seriousness, whether it is a serious adverse event or a routine adverse event. We can do the analysis when we do case evaluation. Next. Case submission. There are two ways we submit the cases. One is individual case reports. We prepare a narration, we submit it to the agency, number one. Number two, we also submit the aggregate reports. We summarize about 3 months, 4 months, the 5 months data, and then we summarize it and then we submit it in both individual case reporting and aggregate case reporting. We are finding the role of artificial intelligence. Next. Still, there are challenges. Whatever we have been talking about is, looking like, these things are in reality. But then we need to see that there is high quality data. With the poor data, we apply artificial intelligence and we run more. And there is a problem with data privacy and the security concerns. And there are still no clear guidelines on regulatory and ethical aspects. And hence, there is a need that this should be monitored by human beings. This entire thing of application of artificial intelligence at this point in time, it needs a human-led governance and we need its accountability and then transfers. Next. So overall, we see that it helps to ease the process of clinical research. It augments the intellectual and operational aspects of the research, and it has the ability to enhance the efficiency of the clinical trial process. Long way still. We have a long way to move still, but then it is unavoidable. I mean, you see a lot of things are getting applied, and then we need to learn a lot. Then we need to adopt such changes and challenges in our routine clinical trial practice. I have taken most of this information from a US FDA discussion paper that was published I think a couple of years back. And I think I have come to the end of my presentation. I've already got a message that our chief is going to come and hence with this. I have really completed it. I start my presentation with this and I thank again the organization, the Shimurti, and the boss of the Department of Pharmacology, Savita. Dr. Trinomix, I don't think in here, but then I need to thank him, Dr. Chiru and Dr. Shana, and also my chairpersons, Dr. Kavita and Dr. Puhal, and also all the participants for your patient listening. My special thanks to Dr. When I was a student, I didn't study in Jipmer, but I see them in Tirupati and this one call I used to attend his workshop, which we conducted as a part of this one. My special thanks to you and gratitude to you, sir. With this, I think I am concluding my speech, and thank you very much. Thanks, one and all.
Yeah. So I was not sure. On videos. By one kill. No. Disturb.
சென்னை தனியா இருக்கு.
Yeah. It's coming, but that will not be taken for granted. Yeah, that's no evidence. Please, please take it. I need some of this. Camera on.
Very good morning, everyone. So I'm Dr. Abhinaya, Senior Resident in the Department of Pharmacology. So it's my pleasure to invite you all to the scientific fest MPSCON 2024. And coming together is a beginning. Keeping together is a progress, and working together is a success. It's indeed a golden opportunity to each one of us to enrich and enlighten ourselves. These 2 days will be revolving around the theme of innovations in pharmacology, bridging research, industry, and healthcare. So without any further ado, let's start session with the prayer song. For this, I like to invite Samyukta. Over to you, Samyukta.
சொல்ல சொல்ல இனிக்கு நடக்கும் முருகா. சொல்ல சொல்ல இனிக்கு நடக்கும் முருகா. உள்ளம் உன் செயலை சொல்ல சொல்ல இனிக்கு முருகா. சொல்ல
And we come to this auspicious event. It's a tradition to begin with the lighting of lamp. It's symbolizing the dispelling of darkness and ushering in knowledge and wisdom. So we are honored to have with us Chancellor Sir Dr. N.M. Vijayan Sir, Vice Principal Sir Dr. Kannan Sir, MS Sir Dr. Ponnamala Ramachivayam Sir, and Dr. Tina Thakur Sir. And I invite all of you to come forward and light the lamp to formally inaugurate today's program. Thank you, our esteemed guests, and your presence has truly brightened our event. And it's a honor to have you to join in the significant ritual, which marks the beginning of our program with hope and positivity. And it's my pleasure to invite our organizing chairman, Dr. Trinav sir, to address us, whose vision, dedication, and hard work have been instrumental in making this today's event possible. And over to you.
Good morning to one and all. It is with a great pleasure and deep sense of responsibility that I stand before you on behalf of the Department of Pharmacology to extend a warm and heartfelt welcome to this prestigious international conference. It's my distinct honor to welcome everyone gathered to MPSCON 2024. First and foremost, I wish to express my immense gratitude and offer a special welcome to our beloved Honorable Chancellor, Dr. N.M. sir. So thank you for the procedure. I welcome our esteemed Co-Chancellor, Dr. Jacob sir, and sir vision and the guidance taking our institution to a new design edge, and we are excited to on the journey, sir. We remain ever grateful for your guidance and the encouragement in making this conference a reality. I'm equally delighted to welcome our Vice Chancellor and Pro-Vice Chancellor and Richard Madam and Obstinate for dedication and development support to have the present promotion bringing the MPSCON 2024 game successor. A warm welcome extended to our beloved Dean Madam and Vice Principal Dr. sir and our Dean Mr. Academicians for our treatment. I'm very thankful to your continued guidance, sir. I'm thrilled to welcome Medical Pharmacology Society to Savitri Medical College. Your collaboration and support have greatly enriched our efforts. We look forward to continue partnership that will bring together a diverse and esteemed group of experts in person from the world. To all delegates, both faculty and postgraduates, we have who have traveled from far and near to bring us for the extend warmest welcome. Your presence here signifies the commitment to knowledge and professional growth. And I'm confident that over the next 2 years, you will learn a lot, really bring using, but also meaningful connections with the friendship. I also take this opportunity to welcome all my dear colleagues from Savitri College. Your dedication to academic excellence is to encourage you all to stay engaged and immerse yourself in the world of knowledge and being shared in the upcoming scientific sessions, sir. As we embark on this 2 days journey of learning, sharing, and collaboration, I am filled with excitement and anticipation. MPS 2024 promises to be a platform where ideas, the exchange, and innovation will be sparked all of the pursuit of advanced in field of medical pharmacology. Once again, welcome one and all for MPS Con. That will be impact on the future of the field. Thank you for being on this.
Thank you so much, sir. And as we continue with the today's program, it's time to honor and recognize the invaluable contribution of our Chancellor, Dr. N.M. Veerayan, sir, who have worked tirelessly to ensure the success of our institution and for betterment of budding doctors, demonstrating exceptional leadership, dedication, and commitment. So may I request Dr. Trinav sir to please come forward and felicitate Chancellor, sir.
Thank you, sir. Now it's my honor to invite our DMH, Dr. Raja, sir, who is instrumental and having visionary leadership. We have achieved a numerous milestones under his leadership. So I'd like to request our organizing secretary, Dr. Shrimurthy, please come forward and facilitate our game, sir. Thank you, sir. It's my privilege to invite our esteemed Vice Principal, Sir Dr. Karan, to the stage for a felicitation. Dr. Karan has been an incredible source of inspiration and guidance for all of us students at the Medical College. And I invite our organizing secretary, Dr. Sanat Naidu, for felicitation. Thank you, ma'am. Today marks a significant milestone in our conference that we are going to unveil our much anticipated conference proceeding to it deals with various countless hours of research and collaboration and dedication from our participants. So it is titled Crucial Pharmacology Trends, and I invite our esteemed Chancellor, Sir Dr. Veerayan, to the stage to unveil our conference proceeding book.
Watch out, sir. Watch out. Zoom in.
Thank you so much, sir. It is my great pleasure to invite our president for this conference, MPS conference, Dr. Shivamurthy, sir, and have a few words about what to you, sir.
Good morning, everyone. Distinguished dignitaries on the dais, founders of the organization, and dignitaries of the dais, esteemed guests, colleagues, respected speakers, and dear participants. It is with immense pride and joy that I welcome you to the MPSCON2024 International Conference. Today marks the beginning of an event that is not only a milestone in the calendar of Medical Pharmacology Society, but also a significant for the field of pharmacology in the world. We are gathered here at Pharmacology and Sarvat University, Chennai, to embark on a journey of discovery, innovation, and collaboration. First and foremost, I would like to extend my heartfelt gratitude to all speakers and participants who have joined and some of them traveled distance. Especially, I would like to mention our international delegates, Mr. Laila Kimona. She came from all the way from different countries. She traveled nearly 3 to 4 come here, and she came one day in advance and messaged me and evaluate the country. So really, and she's also our esteemed sponsor also. So she's always behind us, supporting us. So like this, we have people coming from all over India and different parts of the world. So I think it's very important for the people to think this. I would also like to express my sincere thanks to our organizing partners, senior management and the administrative staff of SciMax, and also Department of Pharmacology, Savita Medical College and SciMax, and our general sponsors who has supported us and being instrumental in life. As we stand here today, it is important for us to reflect our journey, what we have done all these days. That we got us so many points in the government reviews. We got so many programs in since last 9 years. We have done many webinars, some spectrum of topics like pharmacology, regulatory affairs, advanced therapy, good clinical practice, pharmacology, then psychopharmacology, psychiatry, or flow cytometry, clinical trials, and in addition, we also released the book which has reached all of your, you are through your registration kit, so a book on clinical trial management. And we are now embarking on another technique, that is releasing the usual pharmacology book, which is again authored by more than 2 people, and also 56 chapters are included in this. So, what is our vision for future? So we are doing so much, but we are not here to stop here. We are going to have ambitious vision. Yes, it is already relevant to the institutions. And we would like to choose pharmacology. For innovations and business. But also have new mark in the quality and scope of pharmacological studies. In addition to this, we aim to launch India's together. So you have to make this out of the using it properly. That acts use for to share your research work and showcase in the world platform. And we also aim to become several team and also on more of these centers, they will help us to conduct the research in a quality manner and also assess the safety of the products again in a staggered manner, so that we ensure that the work what we do is of quality and also safe. And we don't stop here only. We also celebrate. What do we celebrate? We recognize and celebrate the excellence. Okay, so not only as excellence in commerce of our society and mission. We have introduced the award. Those who have been outstanding contributions to our field of pharmacology, and these includes like for investing senior and young pharmacologists. And we also want to nurture talent by like new speakers, like speakers, expertise and contribute to the content like us. So we have been, what is the aim of this conference? Conference is the theme of this conference into innovations in pharmacology, research, industry, and healthcare. Fine. It reflects the evolving landscape of pharmacology and integrate in the cutting edge research, industry applications, and healthcare practices. So, in this way, this MPS is playing global news, and we also embarking on newer journeys like art, development of and global research. So MPS in the next 2 days, So MPSCON2024 will give a lot of donate for this. The pivotal role of our society, which is playing in shaping the future of the pharmacology, pharmacologists, and dedicated to provide a structured platform for career development, professional networking, workshops, seminars, and assisting research and innovation support. Our society offers numerous opportunities for growth and development and advancement. We are also committed to from which and for policies that benefit our profession. And we have also taken steps having giving our recommendations to Government of India and Drugs and Cosmetic Act when they released a newer version of it. That is the new clinical trial amendment taken 2019. So we can recommendations that they will come for consider. In addition, when we give recommendations to DNR 2021 or other you that is not the or we immediately take a note of it or also that work for press and it's also okay. The outcomes of works are related to law and our profession and keeping all of this even to government or our society. With this, I would like to conclude my comment saying that thank you so much for joining. And we crossed more than 370 institutions throughout, and our organizing secretary will give more details in the next talk when it is updated. And I would like to say that only thing I would like to say, thank you so much for giving us this opportunity in our this conference and also forward for your contributions. Thank you.
Abbreviating the problems organized.
Thank you, sir, for innovating this and its progress. We are updating the program. I'd like to introduce our Chancellor, Sir, from the University. Please share a few words with us. Over to you.
Video ಚೆನ್ನಾಗಿ ಮಾತಾಡ್ತಾರೆ.
Good morning, sir.
Very nice. Very good morning to everyone present here. And we are really happy to welcome you all for this fantastic conference organized by the Pharmacology Department of Sarita Medical College. You all know Sarita Medical College is a fairly young institution. Hardly 2008 to now, it is about 13 years old. But the achievement by Sarita Medical College is so great because the national ranking agency, Government of India, has ranked Sarita Medical College as third one in India. First one being the CMC, that is Christian Medical College, Bangalore, that is more than 150 years old. And the second one is our famous MMC, it's also more than 150 years old. Third one is Amrita, even though it is the address is in Tamil Nadu, the college is in Kerala only, Kochi. And the next one is our, compared to all these colleges, we are very, very young. But we could achieve this only because of the staff of our college who have worked very hard to bring up this institution to this level. And I am very grateful to all our staffs. And as far as research is concerned, we are number one in the field of research, medical research. And we conduct every year, we encourage the students to do all research work, which is not followed in any other college in India. And they every year they display their ability, their research works, and it is viewed by many teachers and professors from outside, and they all appreciate very much on the work done by the undergraduate, because nobody believes that an undergraduate can do this much of work. The standard is so high that it is very hard to believe that it is done by an undergraduate student. Therefore, as MPS promoting you mentioning, we are very happy to associate with them to promote medical research. Research is our breath. We encourage all our students to do research work. And this year alone, our medical college has crossed more than 1,000 publications so far. This is the 10,000 plus publications by the students and faculty of our college. Therefore, research is our breath. Therefore, we will be very happy to associate with you to do all research work. And we will be happy because this is an institution for the benefit of the student. Only one thing I want to tell, our medical college is not run for any profit or any funds. Everything is thrown back into the college itself. The people who are working with us know when we start, how was it? Now it is how much it has been improved, and what are all the new things, innovative things, and what comfort student needs without even they expect. We provide them all the comforts. That is our main motto. Our aim is to have a best medical college in the country. We are working towards that. I hope within another 2-3 years, we will be reaching that level, I think, by God's grace. Thank you very much. Indeed, you have a very memorable memories. There is this time on your life. Thank you very much.
Thank you so much, sir, for sharing your experience with us. Now I'd like to call upon Shah to share our
I would request all the participants, the delegates, to stay back. Though we are giving the vote of thanks, but the program will continue as our Chancellor Sir has a very tight schedule. So we are abbreviating the program for his presence, and we are very grateful, sir. So Honorable Chancellor Sir, Pro Chancellor Sir, Dean Madam, Vice Principal Sir, DMS Sir, distinguished guests, respected dignitaries, and dear colleagues. It's my honor and privilege to deliver the vote of thanks for MPSCON2024. This conference over the next one day, today half day is already over, and tomorrow is going to be, we anticipate it's going to be a resounding success, and it is only fitting that we acknowledge the contributions of all those who have made it. First and foremost, I would like to express our deepest gratitude to the Chancellor Sir and Pro Chancellor Sir. Your unwavering support, vision, and leadership have been instrumental in making this event a reality. We are deeply appreciative of the encouragement and the guidance that you have provided us with, sir, throughout the planning and execution of the conference. And in spite of your very tight schedule, you have graced this occasion. Thank you so much, sir. A heartfelt thank goes to the Vice Chancellor, Pro Vice Chancellor, Registrar, Dean of Accreditation and International Affairs of Savita Institute of Medical and Technical Sciences, CMAS, for the continued dedication and in fostering academic excellence with for this particular event. Grateful thanks to our beloved Dean Ma'am. She is not here for some professional reason, and the Vice Principal, sir, for continuous motivation and guidance. I would also like to acknowledge the Associate Dean of Planning and Development at CMAX for his strategic input and facilitating the seamless coordination of this event. Your role has been crucial in ensuring that everything comes together as planned. We are grateful very much to the Medical Pharmacologist Society for their collaboration and support. Your partnership has been invaluable in bringing together a diverse and esteemed group of experts and participants from all over the world. As Sir had already mentioned, we had 3 international speakers and many more national from all over India. I would also like to extend my sincere thanks to our HOD, Sir, the faculty and members of organizing team of our department, without whom this event would not at all have been possible. I'm extremely grateful for their commitment. A special mention should be made of the chairperson, secretary, members of the scientific committee of MPS, whose expertise and guidance ensured that the content of MPSCON was of the highest caliber. We owe a debt of gratitude to our IT, housekeeping, and logistic security staff worked tirelessly behind the scenes to ensure that all the technical and logistic aspects of the conference was flawless. Thank you very much. Finally, I would like to thank all our distinguished speakers, presenters, and delegates for their invaluable contribution. Your presence and active engagement has made MPSCON 2024 a truly memorable and meaningful experience. As we conclude, I am filled with a sense of pride and accomplishment for what we are going to achieve together. Let us carry forward the knowledge, insights, and connection that we have gained here and continue to advance the field of pharmacology for the betterment of global health. Thank you so much.
Thank you, ma'am. So we are now at a very special moment in our program. It is our immense pride and admiration that we recognize an individual who have been extraordinary contribution to the field of pharmacology. Please join me in welcoming to the stage Dr. Ravindran, who will be honored with the Lifetime Achievement Award. This prestigious award fulfills Dr. Ravindran's dedicated, relentless pursuit of excellence and significant impact in the field of pharmacology. Let us give warm round of applause as we invite his wonderful for the nation to the May I invite our esteemed Chancellor sir to come forward and facilitate the award.
What is that? Yes.
Thank you, sir. Now I request Dr. Ravindran to share his journey with us. The children is here.
Once again, good morning, everyone. What all I wanted to say about the achievements. Morning, I gave a talk for half an hour. Nothing more to say. Thing I'd like to say is I thank very much. I would like to thank Savidan Medical College and as well as MPS for inviting me or giving me this award. Very happy that I got this award. Thank you very much. So much that involved. Yes.
Thank you so much, sir.
Yeah. Thank you very much. So, thank you. Even the observer. Like,
Thank you so much for inviting. I'd like to extend our sincere thanks to our sponsors for this event. IQ training and Medibase, spin-offs life sciences and research. I'd like to extend thanks to the first sponsor for this event, IQ training and Medibase. I'd like to call the sponsor, IQ training and Medibase to the stage.
என்ன பண்ணாதுடா பிளாக் மேஜிக்ல ஆன்ல தான் இருக்கு ஆன்ல தான் இருக்கு இருக்கு கண்டெல்லாம் இருக்கு வீடியோ ஆடியோவா வீடியோ இருக்கு வீடியோ ஆடியோ இருக்கு போயிட்டு வா போயிட்டு
I'd like to call upon the next sponsors, finance, life science and research. Thank you. I'd like to call upon next sponsor, SciMed Scientific University. Instrument is not there. It was a sponsor, Samruddhi Elite Educator. Mr. Raghu. Mr. Raghu. Samruddhi Elite Educator.
Camera video வேணும் இந்த வீடியோட இந்த மாதிரி இந்த வீடியோ சரி க்ளோஸ் பண்ணிடுவா
Thank you. We like to invite our next sponsor,
அப்படியா சொன்ன ரெண்டா தெரியும் Oh, okay. Fine. Okay. Thank you very much. That's very, very good. It is fine. It is fine. It is fine. Yes, no, I'm going to it'll be bit change. Madam, it's not yet for me. Output is output.
I'm leaving.
So, correct. Because
Please sit down.
class up. 1:30. சாப்பிடணுமா?
Start.
விட்டுருங்க இப்போ ஸ்பீக்கர்ஸ்ல இது மட்டும் போடுங்க ஸ்பீக்கர்ஸ்ல இது
Thank you all for your patient waiting. Right now, I request our chairperson, Dr. Kantaman, to introduce our next feature for the event.
I'd like to invite Dr. Laila Teresa Contessa. He is the founder and CEO of Medical Division and founder of CEO of IPA Training Limited. And she is an advocate and entrepreneur, and she has started this career in 1970s.
How are you doing? You put any music on, sound or anything?
She has another one.
There's a gel on, no sound on it.
Life course racing course, and she's a philanthropist and founder in charities to empower women and support children with patient deformities. And she has founded Pan-India Directories and became a certified master coach and trained staff at companies like IBM and Infosys. And she has developed a social gentleman course and taught business English in and also led scale development on Tata FICA 2022, explored clean VR and blockchain and developed IR and virtual reality trading tools. And she is a a founder of Medical to address global health disparities using training project.
Yes.
And she has written global development, and we invite her as a speaker for the Global Partnership in AI Summit, Delhi 2022. On the Honorable Prime Minister of India, Mr. Modi. I'd like to invite you now to deliver a talk on the topic artificial intelligence in clinical pharmacy, clinical therapeutics, and its legal implications. Over to you, ma'am. Thank you.
Sharing is not. She wants to have the video first. She wants to have a video first. Online, you can share, no? Yes, people.
I'm sorry.
Can you share?
Good. It's not my fault.
Share.
Okay.
Share.
Can you explain it?
Just wait. Stop the video. And the video on for last time yesterday.
My name is Lina, as in Indian Lina, and I'm the CEO of two companies. One is called Medibank, which builds and has designed the first smart diagnostic and telehealth clinic in the world. Okay, there's lots of things going on with that. We're not in India yet, but we'll be soon, and you'll get to hear about us.
Yes, sir.
No? Okay, they're not working yet. I am also CEO of IQ Training, and IQ Training uses virtual reality
Sharing, sir.
and artificial intelligence to deliver
This much, please.
immersive and mixed media training to the pharmaceutical and medical professions. Okay? How are we doing? You can zap that along a bit. And does anybody keep you first? I can't hear you. No?
The player.
He's the father of medicine. So he's the father of pharmacy and the father of medicine. Okay? And we did have him here in AI4, but I don't think we're going to get him. Can we do the presentation then?
Sure.
We'll just go straight to the presentation.
No.
So just bear with us. We'll put the presentation screen up. I hope.
Yeah, we ended up orange shots. Yeah.
We are based not only in the UK, but also in Italy, and you'll also be speaking and hearing from my co-director, Professor Federico Bacchetti, who is professor at Bologna University in Italy. You know, Bologna, have you heard of Bologna University? It also has an amazing medical college, rather like here. And his expertise is in artificial intelligence, machine automation, robotics, and everything tech. I'm sorry, this didn't work very well for me because it's really heavy. So we're going to be talking about artificial intelligence in clinical pharmacy, clinical therapeutics, and legal implications.
Okay.
Oh, is that easier? Yeah. Okay. So AI in clinical pharmacy. So we're looking at automation of routine tasks. So do you understand what we mean by routine tasks? Hello?
Yes.
Yeah? Yes? Okay. So we're looking at automation of routine tasks, medication management. Yeah? You know what that means? So we look at patients, how they're monitoring, how we deal with their medication. Do I have your attention? Hello? Yeah? Thank you. We have enhanced patient engagement and personalised medicine. So you're all pharmacy students, yeah? Speak to me. What kind of students are you? What are you studying? Can't hear you. Okay. So we're looking at personalised medicine, and when we talk about personalised medicine, we can use AI to determine medications that are suitable. We can use AI to determine what's actually in those medications. So the next slide is AI is improving drug discovery. Do you all understand what AI is? What artificial intelligence actually is? Hello. I feel like I'm speaking to myself today. Do you understand what artificial intelligence is? Yes? You understand that artificial intelligence is rather like a child, and it can only learn and start to learn what you teach it. So if you teach it rubbish, it will learn rubbish. If you teach it, hello? If you teach it the good stuff, then it will continue to learn. And from what it learns and all the information that comes into it, it continues to learn from that information. In America, there is a totally useless use of a robot who has artificial intelligence. And what they've done is they've taught it to slap people. And there's a slapping competition. You can see it on TikTok or whatever. So they taught right to slap a person. So the person, there's a competition, the person slaps the robot, and the robot slaps the person back. So who do you think wins? I know who I would go with. So lost. Hello. So we've got improved drug discovery, we've got clinical trials, and Dr. Aaron spoke about clinical trials before, so I hope you followed him. And we have predictive analytics and also skilling, and we're going to talk about skilling a little bit later on. Okay, next slide. Right. This here is a list of the top companies around the world that have been using artificial intelligence to, in these different ways, to give pharma and medicine the advantage. And again, Dr. mentioned it before. We're just going to go into it in a little more detail. So in pharma, the top elements are artificial intelligence. We also have big data and analytics. We have flexible production, precision medicine, additive manufacturing, curative therapies, digital therapeutics, real-world data, extended reality and blockchain. And all those companies on the outside are from around the world and are the top companies that are producing solutions using these techniques. And just for an example.
Next slide, ma'am.
Okay, we've got 21% using artificial intelligence, and we've got all these other ones, 15%, big data, flexible production, 13%, and different percentages for all the different ones. Do you agree that only 21% currently use artificial intelligence? in pharmaceuticals. Would you agree that? No, neither would I, but apparently this is what I'm told. But in the next slide, the market growth of this is, if you look at global AI, the pharmaceutical market, it's going to be reaching 28.2% before 2030. Do you believe that that is the only percentage of the current market it will reach? Or do you think it's going to make more? Yeah? What do you think?
No, everywhere AI only, so it will grow like anything.
Yeah.
Everywhere.
So you need to understand, if you are involved in medicine, if you're involved in pharmaceuticals, you need to understand and be using current technology in artificial intelligence and all the other ones that are listed, so that you can compete against everybody else for jobs. Okay? You have to be able to understand how you're going to use this technology, what it is, what it helps. So the market segments, cloud-based, on-premise. Okay, do you know what that means? Hello? No, all right. End user, biotech companies, CROs, academic research institutions. You need to understand, and I hope you're going to go away and start looking things up, because this is going to open your eyes to the future, and the future is unlimited. Okay? You are of an age, both of you, to be able to really suck in all of this information and to be able to use it. If you're working in medicine and pharmaceuticals, you're doing it maybe for money, but a lot more people are doing it because it will improve society. It will improve the lives of millions, billions of people. And if you don't understand what's happening in the market, as much as you want to do medicine, you will not be competitive, and worst of all, you will not give people that need your help that option. Yeah. So, just like an example, I'm sorry, this is really heavy. Just for the next example, today, come today. No. Okay. I'm going to speak loudly, so I hope you can hear me. Oh, it's another one. Okay. Company. Okay. Paid by chalk lights. Okay. So, they based in the UK called Pangea Data. It's a startup company. That means it's a brand new company. A startup company deals in specializing in unsupervised AI algorithms and all this. So they identify that what they're designed to do is identify patient cohorts for drug discovery, clinical trials, and real-world evidence studies. So it scans electronic health records and unstructured doctor's notes. You know, in this country, you get your doctor's note, and it's all written by hand. There are now apps that come in using artificial intelligence that can read that terrible handwriting and put it straight on to the patient's medical record, so that when they come to the pharmacist, there's no confusion about what medication they're supposed to get, how, when, and how, and where. So this company uses this to find the right patients based on phenotypes. And it develops a library of AI models for these particular diseases. Next. A Canadian startup, Valence Discovery, again focused on algorithms for drug discovery. Then on to drug discovery, and their key benefits, again, deep learning solutions. And they can predict and optimize potential drug candidates. We need to be able to identify drug candidates, suitable drug candidates, okay? Because otherwise, the millions and billions that are spent are a waste of money. Sorry, next. Okay, so we're looking at big data. These are all companies and what they're doing. Flexible production, precision medicine, advanced manufacturing. Next one. Real world data, blockchain, and extended reality. I'm through all that because I can see people leaving and I don't want to lose you. So we'll carry on. And this here shows the data, the real world data. Do you understand what real world data is? Yeah? No? Anybody there? Yeah? You guys, do you understand what real world data is? Okay, talk to myself again. Do you understand what real world data is? Up at the top there. Do you understand what real world data is? Okay, well look at this. This here shows what goes in to develop real world data, which is data that is collected about you from your doctor, or these different ways, whether it's consumer data, disease registry, even if you make a claim on your insurance. Okay? This real data, and the value is money, and the value is benefit to developing drugs, medicine, operators. Next slide, please. So this is real world data strategy, okay? And this is how AI pulls out that real data. Again, I'm not going to go into real data because I keep losing people. But this will be available to you. I suggest you read it. Next slide. Okay. We have there are two different ones. Okay. So one is the information that we get, and the other one is real world data. So RWE is when we pull out this information using that previous. So we pull out that information. And it gives us a summary of what we can use either in medicine, operation, or medicine. Next one, please. This is me. This is Fred, who you'll hear from. Not quite sure what time because I suspect you're all going to go off now. We provide this kind of training, which is essential. Next slide, please. So I put it here so that you understand and you start to understand what AI is, how you are going to be affected by everything that has happened technically now. So you've got virtual reality, fully immersive, computer-generated environment. It's not real. Does anybody here use gaming? Yeah. Do any of you young people use gaming? Do you use VR glasses? No. Have you ever seen them or worn any? Yes. Yes? Okay. My company creates, we design, and we build the virtual reality that means that you can go into a live scenario, experience emotions. We can even make you feel emotions. We can make you upset somebody or not. We can get you giving injections. We can get you looking at DNA as if it's in the real world. You can touch it, you can move it, you can feel it. This means what? It means that you can do things without killing anybody. It means that you can do things within your own world that you can do on your own or in a group. You can do anytime you want. And this kind of retention from this kind of training is recorded at around 75 to 82% in comparison to face-to-face conversation or teaching online. Get used to it, because this is what's happening in medical education. We even run technology so that operations can be taught to doctors without them actually having a real patient in front of them, and they can practice, they can investigate the technique, and they don't have to do it in hospital time or school time or hurt anybody, and the costs are considerably less. So we have mixed reality training. So we can, what happens with that is you have a mixture of the real world working with the world that we built for you. Next one, please.
That for me is coming.
So we've gone through why do we need it? It's the oral, the aim of the day, create a better foods.
Audio works out.
No.
So usually the one system.
Legal and ethical implications. These are very simple. Next one. Next one. Okay, regulatory challenges. Well, they're very simple. You'll find them in the legal book. They're all listed there. Data privacy and security. Make sure that your personal details don't go wandering on some insurance company to phone you or anybody else, and that your identity isn't taken. So transparency, accountability, and liability. And the ethical considerations in decision making, potential for bias in AI, transparency, accountability. AI, if you're using these things, has to be accountable. If you use it and you use it in the wrong way, you have to be accountable. And around the world right now is preparing lots of laws. Looks like I've lost most of you. Okay, so the conclusion, guys, you're going to miss this. Bye. The conclusion is a collaboration between researchers. Our collaboration, our talking, your attendance. When you talk about an issue, then you can clearly take in other people's worries. Terrified when they look at artificial intelligence. First thing, they're terrified they're going to lose their job. Right? Now, one of the things that was discussed, one of the things was discussed was pharma dispensing. We actually have a machine that automatically takes or paper prescription, puts them through the machine, and we blister pack medication and spit it out the other end so the patient can collect it in about 30 minutes. Okay? Tech is happening, you need to understand it. Thank you very much. I'm sorry it was a lot briefer than I thought it might be. Thank you very much for your attention. Maybe next. Thank you. Thank you, ma'am, for the highly informative session and very engaging. And thank you for so even though we've been using AI and machine learning in every field, the part of our life. So many of us is a gray area. So it's our professional future. But anyway, just as an eye opener to everyone of you, how you come. Virtual reality, medical education, and the poverty, etc. Thank you. Teachers.
Thank you. Chairperson, can you give a yeah, I think you done the way. Please correct the moment. So give a moment for speaking.
Thank you.
I'd like to invite our chairperson, Dr. Pugal, sir.
Okay. Now we'll play the video.
Which video, sir? Sure.
Good afternoon, everyone.
Which video, sir?
Good afternoon, everyone.
Fred's video.
Good afternoon.
This one, yes. Fred.
So, the next
Professor Bhatti, he Go Business School specializes in big data for Industry 4.0, advocating for technology role in futurism, ESG, and greater societal good. He is the CEO of Essential AI, expert in AI, ML, RPA, and cloud, transforming business automation, focus on natural language processing and sentiment analysis. He is a member of Altia Federation, engaged in consulting, integration, and business model disruption. He is the global technical director for Medivale Limited as well as IQ Training Limited. Over 25 years of experience in leading the digital transformation, shaping future strategies, and turning innovative ideas with impactful projects. Fred blends academic brilliance with entrepreneurial insight, driving AI evolution for enhanced efficiency and business growth. So he has a very good academic and history as a leader. So over to you, Professor. He is connected online.
Just we'll try coordinate.
Yeah.
Just give us a minute.
Trying to connect over the Zoom.
Sorry, sir. Can't out, sir. It's fine.
It's already connected.
Hello.
Oh, connected.
Hello. Hello, Dr. Fred. Can yeah, Dr. Fred, I wanted to know, are you able to log in? Actually, there is a mail you might have received, right? Reminder page in the mail. Yeah. Now, can you exit? Can you exit the meeting? Go to your email ID. In that, there is a reminder. There is a reminder, is there? Check maybe this for spam folder or something. Reminder to join the panel discussion or something. Is it there? Yeah. Is it there? Okay. Okay, I'll just forward the one mail to you. So can you click on that? Yeah.
Devada. What do you have? I'm learning now.
Hello. Yeah. I just send you one mail. Just send you. Just check. It is from MPS ID. Is it refreshing?
Oh, okay. Oh, you sound.
Did you get my email? Emails? MD Pharmacologist.
So there are 2 or 3 sessions that are some terminology, artificial intelligence, machine learning. Okay, is it new or old?
Yeah, I just sent you.
Whether the nouns change, the terminology have changed or it is a new concept. New concept, sure. See, most of our most of the clinical research what Arun was discussing. So almost during the time of COVID, we have implemented everything. Okay, and we have never termed exactly it is a data analytic or artificial intelligence, but maximum. Sir, I'm just filling the gap. Okay, I will they will feel good. Okay. So whatever we have done early, it is little a modification, a version only. And if you're looking into it, artificial intelligence or machine learning or supervised learning, because all these things in last 1 month I was keep on checking the YouTube and learning by myself. Okay, it is as easy as it is because we are actually choose the software or whatever the problem statement is you have to design the problem statement and what is your expected outcome also you should anticipate. Okay, then only we can able to develop a algorithm accordingly. So it is like artificial brain waves. You're able to now see. It is not totally going to replace human brain. Okay, good. Johnny.
Okay.
So both the problem statement as well as the expected outcome you are going to provide and how fast, but how clarity, how precisely you want. That is what you will provide the expected outcome. Prediction. Okay, prediction. So because there are certain challenges, most of the speakers at the end they will be speaking about certain challenges. That is the area where the human brain actually comes. Okay.
Okay. Oh, you are not able to present, not able to voice. So can I use your output in the mic to project it here? Or I will just is that possible? Because in the phone itself, I can allow it to wipe out. Yeah.
Okay. Next thing which we can discuss is how far we are away from artificial intelligence to be strongly implemented in India. Very close. Okay.
maximum like 30 to 40% of most of the corporate sector, they have already implemented. But the lacunae or deficiency is seen in most of the government setups, actually. The government of India is taking lots of initiatives, but implementation at the level of government, like for example, health informatics, all the demographic detail is, for example, in AIDS, 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 Raipur. So those areas it has entered. Okay. Regarding a few of the things are in trial basis only. Whatever they claim that they have came with a solution, because I was working in this field during the time of COVID, most of the AI was not successful. Okay. So finally they relied on the data of the human being only. We are at the stage of implementing making precision. These are the various areas like drug development, research speaking about the clinical trial management by support from the AI. They are they have entered into the market. They have entered into most of the corporate hospitals. And in government setup also, like 50% of the principal institutions are very much interested in taking them. And recently I read one of the trial, a digital twin that was another important area. Okay, it's a very good Indian with IIT Chennai and a few of the other institutes like in India, they have came up with a digital twinning for the management protocol of hypertension. That was very good actually. So there are areas are coming. The interest of the principal investigator is there, and whatever the interaction I have with the people who is involved in this AI problem statement and what is your expected variable, you should be very much clear. Otherwise, because you are training a brain. Okay, if you are not going to give a problem statement and you are giving a n number of, because there is also supervised machine learning, supervised machine learning. So anything unsupervised cluster it will be. That may not be our outcome. So these are the few things, patchy information which I gathered over this last 6 months in this artificial intelligence. And my request is for all of you. Because we are looking at the presentations, the implication part they have stored here. Algorithm they are showing. Okay. Whichever which is going to fit your area. Okay.
You want the link? This is the app now. It is open.
How are you connecting with Fred? How are you connecting with the professor?
The one who is speaking online.
He's connecting through his phone.
They're talking. No, I don't know how he's connecting, but he's trying to connect.
Because there's nothing on there. Fred.
He's trying to connect it to some.
So that is a maintain point because
just allow it.
Last 6 months we were like looking into the data structure, what are the possibilities, where are the areas because our area will be nothing only. But still, why I want to stress on the fact is we are commonly saying that there are areas. Okay, how much data is with our PVPA? Okay, that's data. Why we are not getting that? Because the team is not fully infused. Okay, but the recording system and the AI is not implemented. Okay, because there are commerce area where we have to implement because now also majority of the institutes they are not giving a maximum area reporting. So there are certain areas we have to look into it, and these areas are coming with the problem statement because these technical people are there. They will be possibly collaborating. They will be giving with their solution of our expectation. Okay, just to create some idea, just to create a problem statement and try to look. That is what the main thing with the AI. Whatever I know, I am not an expert. I am just a gap filling the gap.
Hello. Okay. Can you hear me?
Yes, we can hear you.
Okay, I can
Okay,
close.
I'll switch off the phone. Okay.
Okay, thanks.
Yes, sir. He's now online.
So hello.
Good afternoon, sir.
Professor Federico.
Yes, speaking. Good afternoon, everybody. So I can show even my face if I'm able to do so. I'm sorry for the technical issues, but I wasn't able to open the audio and video. So I guess that you are hear me now.
Yes, we can hear you.
Okay, great. So I got a message. I cannot show my video because maybe somebody has to
Stop presentation. Right?
Sure. Can we keep this?
Yes, now you can present.
Now you can share your screen and you can present, sir.
Okay, but I cannot open my camera. No problem if you don't want to see my face, but just to show my.
Share the screen. Share the screen, not the PPT. Okay.
Okay. Okay, just second.
Share the
Okay.
screen.
Yeah, I'm coming.
Yeah.
Share. Okay, screen.
Share screen. Then open the PPT.
Yes, of no combat. Screen share conference. ಅಲ್ಲಿ ಮೀಟ್ ಅದು ಆನ್ ಆಗತ್ತೆ ಇಲ್ಲ ಇಲ್ಲಿದೆ ಆನ್ ಒಂದು ಲ್ಯಾಪ್ಟಾಪ್ ನೋಡಿ ಆಡಿಯೋ ಆಲ್ಸೋ ಫುಲ್ this one what is that? This one is the some microphone that is a microphone. Okay.
Fred, you're able to show the PPT? Hello?
Hello. I think he's not just long.
Hello?
Yes, log. Fred, we can hear you.
Okay. You can hear me
Okay.
now. I don't know what happened. So I'm sharing my screen.
Yeah, click on share.
Yeah.
Click on screen.
Yes.
And then share.
Okay, share.
Okay. And then open the PPT. Yes, we are able to see you. See your
Okay,
PPT.
great. Wow.
Yeah, then you can do the screen show. That's the slideshow.
Thank you very much. Thank you. So
yeah, please click on the slideshow.
Great. Okay.
Thank you. Now you are ready to go.
Okay, thank you very much for your patience, guys.
Thank you so much.
I'm very happy to be here. I'm sorry for the delay for technical reasons. So my name is Federico Baffetti.
Say it like this.
I'm from Italy. And I'm very honored to be here. And I thank the organizers, Dr. Murthy, and everybody who has been working to set up this conference. And thank you to Miss Laila, who is my partner and very great visionary founder of the companies that we are working on some very interesting product that she has been talking in the previous speech. So I'm going to let's say add some piece of details about what artificial intelligence can do in drug development. Just before starting with this, I don't want you to read everything on these slides, so you'll have the materials to read about myself, but just a few words about the hashtags in the upper left corner of the slide, just to give you highlights about my specialization in the technology, exponential technologies, which are driving innovation in every aspects of our day-by-day life, but also in business. So I've been working a lot on innovation and in healthcare. I've been specializing in the usage of such exponential technologies like AI, blockchain, cloud computing, robotics, automation, to improve the way people are living their own lives, but also to help the technical people or the specialists like yourselves in the healthcare area and market to work better, to work to improve their own efficiency and efficacy on their own jobs. So there are a couple of hashtags at the very end of this box, which are very important to me, and they are work-life balance, which means that every technology should be as much invisible and effective as possible to improve our lives and work and job in every aspect that is possible. And the second thing, which is very important to our project that Laila mentioned, which is Medibay project, which is a smart clinics project, is the user experience, which needs to be the most human as possible. So a very quick introduction. So just to recap everything that was has been said before my speech, which is what is AI about? AI is about AI is about data. Data is the main thing that we need to keep in mind when we design AI-enabled products or services. So speaking as a technician, as a technical person, as a professor teaching AI to my students, I usually say that data means to be understood firstly. First of all, we don't need to be able to be clever in writing good code snippets or code programs, but we need to understand what is behind data. So domain is important. The first thing to do is to understand what is the, let's say, business or the overall goal of these data. So what we need to do first before starting and using AI for healthcare is understanding what types in the very details, what types of domains of those healthcare data we are going to handle and to use to train the algorithms, the models that we are going then to use into our products. So what Laila said before is be careful, because if you put garbage into the algorithm, you will get garbage outcomes. So the algorithm wouldn't be of any help to yourself, or actually it could even be worse, because it could give you wrong information, wrong hints, wrong details. So that is the main important part within my job, which is developing solutions based on AI in the healthcare system. The main important thing to think is spending a lot of time in understanding what data we are going to use. So then data are going to be cleaned, to be used for the first trial and algorithm candidates. And then we need to perform a lot of work with yourself, with the special people, with the let's say process owner people, to check if the algorithm is giving us actually some good results, or we need to go a step back and then restart with new data, or maybe improve the cleaning of those data. So this is just a very, very rough and quick and a high-level introduction about how we create algorithms in general, of course, in the AI process, development process, but also with a very, very tight and approach with a very, very strict checks on data when we talk about healthcare. So what is about what can do AI to the healthcare sector? So the first thing is, which is actually is not a very it's not such a new approach, which because we have been experiencing, and I've been working with some pharmaceutical and healthcare company in the past 10 years for applying AI into the discovery and drug discovery and drug creation process. The main thing is that we can leverage on generative AI. Nowadays, it's a couple of that we've been talking about, ChatGPT and all these type of generative AI services that can enable you to create new content. So before ChatGPT and all the hype that we are experiencing nowadays, there were generative adversarial networks, which were some very specialized types of neural networks, which are a very specific type of AI that were able to create new data from existing data. So there were some very big pharma companies in the let's say 10 years ago, around 10 years ago, that were already working on this approach. So using generative adversarial networks, the acronym was GAN, the GAN networks, for the creation of new drugs. Of course, this was the beginning, and but there were lots of big projects, and we'll see later on in my slides some examples, some references, which were due to create new drugs, to experiment and to simulate the expected results of the drugs onto patients. So this is the main part that we are going to discuss now. But also, AI can also transform the services provided by the healthcare systems, of course, by enhancing privacy. Laila mentioned something about this. Even, let's say, automate the workforce day-by-day tasks. So helping you as a technician, as a doctor, as a physician to have, let's say, summarized some, or even propose some drugs to prescribe to your patients. Or let's say even AI can be used for skilling purposes, or for training purposes, for accessibility, or etc., etc. And also AI can be used on medical device. Well, it is already being used within medical devices and in diagnostics to elaborate huge amount of data. Let's say we are talking about big data since 2005, 2006, to have a very summarized and quick and summary of this data coming from machines like testing machines or medical devices, or from imaging data coming from X-rays, or etc., etc. But also AI can be used for diagnostic. There are lots of usage of computer vision with the AI infused to detect within images coming from X-rays or other, let's say, devices equipped with cameras to understand what's inside the image. For instance, you can leverage on some, let's say, wound viewer to you just have some kind of a handheld iPad, which is put onto the wound, and you can see the image, and in real time AI is able to detect if there are some something which needs to be cured with some treatments, or even to detect some proofs of or let's say some clues that bring you to suspect about some tumors or something which is not good within your blood.
Super.
So back to the pharmaceutical and drugs treatment and drugs creation, we are going to have a look at some data and some information about the pharmacovigilance. Sorry. But before proceeding, I would like to point out what is pharmacovigilance. There is, let's say, a science or a discipline which is related to the detection and the understanding and prevention of the adverse drug events, which are named like AEs, right? So pharmacovigilance is very important in the drug development process because, of course, we need to be able to understand how a drug is working on patients. And of course, this needs a lot of data to be understood. Then there are, of course, the main topic, the main issue here is, of course, safety, right? To observe what are the trends in the application of drugs to patients, given the AEs caused by that specific drug. So there is, let's say, a few words about statistics about drug development. What is about AI in drug development? This chart shows you what part of the typical topics of AI are impacting drug development. So there is around 1/3 on predictive analysis, so to understand how the drug is going to impact the patient. There is, of course, even automation, which needs to be, let's say, addressed for complex procedures for application of drugs, and so and also the data analysis about those procedures. And also another third of the pie is about reducing human error. Again, AI can be thought as a means to improve the day-by-day tasks that we are used to do into our day-by-day job, right? So, and this applies to every part of the business, and in the healthcare, in your day-by-day work, of course, there are lots of tasks that can be seen as repetitive, not of so high value, and AI can do some part of that job, right? So now I have pointed out some cases, some actual cases with the reference that you can find in the lower part of the slides. So you will be able to even to go into more details about the cases. But this is just to mention some startups and some enterprises. So very, very big companies now, like in silico medicine, for instance, which is an Hong Kong-based pharmaceutical company. And they have developed their own AI platform for pharma, which is called pharma.ai. You can also check onto the website pharma.ai, which is a very, very powerful platform for doing a lot of things. But they started with the main topic that was to identify potential drug candidates very quickly. So to experiment new creations, new type of drugs, and then even to simulate the application of those new drugs that were like the kind of virtual drugs. What is the impact? What was and what is the impact on some type of different patients? So patients can also be clustered within different types of, let's say, group. So you can decide, you can check if you want to test this virtual drug onto some, let's say, Black people or maybe young people or women instead of men, etc., etc. So this is a very, very powerful platform, which is used by the company to perform lots of their job, and they have taken a very big competitive value on this. So what is the possibility of sorry for this. Okay. So how can the AI be used in predicting efficacy in different stages? So AI can be used during the product development cycle, so to create anonymized and also synthetic data. So if you don't have lots of data starting from your own private data, you can create some and simulate the patient level synthetic data. Then you can also, AI can also combine historical clinical trial databases with by applying AI or machine learning techniques for access to very specific insights that can help you decide and define your product details. Then you can also use, we can also use AI during the clinical trial of the drugs. So that people and doctors and technical peoples, technicians and physicians can also better decide, better understand how the drug is working, and also to inform the site selection, population selection, and understand how the drug is working on different clusters of your population. And then you can also use AI to create, by leveraging on generative AI to create new trial protocols, and also demonstrate comparative efficacy between clusters and populations. Then we can also use AI for prescription of drugs, right? So understanding and having data on behavior of our patients, we can also have AI give some suggestions on how, what, and when to prescribe those drugs, which is a very typical usage within our specific services that we are talking about, which is Medibay, which is a smart clinic where we can also we can gather all data from our patients and understand their typical behavior and then the typical response to drugs, and then decide on top of that how to prescribe the new drugs for the future. And finally, also, again, we can use, we already are using medical devices and in diagnostics, such as the ones that I mentioned before. So computer vision, but also analyzing huge amount of data that are invisible or too heavy to process by the human eyes or human mind. So very faster and effective data analytics, right? So data-driven, accurate decision can be taken by humans, so doctors, physicians, etc., etc. And also we can work with VR, virtual reality, and augmented reality, like we are doing with IQ training, for people to leverage on AI infused within some applications that enables people, doctors, to equip with the smart viewer to understand exactly what is happening within a process that they have to learn about. So having some VR augmented training is very helpful and is very quickly, because everybody is able to study on books. But if you can experience things by putting your hands on something which is virtual, but is immediately viewable by with your eyes, is more and more efficient. So another case study about Atomwise, which has been working on a specific task for modeling, molecular modeling, to predict how the behavior of small molecules and proteins. And this has been used by Atomwise, again, creating their own AI platform with some technology investments, of course, to expedite the compound identification process. Just a few words about another very important case, which happened around 15 to 20 years ago, let's say between 2008 and 2017. In the States, FDA approved hundreds of new drugs, 321 precisely, to be precise. And over the period between 2008 and 2017, FDA Adverse Event Reporting System, which is a specific program to record and report the AE events, recorded more than 10 million AE reports, which is a huge amount of AEs, right? Of course, related to these new drugs. And within these 10 million reports, almost 6 million were serious reports, and more than 1 million were related to death. So this is a very, very worrying problem to FDA and also to the government, because everything which has an impact on given by new drugs is very, very important to be lowered as possible, as much as possible. So in this case, we had to, of course, take care about lots of this big amount of reports, and the impact of these new drugs were huge, right? So everything relating to these events, of course, has a very important impact in terms of timings, in terms of health of people, and also in terms of expenses of the country, in terms of how to cure and treat these AEs, right? And this is has a very big impact on the overall healthcare system. For instance, if you remember, of course, during COVID took every energy, every effort, every person working, every hospital, doctor, nurses, etc., were all impacted on by COVID. So everything about all the other diseases and problems and issues and treatments to be done were, of course, put aside for that period. So this is as a chain of impacts which are very, very bad to the healthcare system and to the overall health to the population, right? So the burden, the health burden and of toxicity and safety assessment is an essential and pressing public health concern, right? Now we have to think about this because AI can enable very quick solutions, can give you suggestions very quickly, can give you insights on a huge amount of data coming, etc., etc. So you have to think about as a help for you to do your work better and quicker, right? Of course, there is a very important thing that we have to think about when we are talking about AI, which is safety, which is, of course, again, quality.
Dr. Fred?
Yeah.
Can we another for 3-4 minutes? Can we have?
Yeah, no problem.
Thank you. So
Yeah,
minutes we'll be able to. Yeah.
Yeah, I'm going to finish in a while.
Thank you so much. Thank you so much. Sorry for that.
Thank you. No problem. I know that I'm keeping you away from food and drinks, so no problem. I'm going very quick. So just a few words about safety, which is very important in terms of data quality and safety of the solutions that are predicted by the AI, right? So to be very quick on this slide, you can see on the left the how and what can AI do for during the preclinical assessments and processes. For instance, AI can predict drug toxicity, can model diversity in patients, so understanding how the drug is going to work on some different clusters of patients, and also can give you suggestions about mechanisms of actions, right? And on the right, you can see what can AI do in the post-market safety, right? So safety is very important when the drug is on the market. And so AI can help us in monitoring the real-world use, make comparative safety analysis, better inform patients, etc., etc. I'm going to conclude very quickly with another case study with the benevolent AI. You can have a look at the website and the link that I've left in the bottom part of the slide about the development of machine learning models that can predict toxicological effects of new drugs, right? So again, AI's ability to process large data sets is very, very a big help to people in their day-by-day job. Finally, Pfizer, in the past, it's been a very long cooperation with IBM. IBM has a AI service which is called Watson. They have been working a lot since 2010, collaborating with Pfizer, which are, of course, a big pharma company, to leverage AI in the identification of new indications for existing drugs. So this collaboration has been very useful to detect and to understand how to treat autoimmune diseases, etc., etc. So, well, this is another example that we can go very quickly. Final words about regulatory and ethical consideration, which were already covered by Lila, but just to point out, to underline the importance of focus on regulatory frameworks that, of course, needs to be followed, especially if you work in such very high regulated market like the pharma one. So it's very important to stick to the HIPAA or GDPR frameworks to be able to, of course, be compliant with the rules within America, Europe, etc., etc. Again, AI is very important to think as a means of help, which is not going to replace humans. So the ethical considerations are everything that the AI can detect and help in suggesting needs to be reviewed by a human being before doing anything about drugs and treatments. The future in drug development, so we can think about applying very into different and very different cases. So for instance, again, enhance the predictive analytics and the efficiency of the predictions, remote patient monitoring and diagnostics. We can use lots of AI for working on data, etc., etc. Help people to get a more equity in healthcare, and as you can see, of course, the first and the main one, I don't want to read everything on this slide, maybe to focus on the cost and time effective innovation. Again, think about AI as a companion that can help you in doing your job more effectively, more precisely, and with more time to the high value things that you can do in terms of treatment of your patients and everything about your patient at the center. So thank you very much. Just to finish, I would like to thank everybody in the room and online for being here listening to our presentation. Just a final word about our Medibay Smart Clinics, which is a very important project that is going to disrupt the world, the healthcare system in the world, and also for the IQ training that we can provide in VR, coupled with the AI, as I mentioned before, for getting you better training and very real. Even if they are virtual, they can simulate in the real world how to do stuff, how to do your job in the VR training that we can provide to you.
Thank you. Thank you so much. Thank you so much, Fred. It was really nice hearing you.
Thank you.
Hello. Yeah.
So, thank you so much for your enlightened speech on the actually, the monarchy that you have accepted to various states to the rules that economic is really very nice and fantastic. And because most of the technology which you have used is very common technology being used in the medical pharmacology background. So it was very nice presentation and diagnosis. Thank you. Thank you, sir. Thank you for doing the session. I'd like to invite Dr. J. Nagaraj, sir, to give the certificates and honor to our staff and the coach and please come to the statement, Dr. Kalita ma'am, for being the fantastic chairperson for this session. I would like to invite our co-chairperson, Dr. Mohar Sivas, for the brief explain about the artificial intelligence. Thank you, sir.
Let's just look down.
Hand over the one.
Is give the second certificates of government of
You will hand over the moment of Dr. Freddy to our. Yeah. We'll give the moment of Dr. Freddy to his hands of Dr. Robert. Thank you, sir. With this, let's break for lunch. I will back in half an hour after the Okay. Since we are running short in time, I request everyone to come back on 2:15, please. Of course, I know it's a very short time, but please make sure you are back by 2:15 so that we can solve the problem. Thank you.
Thank you. How was it? Diga mam sana wana wala sana update dona yeke amen musa kudu pani da pani okay audio da இல்ல எங்களை உங்களை வாட்ஸ்அப் இருக்குல்ல see it is so easy. இன்னும் வாட்ஸ்அப்பே காணோம் எல்லாருக்கும் அதே
Very good afternoon. Thank you. With the online response, everyone has joined back. Can you give a thumbs up over the Zoom?
63.
So with that note, I'd like to invite our chairperson and co-chairperson for our third session. So it's my immense pleasure to invite our chairperson for this session, Dr. Professor Srinivasa, who is a professor and Chennai. He is having more than 23 years of experience in teaching. He is a member, secretary, IHEC, SMC, chairperson IHEC for the faculty research in Chettinad Academy Research and Education. And he is having more than 16 years of experience in PG coaching, and we have received more than 6 times Best Teacher Award in our institute science. And I take my pleasure to invite our co-chairperson, DM. So, who's a professor in the Department of Pharmacology, Institute of Medical Science program. She is having experience more than 33 years of teaching in India and abroad. This institution includes MBA from Medical College, MD in Pharmacology from Medical College, United. They have worked in various institutions, including JSS Medical College, Mysore, Srinagar Institute of Medical Science, Kerala, Dhanvarshi Srinivasa Medical College, KMCT Medical College, and he have worked internationally in Al-Fatih University, Libya, Jason University, Saudi Arabia for more than 12 years. With this note, I hand over this session to Chairperson and Co-Chairperson. Over to you, sir. Agriculture, we want to review Medical Pharmacology, GSL Medical College from the place is a trained in enabling math, enabling from QCA, trained on vigilance, media vigilance, customer vigilance from Register Foundation and is certified AMA, PHFI, counselor in rheumatology, dermatology, geriatric medicine, and it has more than 22 years search article in national. So we're honored to hear his please for you. Thanks a lot for giving such an introduction. Now we are going to show more paper, giving me such a good opportunity to present the topic in MPS form. We selected the topic which will be most useful for postgraduates. Generally, it feels that teaching should be to and extension of the what of the previous knowledge. So if the postgraduates can feel it's like a revision. Mic open. And extension of their knowledge. I talked with some of the postgraduates of Savita Medical College. They told that there are already exposed with artificial intelligence tools in literature review. So those postgraduates who are not going too much to these tools. So today we are focusing more on reference management tools. So they can get awareness of these tools. This is the Next. One second. Okay. Yes, sir. Please go ahead. Yeah. Next section is the top 5 artificial intelligence tools. Top 5 in terms of collection of articles they have in terms of users. Suppose our discovery boasts that has got around some 250 million articles and 3 million users are there. Like that. Our discovery, Mandeli, Jutiro, Collective, and Payable. The art discovery, all these things can be considered the academic reading app. Collective, which provides the latest summaries, non-payable, which is a reading app, so that we can find a lot of articles and can read very fast. Mendeley and Jotaro are reference management tools, same like EndNote. I think they're all relevant to those reference management tools. When compared to EndNote, Mendeley and Jotaro are somewhat younger tools. And they can be integrated with artificial intelligence. Suppose today we are focusing more on Jotaro, it can be integrated with artificial intelligence tool, a plugin source is on area. So next. So these are the things artificial intelligence tools are discovery, Colacri, Mandeli, Jotaro, and Unpayable. Today we are focusing more on Jotaro. Next. Jotaro is
Important step in conducting comprehensive studies to perform literature review. Challenges faced by researchers are overwhelming volume of literature, difficulty in identifying relevant studies, and keeping up with latest research. Artificial tools for literature review help researchers to overcome these challenges. So Jotaro is one of the reference management tool. So before going into Jotaro, first we should have to understand what are the reference management tools. So reference management tools help us to collect and organize our references, generate citations and bibliography from those references, and they can also help us to convert our reference file to publication required. We can insert citations, import and export citations. Jotaro is one of the reference management. Next. So we can synchronize online and we can collaborate with other researchers. These are all the key functions of any reference management tool. Next. So this is outline of topic Jotaro with key functions. Downloading and installation of Jotaro as this is live demonstration. So those postgraduates who are online, they can open their smartphones and they can follow the steps. Components and functions of Jotaro, creating and managing a library, import and export, index citation, in MS Word, reference list, bibliography, group library. This is the outcome of the topic. Next. So, Jotaro and its key functions: free, open source, easy to use reference management software to manage bibliographic data, web browser integration, online synchronizing, and generate of index citations. It works with more websites and compared to manually it works with more websites, so more catalog, more of the databases. Next. These are the steps. So from fundamentals, we are going how to install Jotaro, all these things. Go to Google search engine and type Jotaro or download. Once you type that, you can see two options. Jotaro 6, which can be integrated with artificial intelligence when compared to Jotaro 7. And for Windows, and another is Jotaro Connector. These two options you can see. Just click download button and application will be downloaded. You install it by pressing next, and after it is finished, it will be stored in C drive and icon will be seen on desktop. Another one is Jotaro Connector. It's an extension. Once you install it, you can see in bookmark, it will appear in right upper corner of the web. Next. Like that. As it's live demonstrated, they included each of the slides, what will happen when you type like that. So once we type Jotaro download, it will be shown like that in Google search engine. Next step. Next. So you can see two options, Jotaro 6 for Windows, another one is Jotaro Connect. So you type download on the Jotaro 6 for Windows. Next. Jotaro 6 will be downloaded and it will be stored in C drive and an icon will be shown on desktop. Then for Jotaro Connector, once you install it, next, you can see like this. So when the Jotaro software is open, the Jotaro Connector icon Z will appear at the right hand corner of Google web. Next. Then once you open the Jotaro, whatever the icon which was shown on desktop, once you open, it will show like this. Welcome to Jotaro. Then you have to create an account to use it. So how to create this thing, we shall see in next slide. So like this, it will be shown. Next. To create an account. For that, you can see at the left side, click edit option to see the preferences. So once you type edit option, you can see the preferences. At lower right, you can see preferences. Click preferences option to create an account. So once you click preferences option, it will be shown like that. General synchronizing like that. If you type on synchronizing, you'll ask your basic details, username, password like that. Next. Then once you created an account, it will be shown like that. These are components and functions of Jotaro. left hand panel, right hand panel, and middle panel. You can see left hand panel is libraries where you can create your own folders, categorize them. Those folders, whatever the research topics you have created, resources for those topics are generated within that. Like websites, databases, books like that. Next, metadata. Metadata shows regarding authors and titles. So like that, it will be shown. This is the Jotaro interface. So library, resources, and metadata. Next. So once you see the Jotaro bar, previous ones. The Jotaro bar means left side, top corner. You can see Jotaro bar. If you see it close, next play, it will be shown like this: file, edit, view, tools, help, like this. Then another option, my library, will be there. So this Jotaro bar, whatever the options shown, they have got their own functions. Next slide. So file, if you type file, these things will be shown: new item, new note, new collection, close, import from the library, export library, exit, like that. Edit option, if you type, these options will be shown: cut, copy, paste, search, preferences. The view option, layout, font size, note font size, so items from collection, like that. In tools option, if you type create timeline, RTF can rich text format, and this install browse connector, add-ons, developer, like that. And if you type on help option, support and documentation, troubleshooting, discussion forums, report errors, debug, updates, about it, all these things will be shown. These are the Jotaro bar functions. Next. Then, so how to create your own library? So click the folder with the plus sign. Here you can see my library. Or the top left side of that, you can see plus sign. If you click that folder, whatever the collection you have kept, that if you type that, it will make the folder get important stuff. So whatever the topics you created, whatever the folders you created, if you want to search it, you can type like this. Next. So import and export. So like this. Suppose go to Google Scholar, to select the citation icon, click on your desired citation type, then click on Refman. It will become like that, Refman. Yeah. Or otherwise you can use that icon to save it, whatever the citation you want. Next. So from web pages like this you can save. Go to the web page you want to save and click on the Jotaro factory. It will be saved in your Jotaro app. Next. Import and export. Select the import and select the file to import. You can import as many files you want. Next, select the export file. Say, in fact, you can import and export. For that, on file, in real world, we have seen. Once you type on the file, import and export option will be shown. Next. So these are various entries into Jotaro library. So in libraries, you have created your own folders. Then in resources, whatever the websites which are related to those folders, and title, all these will be shown in metadata. These are various entries in the Jotaro library. Once you started to use the Jotaro, so all these things will be stored in it. Next. So after some time, your library becomes smart too. So you'll get habituated to use it. Later, we can integrate with artificial intelligence. Next. In-text citations in MS Word. For that, again, select the edit and preferences. It will be shown like this: general, synchronizing, search, export, type, like that. Select the type, and it will show like it. Reinstall Microsoft Word add-in. Install MS Word add-in. Yes. Then once you install that, open your MS Office, keeping the Jotaro app open. Then along with it, open the MS Office, and you can see Jotaro tab like that. In your MS Word, you can see Jotaro tab. Once you type on the Jotaro tab, these options will be seen: add or edit citation,
add or edit bibliography, document preferences, online citations. These things will be seen. Next. So these are there are some key functions on this tab. These are the key functions of this tab. Next. How to create in-text citation. So click on document preferences. So in MS Word, once you type on Jupyter tab, these options will be shown. If you click on document preferences and then select your desired citation style. Open MS Word, keep the populated Jupyter library open, then click on document preferences and select your desired citation style. Then click on OK. Then that citation style will be saved. Next. Or otherwise, click on add or edit citation. Then a Jupyter pull down bar will appear. Type the title and hit enter there. Then place the cursor where you want to insert the citation. Like that, you can save the citation wherever you wish. Next. So regarding reference list or bibliography, click on add or edit bibliography. For addition of any of bibliographic data. Refresh that option is for to update the types of references. Suppose for academic purpose, you can align these citations to edit or submission. So the record used in text will automatically appear if you type that add or edit bibliography. Next. So this is group library was created. So time constraint is that you complete first. Creating using new library button, your group library folder needs documents will be shown like this. Because you can create a group library. Next. Thank you.
Any questions? The logo மட்டும் play ஆயிட்டு இருக்குங்க. எப்படிங்க காசு பண்ணுங்க? No, business இது பண்ணலாம் அப்படியே இருக்கு. ஆமா, லோகோ மட்டும் எப்படி க்ளோஸ் பண்ணுங்க?
ஸ்பீக்கரோட
சரி,
இந்த டைத்துல நீங்க டவுன்லோட் பண்ணிருக்கீங்க அதை.
Good afternoon, everybody. I thank the Superiority Department of Pharmacology, Medical College, for giving me an opportunity to present the speakers in details. I also thank Dr. Shivamurthy, President, Medical Pharmacological Society, taking an important step in organizing this conference. I am extremely happy to introduce Shruti Chandra, MBBS, MD, CCCDM, and FIFM, Associate Professor, Department of Clinical Pharmacology and Therapeutics at MGM Medical College and Research Center, Chhatrapati Sambhaji Nagar, Aurangabad, Maharashtra. Dr. Susi Madam graduated MBBS from King George Medical University, Lucknow, and she has in her credit 2 gold medals, 1 silver medal, certificate honor of 4 subjects and prize. And Susi Madam did her post-graduation MD Pharmacology from GSBM Medical College, Kanpur, with honors. And she has got experience of 11 years in academics, 2 years in industry as medical advisor at Loka Laboratories, Mumbai, International Division, wide experience in field of research, academics, pharmacovigilance, prescription audit, clinical trial, medical marketing, medical writing, etc. And Dr. Suti Madam has published around 22 papers in industry journal, contributed 3 books chapters, served as moderator, judge in many national conferences, reviewed many articles also. And Dr. Susi Madam has award Young Researcher Award by Institute of Scholars, Bangalore, Karnataka in July 2023. Merck Award for the best oral presentation in scientific session on cardiovascular sciences at MPSCON. And she has others Shikshak Puraskar at B Maharashtra in 2000
for class credit. And recognition, she has certification course in diabetes mellitus management, CCCDM, and fellowship in FI, etc. And she is a member of life member of Medical Pharmacologists Society, Indian Pharmacological Society, and Indian Medical Association, and National Medical Association of Pharmacology and Therapeutics. So I have a great pleasure in inviting Dr. Suti Mehta for today's presentation. Thank you.
Sorry for the interruption. One quick announcement. We have a certificates for the judges who have came for poster presentation, oral presentation. So we will give them the certificate now with a big round of applause.
Please, big round of applause.
Thank you for giving your time with us today. I'd like to invite Dr. Vanita Dina ma'am, I'd like to introduce you to the stage to give the certificates to the judges.
I just want to inform to the audience that Dr. Dina has been the driving force behind all the scientific presentation. Thank you so much, Dr. Vanita ma'am.
Dr. Preeti
Exception.
Next, I like to come from Next, I like to call upon Dr. Sultan sir to give his certificate to the judges. Dr. Sumita K. Please give a big round of applause for our judges. Dr. Satyanarayana D. Please come to the stage, sir. So I'd like to introduce Dr. Shahaz Khan to the stage to give his certificates. I'd like to invite Dr. Melvin George, sir. Dr. Mark
They are nothing. Good service. It's a PowerPoint for okay, so it's half power.
Thank you so much for everyone. With that, I'll hand over the session to our speaker. Over to you, ma'am.
We are going to start, I think. So, a very good afternoon to all. This is a very challenging job to keep you awake after such an initial match. So, I'll be very quick and we will be talking from artificial intelligence now. This is something like I spoke up. So, this topic is a little bit different since morning what you are listening. So, my topic of presentation is methods which are used for fast track development and approval of COVID-19 vaccines. Next, please. So this will be my panorama of presentation. Next, please. So COVID, we all know all the details. Previous slide. So on December 31, 2019, WHO was alerted by a cluster of cases of pneumonia of unknown cause in the city of Wuhan, China. We are well aware of that. Within a week, scientists identified the causative agent of the disease as new type of coronavirus, which was SARS-CoV-2. So the spread of SARS-CoV-2 rapidly became a public health emergency of international concern and then a pandemic. So it spread it very fast. And as soon as the first draft genome was made publicly available, it triggered intense global research and developmental activity after January 11, 2020. Next, please. So these are the various variants of COVID-19 viruses, alpha, beta, gamma, delta, and omicron, which came into the light according to the dates and everything is mentioned here. I am not going to into the details of it. Next, please. So as per WHO, till now total cases are 776 million and total number of deaths are 7.1 million. And total people who are vaccinated are 5.47 million. And the graph can show a surge where the COVID virus infections are highest in 2022. Next, please. So why do we use vaccine? It prevents infectious disease like measles, polio, hepatitis, influenza. And when people are vaccinated against a disease, the ability of pathogen to spread is limited. This is called herd immunity or indirect immunity. Also, when many people have immunity, this also indirectly protects people who cannot be vaccinated, like young babies and those who have compromised immune status. Next, please. So, vaccine works by reducing the risk of infection by training the immune system to recognize and fight the pathogens such as virus and bacteria, and they safely deliver an immunogen, which is a specific type of antigen that elicits an immune response to train the immune system to recognize the pathogen when it is encountered naturally. Next, please. So this is basically the process of vaccine development. First, isolation of desired genes, then this gene is inserted into a vector, which expression characterization of host cell is done, then culturing of cell bank, then there is purification of protein, handling and storage, formulating and test and examination and analysis of the vaccine is done. Next. So these are various vaccine platforms. So this is a lengthy topic here. I want to highlight that there are a lot of vaccine platforms which are used for development of various vaccines. And here I have highlighted only those who are used for COVID-19 vaccines. So the number in the bracket shows that live attenuated virus is 1, inactivated is 10, protein subunit 24, likewise. So these are the major platforms which are used for development of COVID-19 vaccine. Next, please. So these are mRNA vaccine, which was the most researched vaccine for the COVID-19 virus. One antigen coding strands of mRNA delivered inside a lipid coat. It translated into the protein antigen, and the antigen is recognized, inducing an immune reaction. After that, the pathogen stimulates a strong immune response. So in this category, the emergency list authorization by WHO was given to Comirnaty, which was by Pfizer and BioNTech, and Spikevax. Next, please. So next category here is viral vector vaccine, which use a non-COVID virus vector, for example, adenovirus, which is modified to include a gene that encodes a target antigen. It can be replicating or non-replicating, and all WHO EUL viral vaccines are basically non-replicating viral vector vaccines. So here we have Covishield from the Serum Institute of India and Janssen vaccine, which was given emergency use authorization by WHO. Next, please. Next viral vector is inactivated virus vaccine. So here the genetic material of the virus is used, which is destroyed to stop the disease producing capacity. An inactivated virus cannot replicate inside the body, so higher doses are required. So this usually induces antibody mediated immunity only. And here the WHO EUL inactivated vaccines are Coronavac, Sinopharm, and Covaxin from the Bharat Biotech. Next. Next important category is viral subunit vaccine, which uses the antigen of virus without any genetic material. So basically these viral vectors are different because the purification methods and development process are different for these vaccines. So usually manufacturers use those
viral vectors which have less manufacturing processes and purification processes so that they can fast develop the vaccine. Next, please. So this is the current status of COVID-19 vaccine. By the end of February 2021, there are almost 256 COVID-19 vaccine candidates have been developed, out of which 182 were in preclinical studies and 74 in clinical trials. And we know that only out of these, only 14 vaccines have received WHO emergency use list authorization. And in India, we have developed Covishield and Covaxin. So there are two which were developed in India. Next, please. So this is the list of the viral vector vaccines which were received the emergency use authorization by WHO. Next, please. Next, this is the same. So these are the steps in vaccine development. Why this is important? Because the process of this development usually takes 8 to 10 years. And now we know that we have in hand COVID-19 vaccine when it is there in January 2021, and we have the vaccine. First vaccine by Moderna USA was launched in December. So only 8 to 9 months the manufacturer have taken to launch the vaccine. So basically these processes are given fast track so that the vaccine can come in market very fast. Next, please. So here we can see that the total years which are usually involved in development of a vaccine is around 8 to 10. But accelerated vaccine development timeline is preclinical phase 1 and phase 2. Usually it takes only 10 to 12 months. So in 1 year we get the vaccine in market. So the main important reason for this is that these are the steps which are done in parallel. So usually all the phases, they have given approval phase 1, phase 2. So then once the safety data is there and the regulators have the safety data, then they give approval for the marketization of the vaccine and it enters into phase 4. Next, please. So this also says the same, that around 12 to 24 months for each. So you can see here that phase 1, 2 years, phase 2, 2 years, phase 3 is around 3 to 4 years, which was got short by only 2 months for each of the stages for each of the vaccines. So sample accelerated timeline, which is used by regulators, is used for fast track approval and authorization of vaccine, which comes around less than 1 year. Next, please. So these are the certain techniques which are used by manufacturers that so that they can produce the data very fast. So mRNA technology. So I told you that other viral vectors, they require a hectic procedure of manufacturing as well as, sorry for this, procedure so that the timeline for producing safety data is long. Genomic sequencing, so rapid genomic sequencing enables swift identification of genetic material, accelerating the vaccine development. Then adjuvant optimization, which is very important. So the adjuvant which the manufacturer is using for production of vaccine is important. So which enhances the reducing the amount of antigen needed and enhance the immune response. Then single dose regimens. So if we decide to go with the single dose regimen, then obviously it simplifies the administration and logistics. So again, it improves the fast track development. Next. Electrofusion is a technique to fuse cells and create hybrid cells for vaccine production. And synthetic biology is designing and constructing new biological pathways to produce the vaccine components. Similarly, high throughput screening, vector-based vaccine, and DNA-based vaccine. So these are the methods which are used by manufacturer to produce fast track results. Next, please. So this is in all overall process by which a vaccine is approved. So first the vaccine is manufactured, then it enters the clinical trial phase 1, 2, 3, and then the results are submitted to the national regulatory authorities, from where the licensing is done, and then to immune services, drug technical advisory board approves the vaccine, and then central regulators, they approve vaccine and conduct the trial, then it is marketed and phase 4 is started. Next, please. So these are the various regulatories which are involved in production of vaccine. So Review Committee on Genetic Manipulation, which is responsible for authorization, the conduct of the research, development, exchange of genetically engineered cell banks for the purpose of research and development. Then Genetic Engineer Appraisal Committee, which is DEAC, which committee works in the Ministry of Environment and Forest as a body to review the application and approval of activities where final drug product contains genetically modified organisms. So this is basically for biologics, which involves vaccine also. And lastly, CDSCO, we all know that this is responsible for trial approval. It also grants permission for imports of the drug for trial and exports of the samples for biochemical and biological analysis and permission of marketing and manufacturing. Next, please. So how WHO has received this major outbreak to get the vaccine in less than 1 year? So WHO started COVID-19 Solidarity Vaccine Trial. What is this? It is 28 May 2020. WHO announced the launch of coordinated international concurrent randomized control phase 3 trials of different vaccine candidates. Basically, trial in the several sites at once will help speed evaluation and ensure that vaccine will have tested in different populations. So this trial aims to enroll more than 280,000 participants from at least 470 different sites in 34 countries. And also local involvement helps to identify the sites for COVID-19 transmission and ensure community engagement. Next, please. So that's how they have achieved this target, evaluating several different candidates, which increase the likelihood of finding several effective vaccines, then expeditively involving people at sites of high rates of COVID-19, which causes rapid accumulation of data which can be used for safety evaluation, then eliminating inefficiency of design and conduct of separate trials. So they have combined many cities and countries, results within 3 to 6 months after each vaccine is ready for inclusion. Then international collaboration and country commitment, which foster the international development with equity of access. So it's not that the US has developed the vaccine, so it has been released everywhere. Next, please. So these were the results of this trial. That the results robustly they have achieved. They have submitted the protocol in August, and the vaccine or the immune analysis results were in January. So around 8 months they have taken to say that this vaccine is effective around 70 to 80% and launch in the market after emergency approval. Next. So with this, there are certain ethical issues when you are so fast tracking the approval and development. Everywhere, if you are developing something very fast, there are certain ethical issues which are related to COVID-19 also. So these vaccines were developed in record time. There was difficulty to pursue some reluctant population to receive the vaccine. So many people they were not willing to receive the vaccine. And also there was a debate, not only those who have refused to vaccinate it, but also those who rushed or jumped queues to be first. So some people they want the vaccine first and some even don't want it. So vaccine passports also raise issue to an unequally vaccinated world, where those who are vaccinated were able to go work to the shops, restaurants, and engage in leisure activities and travel. Last point here is that voluntary vaccination compared to compulsory vaccination policies is at the center of debate from last 2 years. What government should do? It should make compulsory or it should be a voluntary vaccination. Next, please. So to summarize my talk, I would like to say that in the middle of the high death rates and alarming fall of global healthcare system, in the initial 2 years of COVID-19 pandemic, these vaccines were approved for the first time based on novel vaccine technologies and fast-track vaccine approval by regulators, manufacturing of the vaccine at a large scale, and effective distribution of vaccines have played a significant role in distributing vaccine shots that provide robust protection against infection, SARS-CoV-2 and evolving variants. So here the key vaccine development process and vaccination programs are still ongoing because of the devastating effect of the pandemic. So in future, we can say that fast development of vaccine will be a new normal activity. So earlier, which was taking 10 years, maybe in future, 1 year will be a normal activity which can be done by our regulators. So these were my references for this presentation. So thank you very much for giving me this time.
No one question.
Any questions?
So, what are your views on now the regulatory use of the vaccines? One question. And second question is, there is a study that all those who are taking the vaccines are risk of getting viral infection and stroke. So, what are your views?
So I would like to say when you bypass certain processes, for example, there is a process of development of vaccine. That this phase has to be all the data should be collected properly. And if you are fast tracking, so there are certain always drawbacks. So this is one of the drawback of COVID-19 vaccine, that efficacy cannot be tested on large group of population because of the fast tracking approval process. But if you see on the perspective of government, that it was necessary action, because once you have something, then you have to give them to the people. So that is why this is a point which is a debate, ethical debate. And second question was, COVID-19 vaccine, people have risk of, so that data we will get in phase 4. That is why post-marketing surveillance of vaccine, when it is given to large population, is very important. So there, under pharmacovigilance, we have to report on the areas and do the signal detection, whether there is some adverse events which are there, and then we can take the action accordingly. So that is why in many, for example, US FDA, they have the adverse reaction reporting system for vaccines, which is very robust and it is followed very properly.
Ma'am, one more. Ma'am, I have to.
So, who will take responsibility for the implement on pharma company? Who's responsible?
That is the debate question. Ethical. Nobody can take the responsibility because the sponsor they have to do the job. Researchers they are doing the research. Right.
Researchers and scientists they are doing the research and they are giving manufacturers they are doing. So it is a public social concern problem. So that is why you cannot just put a mark on anyone. Government has to take what they can. Again, there is always a questionable thing which one has to do. So this is under ethical dilemmas.
Okay. In that one point, so.
My name is Nagraj. I actually worked into regulatory department from pharma. So I was with Pfizer when COVID was offering SFDA. So to just answer you, yes, I'm saying it's completely relies on the pharma company as well as it's a situation that prevents the fast access. That's where regulators came down to get the access. And just to add to it, AEs are not only happened with vaccine and COVID. AEs are there with all other drugs. Even those drugs that are there in 15 years of research still have produced some adverse events, and because of that, things are new. Hospitalization, prolongation are there. So for every drug, you have their own effects, but it's only the point that ends is whether efficacy and safety outweighs the risk or not. Only based on that one thing, regulators and companies will take the decision. Only if the risks are down, then the efficacy and safety it will be approved. And
so the vaccine is supposed to be it's government mistake. If it is quality with pharmaceuticals. Can you consider it? Okay. Thank you. Thank you for a wonderful discussion. Before we go for the third teacher, I like to invite Dr. Shrimati to have a certificate for our last judge, Dr. Fisley. Please give a round of applause. Thank you, sir. And now I hand over the session to our chairman. What will you say?
Thank you, madam, for a wonderful session. Now, I'm going to introduce Dr. Mohan Shani, is the medical advisor, distribution, with the Mumbai. He is got a UG and PG degree from Goa Medical College, has more than 10 years of medical experience in pharmaceutical company, India like Pfizer, Johnson, Denmark, Service Solutions, and he has diverse experience in pharma segments of diabetology, cardiology, GMT, neurology, orthopedics, rare disease, pre studies, and he's author of more than publication. So we honor to show his please. Open his slides. Then the mic. Then go ahead, present. First you start this present. Yes, sir. Select that, sir. Screen mouse key. Screen mouse. It's not opening here. It's full screen of you. You directly move to the slide and see. It's not showing. Actually, it should come. You again close it and open it. Escape. Close and open. Stop sharing. Yes, screen is got stuck. Either close one and show one. You're not getting that. You go. Now, yes, sir. Okay. You don't have to PPT and this is the intro slide. Okay. Intro slide. Close it. Yeah. Up, you can go to the second slide. Yeah.
Good afternoon all. Thanks sir for the kind introduction. My topic for today will be the strategies for drug launch in medical affairs. A disclaimer from my side, all views expressed here are my own views, my current or past companies are not responsible for the strength register. Please.
Video. Excited. Yes, sir.
Before I start with my presentation, I would take this opportunity to thank Dr. Shivamurthy and the entire organizing team of MPSCON for giving me this opportunity. And I'm happy to be here in Chennai because this is the place where I started my career. Starting my career as a regional medical advisor in Chennai. I stayed here for 1 year and then I moved. So Chennai is always special for me and will remain special. So coming to my presentation, my entire presentation will be divided into these three parts. First will be what is drug launch. Second would be what are the phases of drug launch. And the third part would be what is the role of medical affairs team in the different phases of drug launch. Next slide. So let me start with what is drug launch. So just to keep it simple, when a pharma company tries to get the market authorization to bring a drug into the market in any country, that is called as a drug launch. So drug launch is basically bringing a drug into a particular market, whether it is a US market or an India market, right? So whatever is done around that process, before the process and just after bringing the drug, that entire phase is called as drug launch. And this phase is again subsequently divided into three parts. One is the pre-launch, the launch, and the post-launch. So launch, I have already explained to you what it is. It is bringing the drug into market, making it available to the patients in a country. Whatever happens in the previous 2 years or before the drug launch is called as pre-launch, and whatever happens 1 year after the drug launch is called as post-launch. So what are these activities that basically happen? So in a pharmaceutical company, there are various functions. So we have the clinical research team who conduct trials. We have the regulatory team who helps get the approvals from the regulatory authority. So in India, we have CDSCO or the DCGI, who is the regulatory authority, who approves the drugs to be brought into a country. Right, so that is basically facilitated by the regulatory team. And then we have the commercial team. The commercial team is the one which takes the responsibility of bringing the drug into the market at a particular price, right? So that is the commercial team, or we can say the marketing team, and then would be the medical affairs team. So this all four teams combine together, work together for the common objectives, and that entire effort by this team is called as a drug launch. Next slide. There is another term called as launch excellence. So this is a term which has been used very frequently in the last 7 to 8 years. What is launch excellence? So if each of the team operates in silos, all the teams that I have mentioned to you, then there is no uniform process of launching a drug. But if all these teams come together very well, gel well with each other, you will see that the process is very streamlined. That is basically called as launch excellence. It is a strategic process where each member of this team brings in their expertise. Regulatory team brings in their expertise, medical team brings in their expertise, and that is how the process of launching a drug is smoothed. Now, all these efforts should be overall aligned to the organizational goals. So you must be aware that there are some companies which are present in certain therapy areas. Some are present in diabetes, some are present in oncology. So each company has its overall organizational goal. So all these teams have to align to the organizational goal of the company. You cannot randomly select any drug to be launched in a country. Each company, there are some companies which are working only in the oncology space. There are some companies which are working in the nutritional supplement space, right? So accordingly, the effort will be mobilized. The team also develops robust processes, systems so that there are no hiccups in the process of drug launch. There are structured communication channels, whether it is the medical team or the commercial team. Structured communication channels are developed. The clinical data differentiator is identified. When you're bringing any molecule into the market, then you need to identify what is the value that that particular drug is going to bring in the market. And then ultimately, what is the benefit for the other elements of a drug launch? That is the patient, the service provider, the payer, the supplier, and the society in general. So then this element also is brought into the drug launch. So the last element which I have mentioned is becoming a very critical element. So many years back when drug launch was considered, there was very less focus on the patient, on the society, on the payer. Now, what we see in the drug launch in the recent 5 to 6 years is a very strong focus on the patient, payer, society. Next slide. So, what is the role of medical affairs? So, all the teams that I have mentioned require help from medical affairs team at all points of time. So, whether it is the design of clinical trials, identification of the investigator, suggestions in the protocol, then in the regulatory process, what regulatory strategy we need to follow. It is always a common discussion between the regulatory team and the medical team considering the issue. You also have the commercial team. We work very closely with the marketing team to guide them what they should communicate, how they should communicate, right? So all these things are put together, placing medical affairs at a very central role in the drug launch. Next slide. This is what traditional medical affairs used to do. So earlier for most of the products, it still happens. So it is basically to disseminate the data and knowledge about the product or the disease of focus, develop relationship with external stakeholders, mainly the key opinion leaders. So the leading doctors in the specialty are called as key opinion leaders. Suppose you call it as an endocrinology specialty, the top endocrinologists are called as key opinion leaders. And the last part of the training. So training either of the medical team, commercial team, or any of the support functions. So medical team is the core team which decides what could be the type of training for each of these functions. Next slide. Now, what is the role of medical affairs that is evolving now? So as I said, we are now focusing on new set of customers, that is patient, payer, society in general. So what is changing? So from a support role that the medical affairs had some time back, where commercial was the main driver, slowly medical is becoming a as equally important driver as a commercial team in the drug launch process. They work very closely with the global colleagues. So now for the portfolio that I'm currently working with, the global teams regularly connect with us to get a suggestion on their strategy. That is the change which is happening now, which was not happening earlier. So we contribute to the strategy from India perspective, which can help even the global strategy. The new external stakeholders we are expanding to, we are reaching the patient, we are reaching the patient advocacy group, we are even reaching the policymakers, the government officials who are taking key decisions related to access of various therapies. We even interact with them to explain to them the need of this therapy in their setup. And lastly, we are trying to understand the healthcare system. Earlier, when I started studying, we hardly look at the healthcare system. We had some basic knowledge about the healthcare system being doctors. We assumed that the things happen in a certain way and then we were using it. Now what we are doing is we are trying to understand the healthcare system in depth at the medical team level. How is the drug actually being utilized in certain healthcare systems? How are the diseases being diagnosed in certain government centers versus the private centers? We are getting this disease specifics at the level of medical team. And all these changes that you see are contributing to the drug launch. Next slide. Now coming to the specific roles and responsibilities of the medical affairs team in the current scenario. So first is giving the direction to the company. So if we have say 10 molecules which can be launched, right, the decision to decide that we will go with these two molecules first start with the medical team, right? So the company has a big pipeline, say in oncology or say immunology. They will reach out to the medical team to give them the direction. Okay, this time we will focus on these two molecules. So that is the first role. Second role is to represent in external forums. We constantly interact with the doctors as well as doctor associations to explain to them the importance of certain disease and treatment. So that is the external facing role. Generating data. So once the initial phase 3 studies are conducted, there might be some new data that is required, addressing some newer aspects of a drug. So for example, if it's a pen formulation of a drug, there is something called as a patient preference study, which is not usually done by the clinical research team. It is initiated by the medical affairs, right? Of course, with the help of CROs. We also generate some data which can help reimbursement. So nowadays, a lot of drugs are being reimbursed by the government institutes. So we help to generate the data which can be used for reimbursement claims. Then is the regular dissemination and communication of data. We participate in various conferences. We present data at conferences. We create publications, manuscripts to take that data to more doctors. Next slide. We also create a database to answer common questions that come from doctors. Once the product is launched, there are a set of questions which the doctors will have. Can we use it in stage 4 CKD? Can we use it in liver failure patients? So we create a question bank and a database to address this question. Then is highlighting the unmet medical need. So what is the unmet medical need? If you take example of diabetes starting with metformin and sulfonylurea, right? Today we have SGLT2 inhibitors, we have GLP agonists. This entire change and shift in the management of diabetes has happened because of the unmet need. There was some unmet need which was there in sulfonylurea. So they were causing the pancreas to release all the insulin. And then there was a need of a physiological insulin secretagogue, and that is how we got glipti, right? And then there was altogether different drug SGLT2 inhibitor which was not even involving insulin, right? So this is a shift which is happening in any therapy. And this is about creating that unmet need and then addressing the need. The next is the next is about accuracy of the promotional material. So there are the sales team which takes any promotional material to the doctor. It goes under review to the medical team. They ensure that there is no wrong representation of the data in those materials. And identify external stakeholders. So these are the main roles. Next slide. Yeah, so these are the main pillars of the medical plan that we have. So in a drug launch, when we make the medical plan, what are the things that we include? First is we look at the evidence that is available from the phase 3 studies and how to communicate that to the doctors. The second is we ask specific insight from the doctors. So even though we know everything, the doctor sometimes come up with interesting positioning for our products, which we have not thought of. So we go and proactively discuss with all the doctors, ask them for this insight, and then use it to design our strategy. We also define the indicators for our plans. So if we are planning CME, then what are we trying to achieve with that CME? If we are creating a data, what are we trying to achieve with that data? So these are called as indicators. We quantify them and we say that after this CME, we will be able to improve the diagnosis rate of the disease. So these are some of the indicators that we try to develop. And lastly, the communication and engagement tactics. So what are we going to communicate to which doctor? Sometimes there are drugs that we handle which are not for single specialty. Something like a painkiller. Painkiller can be used by a MBBS doctor, by a MD doctor, by a gynec doctor, by a cardiologist, neurologist. Anybody can use a painkiller, right? So we develop a different strategy for each specialty. What we are going to communicate changes as per the specialty. Next slide. This is my last slide, the summary slide of my presentation. So as I said, that medical affairs has a role in all the three phases, the pre-launch, the launch, and the post-launch. As you can see, launch is somewhere around 0 to 12 months, minus 12 months. That means 0 will be the actual drug being available. Minus 12 months is called as launch. At some places, we call it as peri-launch. So around the launch is called as peri-launch. Pre-launch will be somewhere 2 years to 3 years before the drug launch will be pre-launch. And post-launch will be the first 12 months of launch. And these are all the activities that we do. So pre-launch is mainly for highlighting the unmet need and getting insights from the doctor, identifying if there are any clinical trial gaps that we need to address, conducting training of our internal teams, whether it is the sales team or the allied functions, and also building partnerships with ACP associations. The launch phase is more about the product. It is about how to use the product. What is the evidence about the product? How we train the sales team, because now the product is going to be available in the market. What are they going to communicate to the doctors? And the new element, that is the payers, policymakers, we have dedicated educational activities for all sets of customers. And lastly is the post-launch. Here, basically, we continue to address questions that come from HCPs or doctors. We try to introduce the products in the treatment guidelines. So if you take example of diabetes, initially you had only recommendation for metformin, sulfonylurea and gliptins. Today you have SGLT2 inhibitors also in the guideline, right? GLP agonists also in the guidelines. So this is because of concentrated efforts by the pharmaceutical company in collaboration with the HCP association. RWE generation. So real world evidence from data reports is helping us to give newer insights on the already launched drugs. And then broadening the engagement. This typically we do, for example, suppose there is a drug for hypertension. We will first train the cardiologist. And this cardiologist will then train the MD physician. And this is how we connect that network. And the MD physicians will then train the MBBS doctors. So this is how we expand the network. Initially, we will not directly go to the MBBS doctor. We'll start with the cardiologist, then the MD physician, then the MBBS doctor. This is how we broaden our network of HCPs. So this is in short all about what medical affairs does in all the three phases of drug launch. Next slide. Thank you. That's all from my side. If there are any questions, I'm happy to take.
Recently, I think I was finished. Recently, I was in a group actually. When I posted about our conference law, it is called as Worldwide in CR group. In that group, when I posted our conference, they had an objection. What is the contribution of medical pharmacologists to the clinical research industry? Then I strongly wrote, see, if you know, MD pharmacologists are the brain behind planning your clinical trial right from the pre-clinical to the post-clinical and even post-marketing. They are the people who are involved in complete launch activities, promotion activities, training activities, and also the right from the protocol writing to the entire process of collection of data, analysis, and reporting. So people does not know. Why I told you because the pharmacologists need they need to come forward and protect ourselves and confidently that yes, we are doing this. Okay, when I told that, then there was no question. Secondly, I also told Medical Pharmacology Society is involved giving the recommendations to the BCCI about the NTCT 2019 rules. We gave a detailed around 30-page document with what is the current statement, what changes to be done, what is the impact of it. Okay. So like this, we should, as a MD pharmacologist, we should go forward and tell the world that we are doing this. Until we tell this, people will not listen. Excellent presentation, Dr. Mukul. It was very nice. Thank you so much.
Just I'll add one point to what Sir has mentioned. Globally, there is one more phase before pre-launch called an early development phase. In that early development phase, we even have pharmacologists who are contributing to the trial design. This is a change that is happening now, which was not happening earlier. So as Sir rightly mentioned, that not only in the pre-launch, of course, we are always involved in the pre-launch, but even before that, the medical affairs team is being invited in the discussion of how the trial is going to be designed and to take decisions also which product to go ahead with in the early development phase. Yeah. Thank you.
Okay, Doctor. Good afternoon, everybody. I have a great pleasure in introducing the next speaker in the session, Dr. Mohammed Siggat. He is presently the Director, Medical Affairs, Orthomid Life Sciences. Dr. Siggatullah completed his MBBS and MD Pharmacology from JSS Medical College, Mysore, which is one of the premier medical institutions in India. In the current role, he oversees the medical function, managing a team of 18 medical doctors, 200 plus pharmacists, dentists, and biotechnologists. His areas of expertise includes pharmacovigilance, medical writing, business development, audits, and inspection management. Additionally, he is member of MARG Independent Ethics Committee in capacity of basic medical scientist. Prior to Orthomid Life Sciences, he was associated in capacity of associate director with Thermo Fisher Scientific and Medical Safety Lead with Wedge Medicine. So over to Dr. Siggatullah. Thank you.
So a very good evening, one and all. Thank you so much, sir, for the very kind introduction of mine. I know, I think mine is one of the last session of today. It's been one more. So I think many of you have traveled from all over one world. Okay. So you traveled from all parts of the country, and it's been a pretty long route, and obviously the lunch was very simple and tasty. So it's not to make you sleep. So yeah, before that, my humble thanks to Savita Medical College and Dr. Shivamurthy, India Society, and the management of Savita Medical College for giving me this opportunity to speak. Yeah, thank you so much. So today I'm going to speak on utility of softwares, how technology has basically made our life easy in field of pharmacovigilance. So I've been associated, I've been working in domain of pharmacovigilance for last more than 8 years, and trust me, software technology is the thing which makes our work easy. So before I come to that detail, go back in time by maybe 12 to 15 years, to take the liberty of saying that not many pharmaceutical companies were taking pharmacovigilance seriously. So that was a kind of baby steps were being taken, and what it was at that point of time, very unorganized, and there were very few companies were doing pharmacovigilance activity, and out of those few companies, majority of them were just making processing those cases in Excel tablets or maybe the PDF documents. But now, during over last 12 to 15 years, it has grown in a very revolutionary way. Every step in pharmacovigilance and also in pharmacovigilance. A huge role which we have seen for over the course of 5 years. Next slide. Yeah. So pharmacovigilance, everybody is aware. The definition everybody would give is selection, detection, assessment, monitoring, prevention of adverse effects associated with the pharmaceutical products. By line extension, I can take the liberty to call to include the biologics, vaccines, the devices, cosmetic, so on and so forth. So now, if you look at the different steps here, this is where we were doing things in a very manual manner. There was not much of technology which was driving it, but now we are at such a stage. It has been an evolutionary step we have taken in last 12 to 15 years. Every step here is data. It is driven by technology, it is driven by software. So it is not just one patient data we are looking at. It is the data which is generated from thousands of patients for each and every drug. Next slide, please. This is a bird's eye view about the pharmacology. Further differentiation between the medicinal product and that derivatives. It can be any new information, it can be a beneficial effect, or at the same time it can be change severity of already human that is involved, or change in the frequency or severity. So this is what is signal all about. So all the steps are driven by technology and software. So we'll go one by one. I'll basically touch on the ICSR safety databases. Then I'll touch on signal detection activity. Then the quality management system and learning management system. and then we'll also discuss about the future trend. Next slide, please. Yeah, next slide. Yeah. So how the software is helping us in our day-to-day endeavor in pharmacovigilance. So software help in getting the data from an unorganized form to an organized form. Okay. So you have an organized data. It makes it more easier to comprehend it, analyze it, identify any trends. Those are associated with it. Apart from that, data homogenization. So let's say I'm working in India. I'm taking some report pertaining to some drug, like let's say amlodipine. I'm preparing in a particular format. Okay. So same report about somebody else in some other country preparing some other format. So there is some data homogenization because preparing should be easily comprehensible to the other or maybe a different regulatory authority elsewhere. So we have this ICH guidelines, International Concept for Harmonization, and then we have different regulatory authorities. We have come together and said that okay, we need the data maybe in SLOMS format or XML format or we have MedWatch form. We have different other formats as well. Okay, so once the data is converted into those particular specific format, those are readable by a wider audience. So these databases are helping us with data homogenization, making the data more organized, and also they are helping us with data analysis. Okay. Next slide. Yeah. So we'll discuss about safety databases. The first step, the foundational element in the pharmacovigilance system is data, and individual patient data is called as ICSR, and this particular data will enter in the safety databases. We have a lot of commercially available databases in market. I think most of you would have heard about Argus, ArisG. We have Indian version DBH. We have Viva World Safety. We have Pepsico, which has recently come up in Finland. So there are a lot of data in the market. So apart from that, few of my data is reported with regulatory authorities. So there are checking guidelines. The single report need to be submitted to the regulatory authority within 15 or a non-serious report 30 days or 90 days. There are different guidelines set across different countries. Okay. So this particular software will help in doing that particular activity format as I have discussed, SIOMS or MedWatch format and etc. So yeah, so these are a few of the safety databases which are available in market. This is not a complete list. These are a few of the commonly used databases in the market. You can get just Google it. You will come across a lot of them which are commercially available. Next one. Yeah, so this is a very important slide. Can I have a pointer, please? This one.
Yes, sir.
Okay. So this is a screenshot of RS safety database. So if you look here, you have got different tabs. This particular is for different individual case safety report about one particular patient. Okay. So we have data segregated into different compartments. You have a general tab, you have a patient tab, you have a product tab, you have an event tab, analysis tab. What you are entering in general tab is basically the content details. When was the particular report received? What type of case it is? So whether it is this particular report is being received from a clinical trial or from a patient or a customer who is reporting it, or whether it is being received from a healthcare professional or whether it is received from a regulatory authority. So you classify all that. And one of the criteria for validity of ICSR is there to be an identified reporter. So you enter the reporter details in the particular section. So this is RMS. It is one of the commonly used databases, but there are lot many other databases which are available. So their compartment segregation might differ. It might not be same across the different databases. Any sir, whether you are genetics, MedWatch, that will remain the same. And if you look here, we have the patient tab. So screenshots. I did not want to bulk up the presentation. So you get across videos on YouTube, maybe 4 or 5 minutes videos with that. So you get a demo for what exactly we are doing. So in the patient tab, we are entering the patient details, medical conditions, and lab investigations. If it is a child case, the parent details would be entered. Familiar history would be entered. The age of the patient would be entered. So all this we have here. How the assessment what we do. Then we have the product details. What are the product details? What was the drug which was taken and have resulted in side effect? What was the indication it was used for? What was the dose? And finally, after evidence is selected, whether that particular drug was changed, the dose was decreased, what was the de-challenge results? All will go into this particular tab of product tab. And then we have an event tab. Okay. So in event, you enter the status of the event, whether it was a serious event or not. You try to determine the causality. There are different scales which are followed WHO causality assessment scale or a binary scale where we just mark the related or not related. And then we also check whether that particular side effect is expected as per the safety profile of the drug, what we call it as expectedness of Richard's. Okay. And then there is an analysis tab where we enter the narrative. We write in sequence, or we write in chronology what exactly happened. And then we also give a medical assessment comment determining the causality of the drug and the event. Okay. So if you look here, so this particular database is helping us to make the data more organized. There is ease of analysis when the data is segregated in this particular format. Okay, and then we have whatever is the missing information, we can follow up with the reporting patient and try to identify additional information which will help us in determining the causality. So causality assessment is also another fundamental element in the pharmacovigilance. Usually, without a proper causality assessment, you cannot clearly attribute a event or particular cause. So yeah, it is making the data more homogeneous. You have different tabs here, the icons here. If you click on that, probably you will get a report in a particular format. Next slide, please. Okay, so I have already told what is the signal. Okay, so signal is we try to identify at a macro level if there is any new layer which has been identified, or let's say any change in frequency of a particular drug. So if you are retina with 80 patients, 100 they get it, but see like whatever so we try to understand campaigns. So how was the report which is being done for one? What was the important sequence for that particular for the preceding year or report? So we try to identify that by using these particular response signal. Next slide, please. So there is one software by name Empirica, which is commonly used in signal detection. So we discussed that we are trying to check for the changing frequencies, or we are trying to identify any new side effect which is occurring with a greater frequency. So when it's that, there has to be some statistical analysis which so there is some statistical analysis which goes into determining this. So we need to do the size for it, and there are a lot of tests. I mean, to be honest, I'm not aware about all that, but this is determining whether there is an increase in frequency of that particular side effect or not, or whether on a hindsight if that particular side effect is reducing or not. So similarly, if you would have seen the FMVC or an RSI of any particular drug, you would have the title. It is a common side effect or an uncommon side effect or a real side effect. So the signal detection activity will be helpful in determining that. Apart from the side effect, if you are getting not expected for the benefit, we will be adding into the next slide, please. Yeah, so the quality management system is something which is very important. So you have the pharmacovigilance, you are doing it regularly, but are you doing it in a right way or the right time? Following guidelines. At the same time, are you qualified enough to do that particular activity? Is all quality management system. So now we have devices, QMS and LMS. LMS is learning management system. These two are different names now. They are like they come in the same software. We are using one software. Next slide, please. We are using one software by name ZenQMS. So it has a QMS and a LMS actually, which is inherently good. So the declaration of requirements. You are trying to check whether a particular SOP is being followed or not. Okay, you have to audit the trainings which you have carried on, or if there is a deviation from the usual process, you enter that into the quality management system software. And this software is having all these due dates and completion date for the CAPA action, corrective action, or preventive action which you will be doing. So that would help us. And then one question in that navigate the eyes. So why don't you do it navigate? So we have the regulatory instructions. So that time we have to what from the already then you have for example you have person highlighted particular like let's say so and so person has logged into the LMS, completed this particular training over a span of 1 hour. So you have these details entered, right? 1 hour training or 45-minute training. If you don't manage attendance sheet, you never know whether it's 5 minutes for one attending. So all this training, the advent of technology, skills are taken care of. I know it is not entirely going to, but it's so impactful. Next slide, please. Yeah. So, what qualifications that a software must possess? So it needs to be, there should be data protection. Okay, it should be compliant to GDPR. Personal data should not be released outside. Some of our earlier speakers also had highlighted on personal data being misused. So personal data is very important. It should not be leaked outside. And in EU, US, and a lot of other countries, we have very stringent rules for that. So, but any software which we are using, it should be compliant to GDPR guidelines. It should be compliant with all of the years, and any other law which is important from the data privacy perspective. Apart from that, I already spoke about audit rights. 21 CFR Part 11 ensures that it ensures the integrity and security of electronic records and signatures, and it is again mandated by FDA. But when we are calling for FDA, we have this that is widely acceptable by regulatory authorities as well. And then software validation is very important. Any software you use, it needs to be validated. So like let's say I'm working on a particular database, I try to take the validation of that particular database about a particular let's say I'm looking over a period of last 6 months. So now it should not throw up a different result altogether only for the second time. Or there might be chances that it might not show that particular drug account already have this data in the system. So system needs to be this requirement for any student to qualify and using so there should be an undergrad, there should be an availability of results. Very point of time, there should be very so what is next? I think we have touched base on artificial intelligence. There is a lot of artificial intelligence, which is being incorporated into pharmacological system now. I have worked on some of our customers who had, AI-enabled tools with tightly connected to PubMed. That particular software automatically analyzes the abstract, for a particular thing for a particular, and it is the other result. Regardless of anything, it has been particular. So this is the level of AI is coming to me. There is a result of 17 in 1990. So now you have softwares. And to take it to the next level, this particular tools which we have in market, AI-enabled tool, after analyzing the data, literature data, they throw out a report in an XML format or into the format, which can be easily uploaded into the safety data. So with that, lot of standard work which is going in, so that has gone down. So I told you originally when I told that we are Congress over last 12 to 15 years. But many universities it is going to be extraordinarily revolutionary. So yeah, there are different places where AI can be, in fact, everything can be use of AI to make the work easy, whether it is case management, whether it is workflow assignment or data surveillance, things like this. Yeah, obviously there it comes into play when you do a complex data analysis. So to take you back, I was speaking about the signal detection activity. So we have these tools which do signal detection activity. So they're so advanced now. They show up specific trends. Okay, these are age specific trends. These are the side effects which are occurring in young population, or maybe these are the side effects which are occurring in geriatric population. So it has technologies come back. Regarding the marginal data which you have in the tree analysis. Okay. So obviously, there is a scope for a good amount of automation at each and every workflow, whether it is network monitoring, workflow management, regulatory intelligence, regulatory reporting activities, signal management. So obviously, to ensure a greater amount of patient safety and better health outcome results. Yeah. So that was the end of my presentation. So the take-home message for the undergraduates and the postgraduates is, we ended up in this particular science field because we share technology. We are not that academic. That was good for me. So at this stage, you need to technological involved, need to be technological involved to make progress. That is the job. So I would keep it open for any questions. Yes, please.
How to leverage social media for security?
Yeah. Yeah. So social media, we have individual, patient reporting. So we know our companies who have standard operating procedures, which are in place for identifying side effects on social media. So they have a specific way which try to identify their particular branding. Like let's say it is getting reported on Twitter, or if it is getting reported in Facebook, or it is getting seen lot of people putting the side effect which they are observing LinkedIn also. So that particular data is taken up, it is put it into the safety database, IPSR what we call it. Then whatever is the missing information, the parent try to reach out to the relevant stakeholder, whoever has posted, to find out about the missing information.
Can it be done at individual level?
Yeah, I mean that is the follow-ups which we perform are at individual level. Like let's say a particular patient is dialing in the company toll-free number and saying that I have experienced one key side effect. You think the reason I have medical information concentrated team. You think what information is important. It goes to the medical team stakeholder. Okay, like let's register questions. You should have the discipline for it. The other
access the Pro and all
yeah, so that is again at a regulatory level. But what I have spoken about is more in context of pharma companies.
Question.
Again, the same point I would say. Visitro, it is like a regulatory again body. So these are company specific databases. And others can be used by company A, B, C, D for different products, not just for one specific product. A company portfolio by technology. So they would use it for other, the company, specific portfolio information into these workplace and everything.
Check trial is separate and the hospital based is separate.
Yeah, hospital is separate. It's about this. Okay.
But you did mention about this software for regulatory submission.
Yes. So, like let's say US FDA, it recommends that from if you want any serious unexpected side effect, it needs to be reported to the regulatory authority within 15 days. So we have a gateway which is created between the database to the FDA side. So that will help in transmission of the information to US FDA or for that matter EMA or MSH.
So what do you see with the future of PV with the AI coming up?
Yeah, as I said, more precise trends can be noted. So as I said, it was more unorganized way back. Now it is more organized. Okay. So this database helps in activating, like let's say signal activity. So it will give you demographic specific things. It will give you demographic things. So let's say this implies those. Come out to utilize AI in assessing the in pharmacovigilance system.
It's present will be online. Regulation.
So thank you so much.
Thank you, sir, for a wonderful interactive session. Next, I'm going to introduce new professor, Dr. Mahesh Karan. He is the Vice President and Head Medical Service, Pharmacovigilance and New Product Development Center, Pharmaceutical. Sir has graduated from Mumbai, before initially from Mumbai, has more than 16 years experience in academic clinical trials, medical marketing, clinical and MPD, has more than 6 months publication, one article, review and case report, and sir has conducted more than 16 clinical trials, phase 3 and phase 4 trial, conducted more than PM studies, active and observatory. So the pleasure to introduce him. All right.
Before that, we would like to honor our judge, Dr. Baswanda. I request all of you to put your hands together for Dr. Baswanda, because he has been promoted as the principal of Mysore Medical College recently. And he is also been serving our Medical Pharmacology Society as a office bearer. And it is all the more, it is more important for us to study and appreciate more, achieve to get into the next level, that is director. So, but this is really nice for us to have him as the, he himself personally has come here and helped us to get this papers now. But at the same time, he's been serving for the association, and he hosted some of these programs in this institution also, and he will be hosting in future also. And we will be doing a bigger program in the future in your presence, sir. Thank you so much, sir. Please honor him, sir. Sir, please. Prakash sir is our office bearer.
Can you have the speakers also, if you don't mind? Any strong speakers for this session? It's one.
He is connected, sir.
Yeah, I'm connected. I'm connected.
How is that develop this one?
Is there online? You have it presentation? Okay. Dr. Mahesh, can you start presenting? You can do your desktop sharing. So we will end the sharing. Yeah, we will end. Please end this. Okay. So now, please, open the presentation. Okay. You opened? Hello, Dr. Mahesh. Okay. So
yeah, I have opened. Can you see the presentation?
Yes, we can see. Hello, can you hear me?
Yeah.
What I suggest you.
I can hear you.
What I suggest you first end the presentation.
Okay.
Okay, now it is fine. Please go ahead. What I suggest you again, you repeat the same what you did now, just now. You you share the screen. Please share the screen and then open the PPT.
Yes, yes.
Okay,
All right.
please do.
All right.
Okay.
I'm doing. Yeah. All right.
Okay.
So is my screen visible now? In full screen?
Yes, sir. Yes, sir. It is perfectly all right. Can you hear me? Is it mic on?
Perfect.
Oh, you are able to hear us?
Yeah, yeah.
Thank you.
Yeah. We loud and clear. Yeah. So, hi, good afternoon. Namaste. At the outset, I would like to thank the organizers of MPSCON 2024, especially Dr. Shivamurthy, for inviting me to speak on the topic, which is very close to my heart, that is post-marketing surveillance studies and risk mitigation strategies. This topic is very vast, and I could speak on this topic for hours together. But as I have 25 minutes, I will try my best to discuss it in brief, so that you will get a fair bit of an idea about
Hello?
both these topics.
Hello. Sorry, Dr.
Hello?
Mayuresh. Dr. Mayuresh, we are not able to see your presentation. Can you stop the sharing of the? Okay.
Yeah,
So
I
what
have
you do now?
stopped.
Okay. Now you click on the share button. You clicked. Hello.
Hello. Yeah.
Once you click on the share button, select the screen. Select the
Yeah.
screen, and then click on the share.
Right.
Okay, and then okay, then you are able to open the. You can open the PPT. Now you go for the
Right.
show
Yeah,
slideshow.
I have. Yeah, I have clicked. Yeah,
Click
I
on.
clicked on slideshow.
Yes, now it is perfectly all right.
Right. Perfect. Right. Right. So this is the outline of my topic for discussion today. I first discuss about PMS. I will discuss the introduction to PMS, benefits of PMS, sources and types of PMS, and data sources of PMS. Then I will move to the second topic, which is risk management strategies. I will introduce what is risk management, need for risk management strategies, risk minimizational measures or RMM, overview of risk management plans, strategies by regulatory bodies, and then I will discuss about the advantages, and then finally I will close with a summary of my topic. Now, when we talk about drug development process, we start with in vitro studies. Then we go to animal studies, also called as preclinical studies. Then we move to clinical studies, starting with phase 0 or proof of concept studies, phase 1 studies, phase 2 studies, and then phase 3 studies. After phase 3 studies, marketing up is what is sought from the regulatory authorities. And once the marketing approval is given, you have the post-marketing surveillance studies that they start. So what happens to the drug after the approval and when the drug is available in the market comes under the purview of post-marketing surveillance studies. It involves ongoing monitoring of drug safety and effectiveness post-approval. The primary purpose, the main purpose is to identify the unrecognized adverse, that is the negative as well as the positive effects in the general population. So both the negative as well as positive effects are identified here in the post-marketing surveillance studies. If I have to give an example of a negative effect, that is an adverse effect, very recently levofloxacin, there is a for Stevens-Johnson syndrome. This was detected through post-marketing surveillance. And if I have to talk about the positive effects, GLP-1 analogs and extension of indication to weight reduction was also because of post-marketing surveillance, and use of minoxidil as a hair revitalizer in alopecia patients, it was also because of post-marketing surveillance. The other essential components include monitoring off-label drug use, issues with orphan drugs, because orphan drugs many a times do not pass through the regular phases of clinical trials for its approval. So it is better that we have a post-marketing surveillance wherein the safety as well as efficacy issues can be addressed for orphan drugs. Challenges which are associated, especially in special population, pediatric, geriatric, liver failure patients, or kidney failure patients can also be addressed through post-marketing surveillance studies. Post-marketing surveillance studies ensures continued safety, efficacy, and risk management in larger patient populations. Now, when we have to talk about evolution of post-marketing surveillance, we always start with 1960s thalidomide tragedy, where severe birth defects were exposed in patients taking thalidomide. Then subsequently, Senator Kennedy advocated for a better system to oversee prescription drugs once they were approved for the market use. In 1976, the Joint Commission was formed, in which it was decided that the need of the hour is to monitor drugs after they are in the market for safety as well as efficacy, aiming to identify and understand expected as well as unexpected side effects. After this, the process of PMS was very slow, and lot adverse events were what were highlighted. But in today's era, if I have to talk about the PMS is quite well robust, established system, and a lot of adverse events as well as efficacy related matters are also being addressed through the PMS studies. Now, what is the need to conduct PMS studies? We all know that the pre-marketing studies, that is phase 1, phase 2, and phase 3 clinical trials, are conducted in a controlled environment. And they are often inadequate in detecting rare adverse events because of the limited participant numbers. Some ADRs may be observed in a rate of 1 in 10,000 or even more. So they may be missed in the pre-marketing trials. And that is what is very important, because they may be detected in the post-marketing trials. Follow-ups are essential to detect ADRs from long-term or intermittent drug use. Shortcomings of the pre-marketing trials highlight the need of continuous post-approval studies. Now, this is what is the evidence-based pyramid. From top to bottom, the evidence decreases. So top of the pyramid is what is meta-analysis, which has got the best evidence. This is followed by systematic reviews. Then you have the randomized controlled trials. Then you have the non-randomized controlled trials, which includes post-marketing surveillance studies also, and real-world evidence studies, where this is what we are going to discuss today. This is followed by cohort study, case control studies, case reports, expert opinion, animal studies, and last you have in vitro studies, which have very limited evidence. Now, as I have said, the primary benefits of post-marketing studies is to recognize the missed positive as well as the negative effects of the drugs. Apart from that, what are the other benefits of PMS studies? Many of the PMS studies are trends of the incidence and prevalence of the disease also. You have long-term safety monitoring, which is also there, identifying the rare and long-term adverse events which were missed in the earlier trials. Efficacy in real-world setting, as I was saying, that the pre-approval studies are conducted in controlled trial environment or controlled trial conditions, and PMS studies are normally conducted in real settings. So you have better way to assess the efficacy and safety of a drug. Many a times drug-drug interactions are missed in pre-approval studies. And as the patient population is quite huge here, and the patient population is also very diverse, you have or you can study drug-drug interactions better in PMS studies. Especially in a special population group, dose optimization can also be fine-tuned in PMS studies. So older people, low weight patients, patients who are pediatric patients, or maybe patients who with some organ problems, can also dose optimization can also happen in these patients. Support for new indications, as I was saying, efficacy of the drug is tested here extensively along with safety, so you can go beyond the original approved indication. Mortality and morbidity studies, yes, these are long-term studies. You can assess the morbidity as well as mortality in PMS these studies, many of these studies are maybe 3 years, 5 years. So you can draw a Kaplan-Meier's curve and you can see the mortality and morbidity in PMS studies. So if I have to give an example, I have morbidity studies with linagliptin and its association with decreasing EGFR in kidney disease patients. And you have mortality studies like sacubitril valsartan very recently had decreased mortality in patients with heart failure. Now, when we have to talk about the types of PMS, we always start with the phase 4 clinical trials. So after phase 3 clinical trials and approval of the drug, you have to go and do the phase 4 clinical trials. So phase 4 clinical trials are the best types of PMS studies. This is followed by active PMS. This is followed by spontaneous reporting systems. This is followed by observational PMS studies, which is further classified into patient registries, cohort studies, and case control studies. And then finally, you have the PSURs, or the periodic safety update report, and post-marketing surveillance done through it. Discussing one by one, what are phase 4 clinical trials? Phase 4 clinical trials are conducted post-approval of the drug, and they are conducted with a proper protocol. There is inclusion and exclusion criteria which is well defined. The objectives are set before the trial itself, along with the efficacy and safety testing parameters. You have to take regulatory approvals. Ethical committee approvals are also mandatory, and protection of patients' right, safety, as well as well-being of the patient is what is going to be ensured in phase 4 clinical trials. Many a times these studies are single-arm, non-comparative studies, but sometimes the regulatory authorities may instruct you to do double-arm or triple-arm studies, wherein comparator arm is also present. Now, what are active PMS studies? These are conducted to monitor the drug performance in real-world setting. It aims to assess the drug use under approved conditions. So here, the study is going to be conducted only in the approved indication. Same is the case with phase 4 studies. Phase 4 studies are also done in approved indication, but here you are allowed to go beyond the approved indication also, but it should not be completely different indication. So in case, for example, if there is a drug where you are going to be studying its role on skin, okay, you can go to subcutaneous tissue also in phase 4 studies. This is not allowed in an active PMS study. Studies are carried out under a protocol which is approved by the regulatory authorities. Inclusion and exclusion criteria is well defined here and is based on the recommended use specified as per the prescribing information and approved pack insert. So if I have to see the first 4 points in the active PMS, you may say that what is the difference between a phase 4 study and an active PMS study? Phase 4 studies, yes, you are allowed to go beyond the indication a little bit, but active PMS studies, you have to stick with the prescribing information and the approved indication. But apart from that, what is the difference? Active PMS studies are always and always single arm studies, and there is no comparator arm which is there in these active PMS studies. The drug is a part of patient's treatment according to the prescriber's judgment and the protocol. So the investigator, who is the prescriber of the drug, as per his knowledge, this is what is the patient's treatment. And he's just prescribing the patient's treatment, and he's noting the parameters of observation for safety and efficacy. That is what is an active PMS. It is different from clinical trials because the drug is already approved for marketing for the same indication, and the standard clinical trial regulations and guidelines do not apply. When I say this, it does not mean that you don't have to take regulatory approvals. You have to take regulatory approvals here also. You have to go to ethical committee and you have to take ethical committee approvals. You have to take patients' informed consent, and you have to follow the procedure. But apart from that, a lot of other regulatory hassles can be avoided in active PMS studies. Spontaneous reporting systems, or SRS, basically was advocated after the 1960s thalidomide tragedy. This is spontaneous reporting of adverse drug reactions by the healthcare professionals, whether it is doctors, nurses, patients, or patients' caregivers. And many a times you can build the safety systems based on the spontaneous reporting done by the healthcare professionals, patients, and these caregivers. Examples is capmatinib, which is for non-small cell lung cancer. This is a drug which has a safety concern of raising the liver parameters and causing liver toxicity. This was detected in continuous reporting systems. Now coming to observational PMS studies, which is further subclassified into patient registries. Patient registries are the case papers which are entered by the healthcare professionals, and these are maintained either by the doctors, either by the clinics, or by the hospitals. You can go and you can retrieve these case papers and patient registries, and you can analyze them and see whether there were any efficacy or safety related issues with the drug. And as here actively patients are not enrolled, this is a classical example of observational study. Coming to the second type of observational study, which is cohort study. Cohort studies are observational studies which are done in a cohort or a group of individuals sharing the same characteristics. In this, you have arms. The first arm is here you don't have any arms, unlike case control studies. Cohort studies can measure incidence rates, which is very, very important. But one of the limitations of cohort studies is that you require a lot of patients. And this makes these cohort studies expensive, and logistically it is challenging to perform. Very important cohort study was the use of gastroprotective agents and ulcer patients using dabigatran, and they had a risk of having gastrointestinal bleeding, which was detected through a cohort study. So there was a cohort which was patients using dabigatran and had the peptic ulcers, and they had gastrointestinal bleeding. And the other control was patients using dabigatran and with peptic ulcers who did not have gastrointestinal bleeding. The third type of observational study is a case control study. Case control study are widely used observational studies investigating factors are linked to the disease or outcome. Here you have two groups. The first group is of cases, that is individuals with outcome of interest, and then the researcher also tries to construct a second group of individuals called as controls, which is similar to the cases, but here you don't have the favorable outcome of interest. These are comparable studies, and that is the reason why these studies could be helpful in detecting some of the rare adverse events, especially the ones example is thromboembolism risk, which was associated with oral contraceptives, which was detected through a case control study. Now, PSURs are the periodic safety update reports, which are submitted to the regulatory authorities for the first 2 years every 6 months after the approval, and subsequently for the 2 years annually. And there are a lot of safety related information which is present in the PSURs, and this can be analyzed, and surveillance can be made through these PSURs also. If I have to talk about the examples of PMS and what did it cause, there are positive outcomes as well as negative outcomes. Negative outcomes are the ones where the risks are identified, and positive outcomes are where the risks may be negated. Here, the negative outcome of one of these trials was anti-HIV drugs, protease inhibitors, increases the risk of myocardial infarction by 4 times in HIV patients, is an example of where the risk was identified and was, it was positively identified. And the other one was where the risk was negated. That is the 2 vaccines, that is rotaviral vaccine as well as the typhoid tetanus toxoid conjugate vaccine, wherein fever was observed in nearly about 80% of the patients. But fever was the only adverse event which was there. Apart from that, there was no other adverse event which was there, and these adverse events can be easily managed. And the benefits of this was outweighing the risk, and that is the reason why these vaccines are still used. Now, what are the other data sources for PMS studies? Literature reviews, media, whether it is print media or social media, other observational studies by other authors, patient registries, and unsolicited reports via customer complaints. Now, if I have to conclude the PMS as a topic, it ensures ongoing safety, it identifies emerging issues, evaluates real-world usage of the drug, it protects patients' health, and updates risk management. So this basically is a good transition for risk management strategies or risk mitigation strategies. Before we go to risk mitigation and risk management, we will see what is drug safety. Drug safety is defined as science and activities related to detection, evaluation, understanding, and prevention of adverse reactions to medicines. Now, what is a risk and how is it different from safety? Risk is a potential for an action or an event to cause harm. It is assessed by its probability, severity, and duration, and classifies as mild, moderate, and severe. Now, what is risk management? Risk management is process of measuring or assessing risk and developing strategies to manage it. So if I have to simplify and give you an example here, many a times we suffer from cold or respiratory infections. What is the treatment we take? We take an anti-cold which contains paracetamol. We take antibiotics. And then along with that, we also take a pantoprazole or maybe a rabeprazole. Why do we take that? We take that because we feel that we will have an adverse effect, that is acidity or hyperacidity, which is because of the antibiotic and maybe because of the NSAID which we are taking. So what we are basically doing here is we are identifying the risk and we are managing the risk preemptively, thinking that we should not suffer from hyperacidity. That is what is risk mitigation strategy, if I have to put it in an example. So if I have to go and discuss it further, what is risk management? Basically, no medicine is without risk. But along with the risk, you have benefits. And always remember the benefits should outweigh the risk. The balance between the benefits and risk should be effectively considered and must not be left to chance. Failing to manage the risk may lead to crisis situations which may be harmful to the patient. Now, what is risk management? It is a process to improve patient safety by assessing risk of medicinal product and devising interventions to reduce or mitigate such risks while maximizing the benefits. They are sometimes called as risk minimizational interventions or risk minimizational measures, that is RMIs or RMMs respective. Now, how do you go about it? First, you have to identify the risk, that this is what is going to, or this is what may happen. Then you have to evaluate the potential of the risk, that okay, if this happens, then how severe it could be, how frequent it could be. And then you have to devise a strategy to minimize, mitigate, and manage this risk. Now, what does a risk mitigation strategy or risk management strategy include? All the existing and missing information which is there for safety, it has to include that. It has to include measures to prevent any risk associated with the medicines and evaluation of effectiveness of these measures. So if you are using a measure to prevent that risk, whether that measure is really effective or not. Who will prepare it? The one who is the marketing authorization holder. And when to start preparing it? Firstly, at the time of making the new drug application after phase 3 studies, because you have the data of phase 1, phase 2, and phase 3 studies. So you can very well do it at that point of time, or upon identification of a significant safety concern, or when your health authorities or regulatory authorities may demand from you. Now, what is the iterative process for risk management planning? You have two steps here. One is the pharmacovigilance planning, and second one is the minimizational planning. So if I have to discuss both these one by one, pharmacovigilance planning or pharmacovigilance activities, the routinely involved pharmacovigilance activities are collecting information about the adverse drug reactions, and additionally, you can also design some post-marketing surveillance studies or post-marketing clinical trials or early post-marketing phase vigilances in the pharmacovigilance activities. Which are mentioned here, and additionally you can have the information which is related to the pharmacovigilance activities which you have undertaken along with along with this information to minimize the risk. So now if we have to go by the regulatory bodies one by one, the most robust regulatory body as far as the risk mitigation strategies and risk management strategies is concerned is the EMA. And I'm very happy to tell you that even the Indian regulatory authority, that is CDSCO, and the PVPI guidelines are also based on the EMA's guidelines. If we have to talk about the risk management plan for EMA, companies are required to submit an RMP to EMA when you are applying for marketing authorization. It is required for all new drugs and biologics. And the RMP is composed here of 3 core elements. Number 1 is safety specifications. Number 2 is PV plan. And number 3 is risk minimizational plan. We will discuss one by one what is safety specification. Safety specification basically identifies 3 types of risks. One is the identified risk, wherein the causal relationship with the medicinal product and adverse drug reaction is well established. Then you have the potential risk, where the causal relationship between the drug and the adverse event, there is a possibility. And you have the missing information, wherein you are not very sure about the causal relationship here. Now coming to PV plan basically outlines the activities which are aimed. Yeah.
Can we like how long you would like to take?
I will just take 2 more minutes.
Thank you so much.
2 more minutes, sir.
Thank you so much.
So routine activities of PV plan are basically adverse drug reporting and signal detection along with questionnaires, and you have additional PV activities like conducting studies. Then you have the risk minimizational plan, where you have routinely, you can perform a test before the start of the treatment. You can monitor the parameters during the treatment. You can monitor special signs and symptoms. You can adjust the dose. You can perform a washout procedure after the treatment interruption, provide contraception recommendations, prohibiting use of medicines while taking the product. And additionally, you can also have direct healthcare professional communications, wherein you can have leaflets which are circulated to patients and healthcare providers. US FDA is very, very simple. They just have REMS, or risk evaluation mitigation strategies, which are submitted to the regulatory authority pre-approval as well as post-approval. This is not as complicated as the EMA. And who may perform these REMS? It is FDA, drug manufacturer, REMS administrator, healthcare providers, patients, pharmacies, and other stakeholders. CDSCOs ask for risk management plans with an objective to identify, characterize the safety profile of the pharmaceutical products. This is submitted along with the PSURs and at the time of the new drug application. It outlines the methods to further characterize the safety profile, documents the risk prevention measures, and assesses their effectiveness, documents post-marketing obligations, tied marketing authorization. And this is the template as per the Indian regulatory authorities to submit the RMP. This is identifying the risks and devising the risk mitigation strategies pre-approval. This is done in phase 1, phase 2, and phase 3 clinical trials. This is beyond our today's talk, so that is the reason why I will skip it. And this is the risk identification in clinical trials, phase 1, phase 2, and phase 3, and these are the responsible persons who can do it. So this is one of the examples of opioid risk mitigation strategy in chronic non-cancer pain patients who were on opioids, and they were advised for palliative pain physician care. And very important, the conclusion is risk management or mitigation strategies are crucial to improve patient safety and mitigating the potential risks which are associated with drug. To conclude, risk mitigation strategies, key points, benefit and risk balance is what needs to be maintained. At the same time, the risks have also to be managed. It also is responsible for rational medicinal use. Patient trust is also improved because the patient's confidence is improved because you are also telling the patient that you will have this adverse event and this is how you will take care of it. And this is a collaborative effect of government stakeholders, and everybody should unite basically for this. So thank you very much, and I would be happy to take any questions.
So as we are nearing to the end of the session, it's time to acknowledge the chairperson, co-chairperson speakers who shared their knowledge with us today. So I request Dr. Shivamurthy sir to give mementos to chairperson and co-chairperson. I request Sriram Kalsa sir and Prakash to come to the stage and give a memento. To present memento to our speaker, request chairperson and co-chairperson sir to come and give this to the speaker. I request Dr. Vidyasagar sir to come to the stage to give a moment. I'd like to call upon Dr. Shruti Chandravan to come forward and give a moment. I'd like to call upon Dr. Kane sir to come and give a moment. To invite Dr. Mohan Davula sir to come and give a moment. Thank you so much, sir. So as we conclude today's session, I want to extend my heartfelt thanks to each of you for your active participation and insightful contribution. So we have an exciting agenda planned for tomorrow. And let us reconvene tomorrow morning at 8 a.m. and have a great evening. Thank you all.
So,